Perfect. Yeah. Oh, thank you. So cute.
Just
Yeah. That's it. That's it. We're gonna need to do this. So she's taking that wrong. So. She responds. It wasn't for a while. And how she has. She asked me. She's asking me, okay, so we were in the city text her and said, or she texted City and said, someone has a problem with me. I'm so much later. We're all adults. She's talking about what they're I'm also valid, but you know, that's still valid. That's maybe not the truth. They get into it, doctors are long. Dawn is aware of Justin does Justin is now yeah, everybody just had this. And thank God, because this is what I was going to do. Well, I mean, I would say it, but I'm glad that it like the job with yes. Say it to me, and if I had them there, it should probably be done. Yeah, perfect. Yeah. I know the IR techs are coming, and I think Jen and Mike are version of that. Okay.
For video, we're not gonna be able to send them anything, I'm just gonna keep the camera off.
To show like these.
Yeah, so like whoever's talking is gonna.
Oh, yeah, I'm sorry, yeah, I'll let them.
Yeah.
I'll let them, you will be on.
Yeah.
Check. Hey, if you're there, can you promote me to panelist so that I can turn on my video feeds for Baptist Convention 1 and 2?
Oh, here. And I started with
She's at PMDA
Uh-huh.
or radiation oncology.
She's still over there. I was, well, like I said, you know, it's not her business. The pitch up, anybody, you know.
I'm stuck to south now. Oh, okay.
I hear. And the calls.
Oh, okay.
Yeah.
My God. You see, I'm like, her all the same. Oh, that's right. I'm 6 hours. This ass was really on it. Stop by. Didn't ask her today. She's a bad. I think she has a UCI. So I took her. And she has accidents, urine smells awful, and I took her, and had her checked out and turned it in, we weighed, and it was negative, but it smelled awful. And they want a sample. And so I spent $250 to pay for that. You know, I got to pay for that. And you gotta pay for the sample. Your sample is about $150. And it's negative. But we're not to find that shit. Never. Like, yeah, I'm gonna look to see whether or not they can receive like cranberry candy or something. Smell. Yeah, so. My husband. Frustrating.
Testing. Well,
You're not gonna hear, you shouldn't hear this thing, so. You should, excuse me, just like you're talking to the people.
Dorothy. How are you? I cut it. Cut it and colored it. How are you?
You dug about your legs.
Yeah. Yeah, I saw it. I had Sheila.
Testing. Two, can hear me in room. Testing, and can hear you talk to us, please. Do you see your body coming from Timothy?
Yeah, we trying to find out. Oh, yeah.
Can you guys hear me? This is John. I'd like to do a sound check from the podium if possible.
Can you hear this through there now? We need to figure out the sin really. Just an idea, Chad. Good morning.
Yeah, I absolutely came down with.
Yeah.
Beautiful day, today is raining. My mom and dad have one for seeing everybody online. Yesterday it was so like, because I don't see anybody.
I know.
It's like.
I'm gonna relocate down here because she's got a, okay, my laptop, I got a monitor mic in there.
I'll move over.
No, that's fine.
But yeah, I am system, you know, quality nurse and stroke and, neurosurgery, general surgery and psychiatry. Those are my services. So have any concerns or whatever, you know, give me a call. Yep, got any questions, let me know. It was good seeing you again. Laptops don't.
Testing. All right, you hear this through there, nice and clear, all right, cool. Can you talk to us so we can hear you? Hey, John, can you hear us? I see the bar on here going, so you should be. Hello, everyone in the room, sorry. Thanks for bearing with us. We're doing an audio check for the stream. So just disregard everything going on, but, okay, thank you. Hope everyone's having a good morning.
Yeah, Chris. Yeah, Chris. Hello? Hello, Chris?
Testing some more.
You asked me about, okay.
You sign in and your license number. Sign in sheet. Okay. Yeah, I remember your. Okay. They'll put it in the corners now. Done.
So just gonna keep doing the breakfast and then the audio check. Good morning, good morning. Let's take 1, 2. You see audio levels on the Zoom, hopefully people get that. All right. All right, John, there's your voting check.
I'll sit over there.
Yeah, no, I just. That's okay. I'm doing the, I paid for the station. Oh, yeah, that's, just doing all the time. Started a. It's an integrated.
Oh, probably. Yeah, that happens.
Yeah, it was great. He did go. That's great. It's like a old home. Young home, I like that.
You're both perfect. Even better.
Hello, everyone. We will begin in about 5 minutes at 8 o'clock. If you can hear this, get ready.
Oh.
Guys, it should be right because I'm gonna be drinking on the case here. Have a seat, grab a microphone.
No, I,
Did you see my little computer there?
You're not, plug it in. The experience should go black. To the back of it. I got you. Are you getting audio?
No, sorry.
Perfect.
Hope you guys like my loud music. Good morning, everybody. Family business. We had a little change. I know Chris, I think, announced that already. Dr. Foy had an issue, could not be here for the first talk, so we're starting 15 minutes later. And I want to be respectful to Dr. Johanna Frozen that is presenting from Finland next, and he sent us a recorded talk. He could not come here, but it's very exciting things to share with us. So I want to be respectful of his time and make sure we're on time for him. So I'm just gonna, we had at 11:15, there was a block for a case discussion. So that's happening right now. So good morning, everybody. Welcome. We know who you are. Thank you for your support. As I said yesterday, some of you were not here. Again, we can only do what we do because of the teamwork that we have. I owe a lot of gratitude to each and every single one of you in this room for empowering us to do what we do at Baptist. And for those that are not Baptist, we know you do the same at home. So thank you for being here. So I'm going to share a couple of cases here. I saw Dr. Nima coming. So he is the most senior interventionist that can be pimped.
First of all, I was called the most senior in my life.
You are getting old too. I'm not alone. But I told Monsi, Otavio, and Sal that you get ready because I'll put them on the spot. So this is a 50-year-old, my age group type of person that came to us. Her sister had an aneurysm, and she come to us because she cannot see on her left eye. And then her primary care physician ordered this MRI, and we see this. The title of the talk is Complex Brain Aneurysm Management, guys. So what we're seeing here on the screen. Otavio, since you're first to the left.
I'm seeing right now.
Do we have a microphone, guys, so and whoever is streaming can hear us? Here we go. Thank you.
Hi, good morning. I'm seeing right now is the MRI with what looks like a cystic formation in, well, it's too low to be frontal, so I'm seeing two cystic formation there in MRI.
Okay. What can look like a cyst that's round and may pulsate?
So it's aneurysm is a possible diagnosis in that case.
Yeah. So I'm torturing you. I know it's but again, so an MRI like this, right? We call this a flow void, right? Because if it's a cyst, probably would be a color of this the fluid, right? There's a T2 sequence, right? I thought Dr. Sherman, did you go to get coffee this year? I was going to ask Dr. Sherman to describe in radiology terms. We'll get that for next. So naturally, it's unfair. You're seeing one picture ahead, thousands of pictures or hundreds of pictures of an MRI. she had two, large brain aneurysms. So we offer her to undergo an angiogram, and that's what we see. She has a pretty large, giant aneurysm on her left carotid ophthalmic segment, and then she has a 22 millimeter, almost giant on the carotid terminus. Dr. Neiman, she's in your office.
Thank you. How old?
50-ish.
And was it symptomatic?
She's blind in her left eye.
So when, we deal with aneurysm, the first question is treat or not to treat. Obviously, this one being symptomatic and the size and shape and everything, definitely treat.
Okay, how do you want to treat her?
So, open surgery always an option. Here, it doesn't look like, a good option. I would ask, you describe if anything that can be done open. I think in the vascular route, flow diversion would be a good option. The MCA, I have to see a different view, just the branches.
So this is a 3D for you, some selected shots of the. It's
Yeah.
it's a carotid terminus.
Yeah, I think the carotid terminus, flow diversion would be an option.
Any concern that you have for this aneurysm 30? I cannot read that.
Yeah,
My glass up here.
the problem is, post-inflammatory process. And, that can cause problem or rupture. So perhaps oil and, flow diversion, oil would be maybe some protection. It's a giant aneurysm, right? So the natural history is very bad. The treatment also has high risk of morbidity and mortality.
That's exactly what I thought in this case I present when I give my talk about how to strategize when we use flow diverters for giant intracranial aneurysms. We know, and we're one of the first to point this out, and we studied this deeply with a bunch of different studies with Stryker, Surpass, and especially with Medtronic pipeline. That when you have a giant aneurysm, we call giant aneurysm, guys, anything that is greater than 25 millimeters by far a rare bird, thankfully, especially in the United States. We're doing a much better job in quit smoking. But when you go to countries like China, Brazil, Turkey, and people still smoke a lot, you see way more giant aneurysms because this is that has a relationship. And you're gonna see here, I don't want to steal his thunder, but you're gonna see a relationship between cigarettes and aneurysms, maybe through a different pathway that Dr. Frost is going to share with us in 9 minutes. But when we see a giant aneurysm, we know when we're treating this aneurysm with flow diverter, this aneurysm has about a 5 to 10% chance of bleeding after you put the flow diverter. We call that delayed aneurysm rupture. So first thing when I saw this lady, you guys can come in, don't be shy. I know you're not shy. What we don't want is for this aneurysm to bleed after. And if this happens, it's a tremendous problem because flow diverter, different than regular stent, the mesh is so tight that you cannot go through the mesh to put coil. So if it bleeds after, it's a big deal. So when I saw this lady, she failed a balloon test occlusion. So open surgery for her would be a high flow bypass. That is a big deal. High morbidity surgery for clipping of those two lesions. So I said, look, you have this other option that is probably not as good for your eyesight, but she was blind in that eye for about 5 months. That's how long it took for her to get the MRI related. So the chance of her recovering that eyesight was pretty low. So I said, look, we have this treatment that is minimally invasive, but you have this number that you have to be aware that you have a 5 to 10% chance of bleeding. I think we can decrease that by adding coils, and I think we can decrease. We just published a meta-analysis, a patient-specific analysis of these studies that we did with Medtronic pipeline, showing that coils and multiple flow diverters have a protective effect on that. So that's what we did for her. We got really lucky on her because I was worried about how to coil this first bubble and then coil the first bubble. I have a catheter here that allows me to put 2 microcatheters, but just 2 microcatheters, not 3, because ideally I want to have 1 catheter for coiling on the distal bubble, 1 catheter for coiling. So I couldn't do that. So I said, look, I'm gonna coil, so I'm gonna pipe and then coil that, and I'm gonna keep the pipe partially closed, and then I'll resheath it and I'll go coil the pipe, jump out of the catheter. So I lock myself out of the giant guy here. So it's a bit hair raising. So this is the catheter on the first one. Got really lucky when I pulled the catheter back from this one because of the size of this end. I was just able to push that there. But I almost locked myself out of that. So I was able to push the catheter there, and then again, just a technical detail. I like to go really deep with the microcatheter on that, so I don't risk losing access on that. And then put a second pipe and just coil. She did great. Her vision didn't turn a hair. Unfortunately, she did not get better. She didn't get worse. With this size aneurysm, you can push on the nerve on the other side, and she is 5 years from her treatment. She's doing great. Very happy, and her whole family was part of this study that we're going to talk more a little bit later. I'll show you one more here and then we'll stop. I think we can show this in 5 minutes. Another complex one. This lady is very dear to my heart because this was at the beginning of pipeline flex launch. And this lady is 6 months after delivery of her 4th baby. This is right around Christmas time. And she developed weakness on one side of her body, could not seal well, and had this massive aneurysm on the posterior fossa called this basilar artery, with a lot of mass effect on her brainstem. I'll give that to you. I'm gonna pick on you again, Dr. Yu. I don't think it's fair for Salvador and Monse. Chris just walking, so I'm not gonna pick on you.
You know, as the most senior.
So 39 years old. You see her MRI here, and I'll let you comment on that. And you see the angiogram. Well, what are your thoughts?
Yeah, again, it's a large, what's the size again?
20.
Yeah, so again, it's a large giant aneurysm. There's a giant aneurysm, and there's some mass effect on the MRI, symptomatic. Again, high risk, regardless, morbidity and mortality is high. What's interesting is, is that basilar disease, right, proximal to it, the AP view?
So I think the basilar is disease, yes.
So the treatment for this, one option would be open. Let you expand on that, but good PCOMs.
Yeah, so I think you answered the next, it's not here, but you did get a what is called an Alcock test. And the way I do this these days, I put a balloon right proximal to the aneurysm, and then I inject the carotid. So she does have good PCOM, so she could afford losing her basilar.
Yeah, because one option, again, like you said, sacrifice, closing that, and as bad as it sounds, the alternative, also high risk. I think I have a good conversation with the patient as long as they understand that is one option. Endovascularly, coil, stent full diversion again is another option. The inflammatory process post is scares me because you're dealing with the brainstem, which is very compact, and that area of growing can cause a lot of problems.
Yeah, so that's exactly my thought process with her. 39-year-old, symptomatic, first line. This lady was seen 2-3 states north of us for a practitioner that had never done a pipeline before, flow diverter before. And they called me out, can you come in Proctor just before Christmas? And I called her and said, Doc, are you sure you're going to treat this patient there? What are you quoting morbidity, mortality for this patient? About 5%. I said, it's probably 6 times 5%. The complication rate for this treatment is about 30%. I don't think it's a very good first case or early experience case. Again, this can leaves a scar on you, on the family, the whole community, because it's a small town. So she ended up coming, and we did the patient came to be treated by us, and she came to watch the case. But when you see these guys, this is a high octane. This is very complex, very high risk. The odds of this patient dying from this treatment is not negligible. So she has all kinds of possibilities of this going wrong. So I decided to treat her with flow diverter. I did not want to put more than one here because of the perforators. So she did get worse. This is a lady that got a prophylactic VP shunt. She got a prophylactic pack tube because she already had some trouble swallowing before putting her in blood thinners. I gave her a pack tube, said your swallowing is going to get worse before it gets better. So we're preparing her for the storm that is going to come after treatment. And hopefully we'll pass the storm and then things will get better. And fortunately for her, it did. So you see the swelling here got much worse after the coiling, as Dr. Lima said. When you trap clot inside these aneurysms, the aneurysm is a membrane that allows for things to go through. This is permeable. So if you have inflammation inside the aneurysm, this can permeate to the outside of that. And sometimes this can even break down the aneurysm, and we call that rupture. Fortunately for her, a week later, she was doing okay. And for her and her kids, she's back working. She has that little residual there. And that reminded me of a case when I was a fellow way back then at the Barrow. Dr. Spatzler would put these people on cardiac arrest, cardiac standstill, just like the cardiac surgeons do. Stop the heart, because it's so big that you need the heart to stop so this can soften, it can go clip the aneurysm. You had a case that looked just like this after clipping that. So this vessel is there because of this, this aneurysm is there because of that branch there, right? So this is only going to go away if this branch occludes, and we don't want that. That's called stroke sometimes. So that's where she lives, and she's now doing very well, and thankfully she's under control. There is aneurysm residue. I'm very happy with the complex of her case that she survived treatment, and we're able to help her and get her back to her family. I think I'll stop here unless you guys have any questions. We can, do we have the talk ready for Dr. Johanna?
I do have a quick question.
Please.
I'm right here. Your favorite Colombian, right?
Oh.
Okay. So with that patient, what will be the monitoring for that patient? Will they be coming back like every 3 months, 6 months, a year? Like, what is the expectation? Like?
Great question. So she was in the hospital for about a month, and then she went to rehab. We angel these patients typically at complex centers like this. I don't stop the dual platelet until I see that the aneurysm is healed. So I stop her Brilinta when I saw this angiogram, and she has 2 more angiograms after that. But then our colleague, local doctor, is doing those angiograms for her. She doesn't have to travel here for that. It's hard with 4 kids, and but I follow my aneurysm patient for life, and I tell the patients we are together to the day you fire me. Naturally, a person turns 70, 75. Do you want to continue follow-ups? I don't like just, it's a small number. If you have an aneurysm, have a 1 to 2% in your lifetime of having another one. But people get very traumatized and scared from that. We follow this patient a lot of times with MRA without contrast, that there's no radiation and there's no contrast giving. So and we're working with radiology, getting better ways like silent MRA and other ways to improve follow-up without contrast in patients that have stents, for example. But we'll continue to follow this patient. Naturally, the further away from treatment they go, the more space. So every 3-5 years, we do an MRA. Thank you.
Thank you, sir.
So can you put up the first slide for Dr. Frozen, please? So Dr. Johanna Frozen is a dear friend from Finland, and Finland is a country that has history of natural history and treatment for brain aneurysms with Professor Nimela Hirschniemi and Dr. Frozen. Again, these 3 names, any aneurysm conference that you go, It's my distinct honor to have Johanna here presenting to us. We did with Professor Wakalu and Adam Marcher 2 years ago. We had an aneurysm session in our RIDE meeting as a meeting for experts with the FDA, NIH, and industry to discuss specific topics. Aneurysm was the topic, and Johanna talk there for me was very intriguing and inspiring. So I'm gonna hear his talk first that he kindly record to us, and he will be physically with us on Zoom to answer questions. So if you have questions, there are a lot of great, cool information that he will share with us. I don't know if you can hear you, Johanna, but thank you very much. It's an honor to listen your talk and talk to you soon. Thank you.
Colleagues. It is a great privilege to give a talk at the 2025 Innovations in Cerebrovascular Science Symposium. And although I cannot be with you in Florida in person, I wish to most cordially thank Dr. Hanel for the kind invitation. My name is Johanna Present, and my talk today is about our current understanding of the role that inflammation plays in the formation, growth, and rupture of intracranial aneurysms. I have no disclosures that are relevant to this topic. Now, why should we study the pathobiology of intracranial aneurysms? Well, an unruptured intracranial aneurysm is a common disease that is encountered as an asymptomatic incidental finding increasingly often. And since we nowadays have learned that many, if not most of them, never rupture, we also nowadays know that increasingly often these incidental aneurysms should be managed conservatively. But the difficulty in the safe conservative management of intracranial aneurysms is that their untreated clinical course is not linear, making it hard to predict which aneurysm is going to rupture and when. And in order to do this, we need to understand the mechanisms that lead to rupture. Now, many clinical risk factors for aneurysm rupture have been identified from prospective observational clinical studies, from meta-analysis of them, from public health registry studies, and from institutional databases of consecutively treated patients. But at the end of the day, in order to understand how these risk factors lead to rupture, what we really need to study is the aneurysm wall itself. Because after all, whether an aneurysm rupture or not depends on the balance between the hemodynamic stress imposed by blood pressure on the aneurysm wall and the strength of the aneurysm wall. Now, this strength of the aneurysm wall is mainly determined by the structure and condition of its collagen, which is the main load-bearing structure of a vessel wall. And there is very high variation in collagen content and structure of different aneurysm walls, which in turn explains why there is also quite high variation in the mechanical strength of individual aneurysm walls. This observed variation in the structure of the collagen in different aneurysms is in turn explained by the observation that cells in the aneurysm wall can synthesize new collagen. And in fact, collagen in the aneurysm wall is a different type than that of normal cerebral artery, demonstrating that it has been synthesized during aneurysm growth. A multifocal microscopy of the aneurysm wall shows that the collagen fibers in the aneurysm wall are actually oriented according to the mechanical forces generated by flow. This, in turn, implies that it is the mechanical forces caused by flow that guide the remodeling of collagen during aneurysm growth. And if collagen fibers are not aligned according to the mechanical stress, then rupture is likely to occur. According to most physics, the mechanical strain or tension imposed by blood pressure on the aneurysm wall depends on the thickness of the aneurysm wall. So the thicker the aneurysm wall grows, the more the tension in it will reduce. And hence the observation that aneurysm wall can not only synthesize the collagen, but can actually grow in thickness as a result of cell proliferation in the wall, becomes very important, because what this actually represents is in fact the mechanism of adaptation that keeps the aneurysm unruptured despite increases in the hemodynamic stress. Inflammation is a key mediator of this adaptive remodeling of the aneurysm wall, since without the activation of the pro-inflammatory transcription factor NF-kappa B, cells of the aneurysm wall will not switch into a phenotype capable of proliferation and collagen synthesis. An essential part of the adaptive remodeling and growth of the aneurysm wall is also the paratime amplification of NF-kappa B activation in adjacent wall cells, which is mediated by cyclooxygenase 2 or COX-2 signal. This COX-2 signaling, along with the expression of other pro-inflammatory cytokines, is triggered in the aneurysm wall by aberrant flow, making cyclooxygenase 2 mediated inflammation part of the mechanism that mediate the adaptive remodeling of the aneurysm to aberrant flow conditions. A question is, why nevertheless some aneurysms do rupture despite the mechanisms of adaptation that the aneurysm wall has? The answer is that some aneurysms have lost their wall cells, leading to loss of the ability to synthesize the collagen, and in turn, loss of the capacity of adaptive remodeling. This loss of wall cells is associated with cytotoxic inflammation, which is also associated with destruction of the collagen matrix. Now, what triggers the cytotoxic inflammation associated with degenerative remodeling of the aneurysm wall is a key question to understand if one wants to predict future aneurysm rupture. Potential causes are many, but of particular interest is the finding that bacterial DNA is found in the walls of both ruptured and unruptured human intracranial aneurysms. And another very important finding is that also proteins of bacteria are found in human aneurysm wall, and the patient's immune response against these bacterial antigens associates with the risk of aneurysm formation. Now, where these bacteria antigens originate from is not completely understood, but the bacteria they are derived from are common in oral microbiome. But nevertheless, it is actually the dysbiosis of the gut microbiome that has been clearly associated with the formation and rupture of intracranial aneurysms. And to the extent that based just on the composition of the gut microbiome, so based on which bacteria species are present in the gut microbiome, it is possible to identify with reasonable accuracy persons who carry an intracranial aneurysm. Gut microbiome and oral microbiome are connected, so changes in one will affect the other as well. So most likely, it's not that much about whether it's the oral microbiome or the gut microbiome that is relevant, but both. As a summary, what we know nowadays of inflammation in the aneurysm wall is that it plays many roles, of which the induction of cell proliferation and collagen synthesis to trigger adaptive remodeling, as well as the other kind of response, the cytotoxic response causing destructive remodeling, are clearly amongst the most important roles. And although there are many causes for inflammation in the aneurysm wall, clearly a very important but thus far neglected factor is the composition of the oral and gut microbiome that triggers or modulates the inflammation in the aneurysm wall with mechanisms that remain yet to be discovered. Now, how can we translate our knowledge of the aneurysm wall pathobiology into clinical practice? Well, using the composition of the gut or oral microbiome might be possible to screen persons at risk of aneurysm formation, or it could turn out to be very useful to use screening for immune response triggered by exposure to specific microbes as a tool that will help to predict which aneurysm is going to progress to rupture and in which patient. In addition, I just presented to you how aneurysm growth is mediated by cell proliferation and collagen remodeling that requires pro-inflammatory signaling through cyclooxygenase 2. This provides an easy target for drug therapy that will prevent aneurysm growth and stabilize the aneurysm wall, together with antihypertensive medication to reduce hemodynamic stress. And this could turn out to be sufficient to prevent the progression of low-risk aneurysms to eventual rupture. And we have 2 ongoing trials in Europe investigating these concepts. The PROTECT-U trial, which is a clinical drug treatment trial investigating the impact of daily aspirin use coupled with antihypertensive medication to prevent aneurysm growth. And then we have another trial called PROTECT-FINS ongoing in Finland, which is a prospective observational study in which we investigate, among other things, the predictive value of microbial markers to detect or predict future aneurysm growth. And it would be great to have you join both of these research efforts. Before we finish, I want to thank all my coworkers and lab members for their excellent work and support. And I also want to thank you for your interest on the topic and this presentation, and happy to take any questions. And finally, most warmly welcome to Finland next year in May to the upcoming 17th meeting of the Scandinavian Neurosurgical Society, which is a perfect forum to discuss more ongoing studies and our knowledge of the pathobiology of intracranial aneurysms. Thank you very much. Dear colleagues, it is a great privilege.
Hey, Johanna, thank you.
Hi, how are you?
Hey, how you doing?
You hear me just fine?
Thank you. It was perfect. Thank you very much for participating. Do we have any questions, guys, for Professor Trosen?
So Ricardo, greetings from Finland, and thanks for the invitation. It was a great pleasure to contribute, and I really hope that all of you found the presentation interesting, and maybe provoked some ideas. And if you're interested in the role of microbiome in aneurysm pathology, or in drug treatment trials that are ongoing in Europe, please don't hesitate to reach out to me, and would be great to establish collaboration and get more patients and more data.
Absolutely, absolutely. So I have two questions, Johan, if you have a minute.
Yeah.
So relationship, we're talking just before you present cigarettes and oral health. We know my dad is a retired dentist, so we know that's a disaster for your dental health if you're a smoker. So that's number one. Could your finding explain more or better cigarettes and aneurysm relationship? So I'll let you answer that, and I have another one.
Yeah, that's a great question. Well, based on our data, it looks like cigarette smoking is connected with periodontitis, so poor dental health overall, leading to dysbiotic oral microbiome, which in turn will affect the gut microbiome as well. And you know, in our multivariate models, if you include the dysbiosis of the oral microbiome or the periodontitis into the models, then cigarettes smoking actually loses its significance as a risk factor. So definitely there seems to be some connection between cigarette smoking and poor oral health, leading to the changes in the microbiome that eventually predisposes to aneurysm formation. Whether that's the whole story or not remains to be seen, but at least it's part of the story. Yes.
Thank you. And you talk about, and I saw Protect You with aspirin antihypertension. Anything directly related to the oral flora change and addressing dental health? Any drug related to that on your studies?
For the time being, no, but we're looking in our data sets whether we can see any association with you know, how the patient takes care of their dental hygiene and the outcome or evolution of their aneurysmal disease. Kind of the point would be that you know, if we can show an association that when you start to take care of your dental hygiene better, then that would stabilize or have an effect on the aneurysm, that would be a wonderful thing for the patient's perspective point of view. But we're not yet there. We do have some interesting data sets coming from Finnish National Health Institute, like a national health survey that actually has this kind of data. So it's possible to study the impact of brushing your teeth on the evolution of the aneurysm disease. But yeah, we'll see what the impact is. But for drugs that would affect directly the oral health, no, not for the time being, but happy to hear any great suggestions if you have some drugs in mind.
We have one more question for you here.
Hi, my name is Lorena. I used to work with Dr. Hanel in the Mayo Clinic. You have a very interesting presentation, and thank you for that. I had a history of lacuna in part back in 2012, and my grandfather and my uncle passed from ruptured aneurysm. So I'm concerned because I was also diagnosed with lupus. So does it potentiate the risk of inflammation? And can I continue using the monoclonal antibody infusion for that?
Well, again, a great question. A question that also in a very clear way demonstrates the difficulties we have at the moment in counseling our patients. There's just so much about the aneurysmal disease that we don't know yet, and what the impact of using any kind of monoclonal antibody therapy would be to the aneurysm. I have to say that we don't know, or at least I don't know for sure, and I'm not sure whether we have that kind of data yet. But definitely that something that needs to be determined.
Thank you. Any more questions here? Thank you, Hanel. Really appreciate you being here.
No worries, it was a pleasure, and
Thank you. I'll see you soon.
thank you, and I wish you all a great symposium.
Thank you.
Bye-bye.
Thank you. Have a good one. So the next two topics are connected, and it's very dear to us that we have here in the spirit of Institutino. And Gary Poppenberg from my American alma mater, the State University of New York in Buffalo. Go Bills. So the next session, we're going to show a work that has been ongoing for 4 or 5 years at Baptist Downtown, and our own Monsi is going to show us a little intro into what what is being done. And I'm going to invite Olivia Hoblet, that was instrumental in this, to come and join us, so Olivia can make comments. The Florida, it's called Florida Brain Aneurysm Study, but it's actually Florida, Georgia, because we are right on the, I like to tell people I live in South Georgia, not North Florida. I'm also going to show us a little bit, just right on the tail of what you want to show us, and we know. Find the presentation with. Here we go. Can you guys see my screen?
Yeah.
Here we go. So this is a tremendous teamwork that I've been asked the other day. We don't know what the research fellows do at Lardy. I think this is a great example of what the research fellows do at Lardy. Dr. Benali was a research fellow. Dr. Cortez, that is now in Buffalo, was a research fellow, and Monse has been instrumental with Gina and the BHRI team. So there's a great combination, strong effort between BHRI, Lardy, and Wolfson, sparked by these two. There's two. And I've got our guests standing here for 30 minutes, 1 hour. Phil and Olivia Hoblet, I think it's worth a minute of this, and Phil knows that I give much more credit for Martina than I give to myself in our Hanel domain. Olivia is the Energizer Bunny, and Phil has no option. He has to support her. I have the same at home too. So Trinity Hoblet came to us at Wolfson when Dr. Alex Beyer was just starting, I don't know how many years ago. Trinity had a very special condition called primordial dwarfism type 2. So she never got, how tall was Trinity? 29.5, she would be here. 29.5 inch tall, with a lot of energy, tremendous personality. She had 13 brain aneurysms. These kids that have this condition, they're much more prone for brain aneurysms. Trinity was operated first at Stanford for an aneurysm. Unfortunately, almost died on the table. Thankfully, Dr. Steiner was able to save her. And fast forward a couple of years, she had another bleeding from an aneurysm. And she was treated at Wolfson, and we were able to treat 8 of her 13 aneurysms. She had 2 little aneurysms, one that grew a little bit. I counsel Olivia and Phil that maybe you should watch that one. She had another aneurysm on the left side that grew a little bit. I said, Olivia, Phil, let's treat this aneurysm. She was scheduled for treatment on Wednesday, and I'll never forget that Sunday night, Olivia called and said, she's having the worst headache of her life. I said, bring her to the hospital right now. Unfortunately, she coded en route from Fernandina to Wolfson. We're able to treat her aneurysm, but that was too much for her, and she passed. Again, we saw Silas yesterday here, and this is another super inspiring story. When life punches on your face, instead of being regretful, mad, pissed, Olivia and Phil said, we're gonna hug this disease. And they turned that into the Trinity Law Republic to keep her alive and to honor her. And with that, Olivia from inside was instrumental and inspired the state of Florida to give us funding to do this. So this is a study that got paid with a lot of our taxpayer dollars to the state of Florida through direct interaction and intervention of Olivia and her team at the state of Florida. She raised over $1 million for us from state of Florida for this study, and we're going to show you here the results. So cannot ever say thank you enough to both of you for your support. Your daughter is alive, which is really great.
Yes, thank you, Doctor. You know, actually, this is all Trinity's work, right? So I always tell the team when I'm doing the dishes and a good idea pops up, and the board say, "Oh, that's a great idea." I said, no, that's Trinity's idea. That's just telling us what to do. I think one of the biggest thing is we want to compliment you and your team because we're doing a small part. You all are doing the most important part, right? I think relationship is the biggest key, and our state leaders are approving over $1 million because they believe in your work. And so congratulations on that.
And just to share too, that all the involvement, everybody that's here and going forward to make more additive to become doctors or whatever your path is to help in this escapade, we'll call it. But he gave us 3 years more than we would have had with Trinity. And the relationship that he had with our daughter was so key and everything as to why we really we connected with their relationship, which really helped us decide the path that we were going to do as well. So a lot of it was the way that your relationship was with Trinity. And I don't think we've ever really told you that, but as we've talked and we've done things, what we saw in your relationship with our daughter is what brought us to a point of where we are with the Trinity Foundation. And that is her full name. That's why it's her foundation.
Thank you. Monse, please.
Thank you, Dr. Hanel and Ms. Hawley and Mr. Hawley for having me here today. I'm just going to be talking a little background about the project, and I'm going to show you through research and published studies how important it is actually to study familial intracranial aneurysms. And then later on, Dr. Hanel will show you the preliminary results of the study. Brain aneurysms can be present in up to 4% of the population, so that's not low at all. The risk of a brain aneurysm is that it can rupture, and if it does, it can bleed, and it can lead even to the person can die, or it can lead to a severe disability. So it's not only important to screen for the disease because also helps the people to be up in the society, but also decreases the cost associated with healthcare in long term. For example, these patients, if they get bleeding, they need to get care in the hospital for a long term, and that increases the cost that they might need to pay in the future. So there is ongoing research about, again, the demographic factors involved in the development of familial intracranial aneurysms, but there is little about the genetic factors involved in familial intracranial aneurysms. And in future talks, you are going to see the importance of the genetic background for the disease. I'm going to start with this protocol that was written by Dr. Broderick and colleagues. This is actually the backbone for the Florida familial intracranial aneurysm, because it not only led our group to see for a model on how to screen, detect, and enroll patients into our study to have the data in the higher quality standards. This protocol is going to let us also compare our data collected here in Florida to at a national level in the US and international levels with other family, with other cohorts or familial intracranial studies. And I want to show you this study as well. This was done by Dr. Brown and colleagues. This study was fundamental in establishing the importance for screening in individuals that have a family history of brain aneurysm. It not only helped to detect that these patients with family history of brain aneurysm have higher number of aneurysms, and that they actually have a higher risk of rupture at a younger age than sporadic cases. This other study, again, on the same line, is showing that patients with family history of brain aneurysm have a higher mortality rate at a younger age, less than 50, than patients with no family history at all. On the same line, this study by Dr. Broderick, again, from the familial intracranial aneurysm group, is also highlighting the importance of screening. Why? Because these patients get to rupture and get to have higher level of complications that patients that have no family history of brain aneurysm. So if you ask me, is screening important in these patients that have higher risk of developing an aneurysm in the future? It is. It definitely is, and it has been shown in the past. What about mortality cases among members with family history and without family history? This study actually shows that there's no mortality rates difference. However, it did conclude that patients that had a previous rupture have 2.5 higher risk of death in the nearly upcoming years than those patients without any previous history of rupture. So if you have a family history of brain aneurysm and you actually have a rupture aneurysm, you have 2.5 higher chances of death in the upcoming years than cases without any family history in the past. And I wanted to conclude with these two studies, This is a meta-analysis which actually was looking of all the data that has been published in regards to familial intracranial aneurysm studies. And it actually highlights, again, the importance of screening in these kind of patients. So if you ask me, do we need to screen patients with only a second-degree family member with a brain aneurysm? Actually, no. You need to screen family members that have first-degree or second-degree family history, because one case in every 5 individuals with family history is going to develop a brain aneurysm in the future, and that was established by this study. And in line with our next talk with Dr. Pockenberg and Dr. Tutino, what about the genomic basis for familial aneurysm development? Well, this study here by Dr. Tatiana actually set the foundation, saying that there are genomic areas that increase the risk for developing brain aneurysm in family members. It actually didn't find a specific chromosome or gene related with familial intracranial aneurysm foundation, but actually helps set the standards that there might be an association with a specific gene that is actually forming these aneurysms in family members. So it's worth looking into the genome of these patients with brain aneurysms. Now I would like to invite Dr. Hanel to show the preliminary results for study.
So you saw that for familial intracranial aneurysm study, Bob Brown was my partner when I was at Mayo. He was the PI for ISUIA, biggest, largest unruptured intracranial aneurysm study done in the United States, and Joe Broderick from Cincinnati. The 2002, or the first study was presented. If you fast forward 20 years, why in 2025, we don't screen family members. If you go to American Heart, I always say this, I think we changed this at Baptist, thankfully. But if you go to your primary care physician, did anybody in family diabetes, colon cancer, breast cancer, yada, yada, yada? All good questions. Nobody asks a person, do you have anybody in your family with a brain aneurysm? We had one of our friends sharing her personal story. Again, 2 family members with brain aneurysm, by conservative estimates, ISOA, that's the number that Monse showed, just double the chance of having a brain aneurysm. We screen people for things that are way less problematic than a brain aneurysm. Probably because in 2002, and you saw the numbers for brain aneurysm on the familial intracranial aneurysm, 26 centers combined, did not make guidelines that we should be screening people. Why? Because the treatment of a brain aneurysm in 2002 probably was not a walk in the park. We had very well established craniology for clipping, endovascular was just starting. If you fast forward 25 years, today, to treat a brain aneurysm with an intrasacral device like Webb and others coming, it's a 2% MNM, 3% MNM, 4% MNM, but it's a much safer event.
I'll have to unplug it, play it back in.
Much safer event than it was 25 years ago. I remember when I was a fellow, our perfect. So the goal for this was to spark this discussion again. And we're hoping now they're very close to finish this study to reach out to our national societies, SNIS, through Olivia, through other patient-driven associations like the Brain Aneurysm Foundation, the B Foundation, and others. Let's look at this again, because maybe in 2025 makes sense to define who's higher risk and push the insurance companies to pay for that, because the poor patients is stuck on that. I want to be screened. Unless you come up, oh, patient has headache, needs an MRA, oh, the patient wants a screening. Somebody with familial history can do genetics for breast cancer, and rightly so. Why does a patient, family member of brain aneurysm deserves less? Then the opportunity and the option say, I want to be screened, although I don't want to be screened. It should be up to them to decide, do I want to do that or not? So we embark on this. I share with you guys, for us was Olivia supporting Florida State and subsidized by Baptist with the work of our group of radiologists and Baptist to do MRAs at a much more affordable price than a commercial rate. So everybody that has proof, oh, here's the death certificate of my mother, she died from a brain aneurysm, I want to be part of this study. Or I have an aneurysm, I want my beloved family to be screened. So any first degree relative, either proven that this person had an aneurysm by a medical report or treated by one of 4 of us at Baptist, these people were enrolled in the screen for the patient, the subject that triggered that. If possible, we got a blood sample. These people already had their CAT scan, MRI, angiogram that found the aneurysm. And for the family member, we save blood, collect blood, and Carrie and Vince are here because they're going to be inheriting and doing all the work on the genetics part. For me, it's a bit back to the future. I started in Buffalo and super cool through Adnan Siddiqui, Anilad Levy with Vince Tutino and Carrie Poppenberg. We're going to be doing all this genetic analysis, very advanced genetic analysis at State University of New York in Buffalo. So that's where we're going. So Mons is here. Again, there are many people that work on this. Gina, I saw her in the morning. She's here's Gina. Dr. Gubi and the BHRI team with Gustavo, Victor that have worked on this before. This was kind of sluggish to this young lady show up. Dr. Khan, I saw you here. Did you step up? Monsi is an MD, PhD, daughter, mother, phenomenal candidate applying for neurosurgery residency, so you need to get her resume. Dr. Khan is the chairman of UT Galveston, and they just met 2 residents in neurosurgery, so she's gonna be applying for the next cycle. She wants to come and visit you. I would hire her if I could, if we had a residency. Monse changed the speed of this. When she joined this, she comes from the family of the Energizer Bunny. She just grabbed the bull by the horn, and the enrollment went from X to 5X because of her work and dedication. So thank you, Monse, for igniting this and making this happen. We are almost done with this. I think we're 62 family members to enroll 1,000 family members. I think the Familial International had more patients, but they had blood samples. I think there's going to be the largest data set of family members with imaging and blood sample all over the world, from Little Baptist in Jacksonville. So we are naturally very proud of that. A lot of people naturally don't have brain aneurysms in these families, but very interesting. We found a significant number of patients with that, and you see here a distribution that is typical to us. Most of the family members were females. A history of cigarette smoking, about 36%, and others that you see here. A lot of demographics all over that we're going to be writing about and talking about disparities of care, where this is more prevalent, and there's a lot to be done here. We did the spot as well, a small number of pediatric patients that participate on that with the Wolfson, Dr. Aldana and his team, and we have blood samples for a lot of that. And we did find a fair amount of not negligible aneurysms. So you see here this youngish lady in her 60s, as Dr. Hopkins would say, they always look younger and younger. So a 60-year-old for me is a very young person today. She had this aneurysm that is not small, and we decided to talk to her family that ruptured. Monse just showed that is a higher risk for her to rupture, and naturally, it does also bring a psychological burden to these people. My sister almost died from an aneurysm. Now I have an aneurysm, what do I do about that? And they're much more prone to get these aneurysms treated. So she was treated with a flow diverter. Another one that was found to have this ugly looking basilar tip. So I love this example because this lady, our numbers, and we're not sharing them specific for obvious reasons. Monse and the team want to publish this at a national meeting, present that. So if I show you the prevalence, but I'll tell you that our prevalence is way higher than the 6%, near double the 6% that ISYA showed. This is with everybody's screen, not only and on the Familial International study, Familial Intracranial Aneurysm study from Broderick and Brown. They only did imaging high-risk patients, familial history, and cigarette smoking over 30. So they biased the sample by choosing the higher risk group there. But we screen everybody that wants to be screened. Naturally, it could be, this person is more worried about, maybe he or she smoked. Prevalence of cigarettes is 30% only. So there's a lot of people that got screened that didn't have exposure to cigarettes. And you find an aneurysm like this. For any of us that treat aneurysm, if you see this, again, this needs to be treated. It's an irregular basilar tip aneurysm, close to 7 millimeters. And today, this is a 30-minute treatment, minimally invasive, with an upcoming femoral dispersion, but it could be a radio approach, a web placement with M&M that is low. I think the bottom line for us, again, these patients, family of patients, deserve the choice. Do I want to be screened or not? And we're talking about 10, 12% of them have an aneurysm. Vast majority of them don't need treatment, absolutely. But it's a good thing for you to know. And sometimes it's a come to Jesus moment for these patients. I have a brain aneurysm that is small, I don't want to be treated, but I'm going to quit smoking, I'm going to fix my ways, I'm going to lose weight, I'm going to get healthier. So I think the timing may be right to bring this to the national discussion. If we can get American Heart to say every primary care physician should be asking do you have a family history of brain aneurysm, and on specific groups may be guided by genetics, and that goes to Carrie, that is coming next year. Maybe we'll find a genetic marker on a blood sample that is way easier and faster and cheaper than an MRA. I say, okay, you do have genetics, propensity for that, let's screen everybody that has a family member. I think that there is a big discussion that I think is destined to happen again at a national level. We're hoping to spark this, and through this study that we did here in Florida and South Georgia, we go to that. The Jaguars change games sometimes. We hope we can change the game, come from behind, and make this for this group of family members that sometimes are very scarred by a subarachnoid hemorrhage that we know is a devastating event in anybody's and in the whole family's life. I cannot say thank you enough. Olivia was instrumental with Phil to get us to the state of Florida, the support of our Congressman Aaron Bean, Senator Clay Yarborough, Women Duggan, Baptist Lardy, MDB, Dr. Sherman representing the team here, and actually our patients and the family members to donate their time, come there and be screened and participate on that. With that, I will stop, and I'm gonna save questions to after the next talk, because the next talk is directly related to this. As I said, Carrie and Vince are here from State University of New York and Jacobs Institute. They're going to talk to you about genetics of brain aneurysm and potential blood-based screening for brain aneurysm. So Carrie, please. So this is Dr. Carrie Poppenberg, a PhD from Buffalo, New York. Thank you, Carrie.
Hello, everyone. Thank you so much for that introduction. I'm very excited today to talk about work that we've been doing for about the past decade, trying to develop blood-based gene expression biomarkers that can help to not only detect aneurysms, but also to assess their risk. Okay, these are my disclosures. As Dr. Hanel said, I am from Buffalo, and I'm in this really unique building called the Gates Vascular Institute and the Clinical Translational Research Science building. The lower floors are all part of Applied Healthcare and Neurosurgery, and then the upper floors are all research labs at the University of Buffalo. So it allows for this really unique environment where you can collaborate with the clinicians just by an elevator. It really helps us to get clinical samples as well and be able to inform our research with clinical questions in mind. This was all founded thanks to Dr. Hawkins. So for our lab in particular, we focus on vascular diseases, predominantly brain aneurysms, ischemic stroke, and brain tumors. We today are talking mostly about brain aneurysms, and for our lab, we do keep that clinical connection in mind and try to have these very fundamental questions that we're answering. So how do aneurysms form? What treatment strategy would be best for a given patient? And here I'll be focusing mostly on who has an aneurysm and how likely is it to rupture. So Monty gave a great introduction, so I can kind of skip over this. But the main thing I want to highlight is that intracranial aneurysms are mostly asymptomatic. A lot of people don't realize they have them until they rupture, and most of them are found incidentally when imaging is performed for a different reason. As she said, rupture is very traumatic. It has a high rate of morbidity and mortality, with half people dying a month out after rupture. So it's really important that we are able to detect these aneurysms and treat them or monitor them before they rupture. So imaging is right now the most common way to identify an aneurysm. However, we can't use it for widespread screening. It's expensive, it has its own risks, especially for DSA, and it can be inaccurate in the case of smaller aneurysms. And as Dr. Hanel said, most patients, even with a family history, aren't recommended for imaging. So that they may benefit from it, but right now, in the guidelines, it's not happening. So we need to find a way that we can non-invasively identify those who would benefit from imaging, which led us to wonder if we can use a blood-based biomarker instead, as a pre-screened imaging. So a biomarker is defined as a characteristic that is objectively measured and evaluated as an indicator of abnormal biological processes, pathogenic processes, or a pharmacological response to a treatment. So in our case, we are pitching to use a blood-based biomarker to detect the presence of aneurysm that can then indicate whether a person would benefit from cerebral imaging. The advantages of a biomarker is that It's minimally invasive, it's low risk, it can be done quickly and inexpensively, and the other benefit is that it does tell you something about what's happening in this patient's biology. So our central hypothesis is that circulating inflammatory cells carry a signature of aneurysm in the circulating blood. So due to this interaction with the aneurysm wall, these cells can change their expression profiles. And we are focusing on RNA biomarkers, which really are a dynamic response as opposed to some of the more genetic-based biomarkers that don't change in the environment. So as Monty pointed out, there are known genetic risk factors, but a lot of those actually just link to whether they have a propensity to have an aneurysm, whereas our biomarker tells you if there is one currently. Through histological studies and human tissue studies, we know that the aneurysm wall is marked by inflammation, and there are all sorts of mediators that are released into the blood signature that can change the profile of these circulating cells. We're trying to capitalize on this interaction between the blood and the vessel wall to make a biomarker. So our overall goal is to develop a molecular diagnostic test that uses these expression changes to not only predict the presence of an aneurysm, but also its propensity to rupture. Our general workflow would be that the doctor orders the test, goes to the lab, runs our gene panel, looks at the algorithm, and the report is given back to the doctor, who can then use that to inform if the patient should have imaging, what level of imaging, or just repeat back with another follow-up blood test. This would be ideal for people who don't meet the criteria for imaging, people who have one family member and a risk factor, so we get more people screened and lead to preventative treatment and early detection. So for our initial detection studies, we began this about 10 years ago, as I said. The general workflow is that we recruit patients who are receiving imaging. That way we know definitively whether they have an aneurysm or not. We collect blood samples. From the blood, we extract RNA, which gives you that gene expression profile, perform sequencing, and we use the transcriptomic data to identify genes that are differentially expressed in the aneurysm population. We can use that to also look at the bioinformatics, which gives you an idea of what these genes are linked to, and then build biomarkers. To date, we have about 1,000 patients that we've collected blood from. So for these potential patients, we rule out any who don't meet our criteria. The recruited patients might be further excluded due to different confounders and end up with a filtered population that we go for RNA sequencing. Some of those may get further reduced due to quality and inaccuracies. And then we have a final data set, which is roughly half aneurysm and half control. Within this data set, we further split it into a training cohort and a testing cohort. In the training cohort, that's where we'll look at the actual transcriptomic data, try to identify those genes that are associated with the aneurysm population. Again, we perform bioinformatics to get a better idea of what ontologies and pathways are affected in this disease population. And then we'll build our machine learning models using these differentially expressed genes. And this then gets tested in the independent testing cohort, and ultimately we have our biomarker. So our first studies, we started with neutrophils, which are the most abundant white blood cell, and they're known kind of as the sentinels of the immune system. So they are able to change their expression in response to vascular lesions or other pathogens. So it makes it really kind of a dynamic and responsive cell type to use. Our first sequencing study had 134 patients. We used 70% of that as a training cohort and found 37 genes, which you can see are able to kind of clearly separate the control and aneurysm populations. In our model building, it had good performance with AUCs over 90%. And even in the withheld testing cohort, we found that the accuracy was about 80%. And again, can separate between those aneurysm and control samples pretty well. The genes that we found were largely associated with activation and inflammatory signaling. So it is capturing some of the important processes that we know are happening in aneurysm pathogenesis. The top network shown here, our genes are in the colors, so you can see if it's increased or decreased expression in the aneurysm group. And we see that there's TNF alpha signaling, which is a very important inflammatory kind of hub that can induce these changes in macrophages and endothelial cells that are critical for the aneurysm growth. MMPs were also in our network, which really help with that extracellular matrix breakdown that allows the aneurysm to continue to grow. From these studies, we saw that it is possible to use blood-based biomarkers to detect aneurysm. Our models had an accuracy of over 70% in testing, and we saw that the genes were identifying to make sense of the disease, reflecting inflammatory responses and other signaling pathways. We also saw a lot of peripheral neutrophil activation, which we have learned since is a really important process in aneurysm formation. But this is not the best blood cell to work with. So we have pivoted to use whole blood. Whole blood is stable. You can get a lot of high quality RNA from a little amount. And it fits in better with the clinical infrastructure rather than using neutrophils that have to go through an extensive processing step. So our first study here was with about 70 patients, half of whom had aneurysms. And you can see here the breakdown of the different cell types. And between the control and aneurysm population, you're seeing largely the same breakdown, and that neutrophils are the biggest contributors. So it will likely be an easy shift for neutrophils to hold on as we're having a lot of the same signaling pathways. We again split into a training set, which had 47 samples, and we found 18 genes that were associated with aneurysm presence. These genes reflected activation of leukocytes, macrophages, again, things that kind of fit into the pathogenesis of aneurysm. We also see cell death, which is really important for that extracellular matrix turnover. And the network here, which is a little dense, shows a lot of signaling around NF-kappa-B that Dr. Frusen talked about as an important inflammatory process. Again, we were able to build models that perform well in both training and testing. You can see in the PCAs, those colored plots, that the groups of aneurysm samples separated very well using just the expression of these 18 genes. And we had AUCs in both groups of about 90. We also did a study with Dr. Hassan to look at these genes in a different population. So in this study, they actually were able to draw blood from inside the aneurysm itself and compare it to the expression proximally. And half of the genes that they tested from our 18 had higher expression in the aneurysm sac, which means that those ones in particular are likely changing their expression due to the interaction with the aneurysm wall. And 3 of them were correlated with the proximal expression, so those again might be better targets that are actively changing due to the presence of the aneurysm. So just to kind of summarize this section, we began this over 10 years ago, looking at these blood-based expression markers, and there really wasn't much work being done at the time, but now there's been a whole lot of publications since then. And most of the studies, besides our groups, were looking at just one molecule, because we're trying to look at a panel that might be more effective in heterogeneous populations. So from this, we've published a bunch. We've thankfully been able to get a lot of grants to help us continue this work. And since we established this is feasible, we then moved to try and make it actually clinically implementable. So we began developing our assay, which is called Neurosurgery. So we originally had used RNA sequencing because it is helpful to get thousands of genes and be able to identify ones that change. But now that we know what genes we're focusing on, we were able to build a smaller 50 gene panel that can be used with just PCR technology, which is common in most labs, and it's a lot more inexpensive and quickly to do as opposed to RNA sequencing. We partnered with a company called Dexterity Diagnostics, and we were able to build our assay, which is composed of 50 genes that were based on those previous neutrophil and whole blood studies using RNA sequencing. There are a couple different normalizers to help just make sure we have stable reads coming off of the platform. So we had to do some analytical testing to make sure that the probes we designed were responsive, and we did this just using control blood and RNA. And we found that the signals were all robust, well over that green line that you need for detection, most of them being high signaling. And the majority of the probes also didn't have a lot of technical variation. So we were confident in the probes that we had chosen. We also see that they are linear with the input, which you expect. As you give them more blood or more RNA, the signal should increase, which was the case for all of our genes. We also found that it required a very low volume of blood, which is very important as you're moving to a clinical test that you don't need to use a large patient sample. After we established this with just control blood, we did look at the performance with 20 of our clinical samples and found that the signals were detectable and that there was minimal variation as well. So our panel just demonstrated robust and stable signals. It had linear expression and it was compatible with either blood or RNA. So our preliminary model using this did have good performance with accuracies of about 65%, but that does suggest that because this is a new data type, we kind of have to refine it as opposed to the RNA sequencing model that we had. But using this, we had a prototype to go forward with a large validation study. So our actual clinical testing, we completed a large study with 550 samples that were collected from 3 different centers throughout the US. And both collected from aneurysm and control patients, and you can see the demographics are largely the same between these 2 populations. However, as expected, there is a higher percentage of females and a family history of IA in the aneurysm group. So to retrain this, now using this assay PCR data, we used our 50 genes. We included some demographics and comorbidities, and we also used gene ratios just to kind of increase the feature set. And through some statistical filtering and ranking, we ended up with 50 genes that were then 50 features that were fed into our prediction model. We used a couple different modeling schemes just to see which best fit the data, separating our large sample into a training and a testing cohort. Within the training cohort, we further split it so we could figure out the best parameters and best model, which is then applied to the held out independent testing cohort. We ended up with an SVM or sport vector machine model that had 12 features that were both genes, patient factors, and gene ratios. And in training, it had an AUC of 0.82. It also performed well in testing with a similar AUC and accuracy of almost 80%. You can also see that it has a high negative predictive value, which is pretty important for a disease with aneurysm where the incidence is quite low. So we have a good anti-screen platform to move forward for as a pre-screen. So now that we've established the risk, we go back to our other fundamental question is how can we figure out which ones are going to rupture? We kind of repeated this process focusing on rupture. So when an aneurysm is detected, clinicians typically have to weigh the low rupture risk, the treatment complications, and figure out what's best for the patient. There are some clinical metrics that help them in this decision-making process, largely size and phases score, which takes into account some of the demographics of the patient. And we wanted to come up with a blood-based diagnostic that could help with this decision. So it could also be used during watchful waiting. So in between imaging scans, they can have a blood test that can see if their aneurysm is changing or not. So in our previous studies, we had already kind of seen that the blood does change with respect to risk. You can see that the fold changes in green are less dramatic than those in orange, which are from the larger aneurysms. So it's likely that the larger aneurysms are changing the signal even more strongly, and that the aneurysm samples did separate well based on size, even when we weren't really looking for it. And in that study where they had the interluminal blood sample as well, we found that there was correlation between some of our genes and these risk factors, size, and vessel wall enhancement, which indicates that the aneurysm is risk B. So our first study was done in about 70 patients, and we looked at genes that were associated with size and phases as our two ways of assessing risk. And these genes reflected higher inflammatory signaling and vascular remodeling in the high-risk groups. And as you can see in the PCA plots, again, we're able to separate these groups using these genes' expression levels. 10 genes were found in both size and phases, which are likely good targets to further continue with. And a couple of the genes were also associated directly with the expression levels. So as the size increased, the gene expression also changed, which is easy to see on this visualization here. The expression kind of goes with the arrow trend. So as the size got higher, the expression of the genes increased, same for the phases score. We built a model in using these transcripts as well, and we're able to achieve a testing accuracy of almost 90% for the phases stratification and about 80% for the size delineation. So then we completed a larger study on almost 200 patients. We found 55 differentially expressed genes in this population, 3 of which were already in that previous work. And we developed models again, having even better performance with an AUC of almost 90% in both training and testing. And we found that adding patient factors in this cohort didn't actually seem to matter. So it was really the expression of these genes that was driving the prediction accuracy. So we showed that we can do this with risk as well. So now we want to kind of add it all together. We recently developed AnnuScreen Plus, which combines both markers for presence and risk. And again, we work with Dexterity Diagnostics to create a new 50 gene panel that has features that respond to both of those. This used our results from our original assay testing and a large-scale RNA sequencing study. And you can see that we tried to pick features through modeling that really separated those two groups well and had high performance in some preliminary efforts. So we recently, actually just last week, completed the analytical testing for this component. And all of our probes, again, similar to the first assay, are detectable. They have linear response. They have low coefficient of variation among replicates. So it's good to move forward with them. And this doesn't matter whether you use blood or RNA as the input. So through this work, we showed that you can use blood-based biomarkers to both detect aneurysm risk and its presence. And the models that we were able to build in these cohorts have a high performance of AUCs of about 0.8 in the independent testing cohorts. And most of the genes are showing that there is increased activation in inflammatory process in the aneurysm group and then further in the high risk groups. The next steps we're working on are AnnuScreen validation. We're also exploring some multi-omic models to help improve performance. And we have from this a very large data set, as I said, about 1,000 patients that we can do further studies. To work to test the next stage of our prototype, we are about to test it in 200 bank samples, and we are continuously enrolling. We will ultimately validate it in about 600 samples of both aneurysm and control. We also have study samples within that have repeat blood collections and imaging, so we can see how the expression changes as the aneurysm grows or stabilizes. The study that we just learned about, we are partnering with Dr. Hanel to test our assay in this large familial population, which is kind of our target population. It is those people who wouldn't be screened otherwise. We can test our assay there and see if people warrant having imaging and hopefully get them treated. In this study, we are also going to look at IA-associated variants, so in the genome itself, to see if there's a higher likelihood of people having these genetic mutations as well. Some of the multimodal biomarkers we're working on are trying to use non-invasive imaging to further stratify risk. We just completed a study with 16 patients who had transcriptomic profiling and vessel wall enhancement, and combining these features together does give you a better separation between low and high risk aneurysms. There is also a correlation between the gene expression themselves and these radiomic features. We're working on validating this in a larger cohort with multiple centers contributing. And the last thing that we're kind of exploring is spatial sequencing. So this gives you an idea of what the expression is throughout the aneurysm itself. Right now, we're just doing it in a rabbit model, but we're hoping to process the aneurysm dome tissues. We can actually see what the expression levels are at different areas of the flow and how it changes in response to the hemodynamics. Thank you to all of the partners and our collaborators that help us with this work, and our funding sources. Thank you very much. Take any questions.
Coming.
Family members, whose family has a history, what excuses do they use to not be followed? They don't want to be followed.
The family members are like the healthcare providers, like the insurance side of you asking.
Well, say for instance, my mother had a rupture, and so that's first degree. What reason would I give that I don't want to be followed in a study?
I mean, I think that's very much a personal choice. A lot of people live with aneurysms and they never rupture and they're totally fine. So it's whether you want to know what you have and do something about it, or kind of live blissfully as you are.
May I comment to that real quick? I think one of the things that we've been working on is awareness through the Trinity Love Holiday Foundation. And talking to a lot of people is, I think, not knowing about it, and I believe that's why awareness is so important. Also, financial, right? People doesn't want to have to, like, when they hear ambulance, oh, I have to pay for the ambulance cost, right? And I think it's like, how can we educate them more of the bigger risk? So I think education and awareness is the biggest part of that.
So just to go to your point, again, humans are very, very interesting. So another common that we see, again, vast majority, 70–80% of our patients are ladies. So my son is a smoker, he doesn't want to have anything to do with this. So it is, as Carrie says, a personal decision. Some people just, they don't want to know. If I have a problem, I just want to die quick. I heard that before from a son of a patient that had some quoting him on that. So it's a very personal decision, but I would flip that, right? 180. So now my mom has an aneurysm, I want to be screened. I go to my primary care and I tell him or her, my mom had an aneurysm, I want to be screened. And then my insurance company say, no, you cannot be screened. So that's what I think we need to change this a little bit. If somebody has family history, we see patients. with 2, 3 family members. We don't even ask these people at a primary care physician office, do you have family history? Today, on American Heart Guidelines and all primary care physicians in this country and what the US does, a lot of times the world follows, for better or worse. We want to change that. Have that as an option to first ask primary care physicians should be asking this question, just like high blood pressure, just like diabetes, breast cancer, colon cancer, we should be asking that question. For brain cancer, we should be asking that question. If the answer is yes, and the person exercise her free will, I want to be screened, then I think the insurance should be asked to cover that. I think that would be phenomenal. And if we can get to the point that we can tag that into a test, that you go there and put your factors, yes, I'm over 30, I'm a female, I'm a smoker. My mom has an aneurysm. Now you do a genetic testing and you see all this aneurysm plus positive. You know that person should be getting an MRA. Might be a better way than just getting MRAs for everybody. But again, I think that's true where it should help. But the idea is to use this data to spark a national conversation, to maybe we should be looking into this again. Again, I have tons of good data from the familiar of FIA study from the early 2000s, but I think this is a current data set that just reinforce the prevalence of this.
I have one more.
Please.
Just a little bit different. I'm not aneurysm, but my husband is a brain tumor survivor, and our son Trevor is aware that the testing is available, but chooses not to because at this point he doesn't want to know. So he does know that he can have genetic testing, but that's his preference, is not to at this point. Another question that I had, I didn't on Dr. Perosian's presentation this morning, he talked about collagen and Trinity states. I know with dwarfism, collagen plays a role in that as well, but are y'all also studying the role in collagen with because I understand you have 13 aneurysms, so I just kind of wonder if that's also in your studies as well.
It is, that's actually one of the genes that kind of comes up a lot in our networks, are a lot of the collagens. And also a lot of the known genetic risk factors are linked to collagen genes. So as we do the familial study, that's something we definitely want to focus on, is how prevalent are those collagen mutations in our aneurysm population.
And just to comment to that, big Korean study tying brain aneurysm with osteoporosis, that is another collagen. And there's no great study saying why in the world this is a 70, 80, 90% of the studies that we finished recently. This is a ladies' problem. Sacral brain aneurysm is a mostly female XX gene problem. So we don't know what that is. So probably has to do with collagen metabolism that is out there, especially with the female hormones and menopause. So fibromuscular dysplasia is another collagen problem that is more common in ladies. A female with cervical fibromuscular dysplasia is 4 times more prone for brain aneurysm. So there's a lot of ties that based on the collagen metabolism that you described.
I have a question for you. So, Dr. I think Dr. First was talking before about proteins inside. And I know that has a effect on the lining of the stomach and causes penetrations. Is something like that in the blood volume? Is that what causes the breakdown of the wall identifiable?
We haven't looked too much at proteins themselves, but the gene expression, so that is something we want to look at as more proteomics. We haven't done anything with the gut microbiome yet, so I can't fully speak on that, unfortunately.
I think when you talk to Johan about that, they have a lot of questions, not many answers, but this has been described before for heart disease, where they found bacteria, DNA, or proteins into atherosclerotic disease of the heart. But it's very intriguing that they find a high prevalence of those in brain aneurysms, and it ties spot on into cigarettes and poor dental hygiene. So I think it's more to be seen there. Yeah, go ahead.
Your thoughts or discussion about the findings translating to aneurysms in other parts of the body as well?
Yeah, so for our studies, we made sure we had imaging so that we could rule out whether there were any abdominal aortic aneurysms or aortic aneurysms in other parts of the body. So that's another study that we're hoping to conduct, is how sensitive is our panel to intracranial aneurysm, or is it just kind of picking up aneurysm processes in general? So that work is hopefully coming down the line.
James Mesquia, that was my former partner here at Mayo Clinic, does a lot of study in genetics of stroke, is a world expert in that. James found an association between abdominal aortic aneurysm and brain aneurysm. He's a study population. He published on that a while back.
There are a number of genes that we have found too that are also differentially expressed in like AAA. So there definitely is a common kind of pathogenesis behind them.
Another one that just for the abdominal aorta, that's more common in men. And men have a different type. So fusiform basilar aneurysms that we're gonna hear after the break from Dr. Catherine from Mount Sinai. Those are more common on the XY people. So fusiform, just like abdominal aorta, this fusiform basilar aneurysm, vasculopathy are more prevalent in Mayo, and maybe a correlation on the physiopathology. Any more for Dr. Popenberg, guys? If not, thank you, Karen. Before we break, I'd like to invite Dr. Sovajo to join me here. I know Dr. Lima had to go take care of patients in the hospital. Is number one for all of us. Wendy, are you around? You'll see Wendy. Dr. Naval is not here. Dr. Chimaisani is going to represent the critical care part of the family. If you don't mind joining us here. Every year, oh, here's Wendy. She was hiding. Morning, sir. So every year at the end of the conference, we honor somebody that our team talks about and brainstorm who's here with us that we should honor for work on awareness, innovation, anything related to cerebrovascular disease and brain aneurysm. And this year, because we don't want to torture her and him to be with us to the end of the 2 days on their busy schedule, we're going to do the Innovations Award ceremony right now. And it's my distinct honor to invite Olivia and Phil Hoblet to come to the podium to receive this award, and I'll let. Thank you. I don't need, I already told you guys the way I feel about this duo. I think this is in great hands, and it just honors what Olivia Phil through the Hoblet Foundation have done for Wolfson Baptist. I know Phil Aldana would like to be with us. He could not be here, but it is heartwarming to give this to you, Olivia, on behalf of the foundation. You guys are inspiration. It's very, very hard. I wouldn't be able to do it if it was my own child. So thank you.
Thank you so much for this, Dr. Hanel and the Baptist team, and to everyone. Again, we couldn't done it without the support of the community and the state leaders, Florida, and also a lot of our donors and sponsors, and especially our board of directors, right? So our board of directors do all the hard work. So we give all the kudos to them. We can't wait to share this, and to you, Dr. Hanel, We could not have done it without you, Dr. Aldana, the rest of your team. So thank you for all your hard work. What we're doing is very little. What you're doing is massive. So thank you.
That we go to the most anticipated time of the meeting, that is the break. Chris, at a time will come back. You have your program, I don't have that.
Right at 10?
10:15 or 10?
Yeah, 10:15.
10:15, guys.
Also, want to announce within your bags, you have the vendor cards. And as you go out and venture out to the vendor space as well, you'll gain a sticker, from then you'll be in a drawing at the end of the day for a minute. Thank you.
So I was like, right in that. Like, we started it, and I just like there. It's like, down about that.
What's your advice? All day on that.
But right around that time.
I was gonna feel the company, just all here. I saw Adam.
Are you doing? Something we want.
Save that phone.
Okay.
I don't have my glasses.
So.
Promoted this earlier. That's on the shores. I think it's voted, but I think you just gotta get it out. That's so fine.
Well, I was, I mean, cause I think I should.
More narrow.
And I feel like it's not gonna. Yeah.
Yeah, I appreciate it.
Yeah, and it's you guys, yes, the neuro. I've done Sits down on just like we're like, oh my God, I didn't know you could do this yet. How long did you get away? And why is there Play-Doh everywhere?
Yay, okay.
Yeah, get us a second here. I know, right? Yeah. Since I run it all, I know that. I'm like, I think that's, but they have, right? So they it's now totally just, I mean, it's actually unsexual. So now I'm like, basically.
Oui, bonjour, c'est à l'appareil. Je vous appelle, j'ai rajouté un patient au programme la semaine prochaine qui s'appelle Laurent Bernard. Pour mardi, ajouter le mardi au programme, à la suite du programme. Laurent Bernard et... Oui, c'est ça. Donc, elle est née le 6 août 1948. Et le 5 mardi. Et eux ont une troisième position. On a joué le statut.
Christina is the best, she's the best. Yes. Oh, yeah. Yours, that's five.
I was like, whoa. But I yeah.
My name is Gina, anyway, so, you know, it's really. You're all good. I was thinking over there.
Oh, hey, welcome. Thank you. I love the shirt. So when did you arrive? Where are you?
I mean, by the time we get to the budget, just so I'm just. That's one of my favorite things to do. I'm like to learn. Maybe that's about our. Pleasure.
Gotta do 2 months. So feel all done with the foundation, I'll never start on the foundation. Got all warned about that would develop.
Oui, oui, c'est un monsieur qui a un cavernome, oui, frontal. C'est au mois de mai. Oui, oui, voilà, si vous pouvez coupler les deux consultes.
Moi, j'ai prévu avec la
Si Christine peut le voir le même jour. Voilà, c'est un monsieur qui a un cavernome découvert de longue date. Il a saigné, il a des saignements chroniques itératifs. Et, il décrit des troubles cognitifs, des difficultés au travail, des troubles du langage, avec une évolution un peu paroxystique, des fluctuations, quoi. Donc, je suspecte chez lui des crises d'épilepsie partielle. Bon, ils lui ont fait un EEG en dehors des crises, etc., qui s'est avéré être normal. Il ne faut pas écarter des crises partielles, quoi, sur voilà, quand ça fait plus longtemps. L'EEG, c'est instantané, c'est le moment où on fait l'EEG, s'il n'y a pas de crise. Et il décrit aussi des difficultés, des troubles de la parole avec un manque de mots, une dysarthrie. Voilà. C'est parfait. C'est bon. Je t'ai envoyé les documents, là, tu les as vus? Tu veux les miens ou pas? Oui. Et celle de Bertrand, je peux te les envoyer. D'accord.
I like that. They would have a cold water in our house when we started getting tired, so then if we fell asleep, it would be like all they're gonna do, you know?
Des choses, ouais, il y en a pas mal. Hein.
Oh my God, like the various, you know,
Oh, il y a les deux. Hein. Il ne faut pas oublier, hein, comme ce que j'ai expliqué, une fois qu'un trauma crânien avec un scanner normal, ça veut dire pas de traumatisme crânien. Non, c'est pas vrai. D'ailleurs, là, exactement le même tableau. Je lui ai demandé de prendre rendez-vous. Monsieur, je l'ai vu dans une consultation. C'est un trauma crânien. Le gars, il est au travail. Il se prend un arbre. Il tombe, enfin, quelqu'un qui est en train d'élaguer, il se prend une grosse branche sur la tête et il part. Et il se prend un impact encore frontal sur le truc. Bon, perte de connaissance, il arrive aux urgences, il lui fait un scanner. Des lésions minimes, quoi. Pas grand-chose. Et bon, là, il s'en sort, hein, il n'y a pas de déficit, il n'a rien. Et physiquement, il est rien, mais il s'est fait les post-traumatiques, des troubles visuels bilan-ophtalmo normal. Il a des troubles visuels, une gêne visuelle, il a perdu l'odorat, il a des troubles de concentration, des troubles de mémoire. Voilà, un traumatisme en apparence banal, quoi, qui soit considéré comme bénin. Il a quand même un retentissement. Bon, je lui ai demandé de faire un bilan orthophonique et un bilan de neuropsy. Les secrétaires vont en parler. En plus, c'est un accident de travail. Là, c'est pareil, il a des lésions. En fait, voilà, c'est qu'une personne normale, pas trop âgée, qui travaille, etc., un trauma, il a quand même un retentissement. Imaginons quelqu'un âgé qui a déjà un capital neuronal, pas élevé, avec l'âge, on en perd beaucoup. Voilà. Derrière, ce qu'il a lui permet de vivre à peu près convenablement, mais le trauma crânien, ça lui flingue le truc, quoi. Il lui reste son capital qui lui reste, il est perturbé, c'est suite au traumatisme. Et boum,
But the flamingo was like the message, right?
Yeah, that's just like, if I put the file,
D'accord. Bah, ce gars-là, il relève justement de l'optique.
I read something about this team, like this uncle was kind of like that. And I'm like, I don't want these carriers. He's like, I'm not about this. Yeah, that's true.
That's the whole one.
Y'all are getting all
The most thing that you're not doing.
How are you? I'm Edgar. Nice to meet you.
No. I'm sorry, but I got.
Hey, listen, I didn't get to that final step, so you're already one. No.
Yeah,
So, I was in my own work, what the nurses saying is the work happening, she says, they were going to pay my friend is out lunching in class. Got a wrong. Right? So, maybe take. Yeah. So she asked me, how much property? I said, the word got around about that. People come from all over town, on the way home to restaurants with walking bags, whatever's left over. It's more city, like people drive through my driveway. I remember. Word got around about that. So eventually, one day I woke up, this was I got in my, I made it last year. I wrote the white city, I wrote the white city bar. And last year, that's all like better. And inviting everyone knew about that. I found you were two factors. Factor one. And the other factor was. So that's how much more like. So. Literally.
You smash your.
Oh, yeah.
I was like, I was all worried about this.
Oh, no, I know. It's like, it's a nail. I have a brand. So I wish I could.
I just, you went like that, and I was like.
No, that's where you hold the nail. I put one on the wall, I sit next to someone at the Delta blog and he was the one that the guy. I looked at the wall. It looks sorry, I think about it. I was a kid.
Yeah. It's the salt, but
I'm not breaking down for the reality. First thing, yeah. His name is Harlow. I know. He told me. He wrote the song. Celebrates. Oh, he wrote it. He didn't write the music, he wrote the words. And he was hanging out with someone and he picked up the words. He never got the words. But I thought that was. Yeah. I believe that. I know him, I know him. That's probably it. Yeah.
So,
yeah. Had two shorts. But the geography. I did. I chopped that down for a long time. That would be the last thing I played.
But I think they are excited.
Yeah. You always do. Cool.
Well, it's Friday. It's Friday. Is there a year? So how does work on Saturday where you're yeah, so it's me, Ben, and coming on Saturday.
Yeah,
it's only the two. And that's okay. It's a lot of people is in the second floor. But yeah. So we have. Yeah, we figured out how to borrow a part of the basement. No, we're using the one of the basement because it's ours and get destroyed. We have the plan.
Okay.
So we're coming on Saturday.
So.
That's what I was telling you.
Yes.
It's important.
Various. I gave them your business partner.
Yes, that's what I was like, oh my god, so I do it to with you and Chris and Eric. So, because we didn't go like. Research for work for like. Yeah, like for like one of those science jobs it was like, this is gonna be so like, oh my god, like it was so embarrassing for like 3 days, right? Yeah, like, oh, we were like spinning in circles. So. It was fun. But yeah, like half of us were talking and like so when I finally I remember like they talked to the captain group or whatever, like when they got behind it was like after that when I kind of like people ready to talk about that. Like they just like went to the bags and like the person that was bringing back. So that's where the girls. Oh yeah, I was like. Yeah, and they were like muscles I didn't think. Yes. No, because as soon as actually. Oh. So let's.
My friends are like thinking they're right at McDonald's on the beach, like walking back, you know, and I'm like, no, not living here. Not a good idea.
Actually, I couldn't start bracelets. I didn't work it, but I'm just figuring it out. I'm yeah, no, I'm not. I live on the Gulf Coast and that's what I say.
It's just so much prettier.
It's different. I like, and it's, I always watch you don't have or whatever. So this is a nice shape. That I always it's like hard to go there. It's like a lot of stuff like that. But again, everything's kind of sad. It's all good. Bought up by investors, like all the proper house. Oh, okay. Oh, and I know, yeah.
If I go full time, or do you guys make it? What would it take? Not what it takes.
I used to work for.
I'm in Jose,
You tried to add me, but then couldn't. I know. But it's nice. Well, I'm a high schooler in here too. It's not if there are any like hot spots. Good, how are you? It's great. It's good. Yeah. It's perfect. We were not that, but we were like, I don't know. But I was like, every year, like, at the end of the winter, I'm gonna like, I'm gonna pull up my yard, I'm gonna get all my weeds done, I'm gonna get all my pruning done. And I was like, so when did you have that last snap? I was like, okay, this is like divine intervention. This is my last hurrah. So I'm out there, like, get everything done. Yeah. And every summer, like some people, you know, everything's growing like crazy until the rain, and I'm like, what did you think? So did that, and I'm like, yeah. 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 No. I just signed up, so I'm gonna start next month,
Hey guys, welcome back. So we're gonna restart, a little change here in the program. Dr. Johnson Foy, one of our own Baptist physicians, we had a hiccup with that talk in the morning, but we're gonna go back to the program. She's gonna tell us what every primary care physician needs to know about brain aneurysm. Thank you.
So good morning. I'm glad for this hiccup. I normally wake you up. But this time I was moved to before lunch and now I don't have to be right before you and lunch, so I'm happy. And hopefully we're gonna have kind of an exciting little talk about the basics of aneurysm. So this is just going to take you a step back for a minute. I am a family physician here in Jacksonville who focuses in on all general health, but aneurysms definitely are one of those things that's important to primary care. So it's important for us to kind of really know how we should be approaching this. So I have no disclosures. And my goal will be to just kind of, again, start from the basics and help us do that initial thought process if you are seeing someone in your office and aneurysms is something that is a part of their history. So identifying the types, discussing epidemiology, and really clarifying the risk factors of aneurysms. So we live in a world where we have news about everybody all the time. So when it comes to health conditions and those people who are prominent figures in our community, we immediately are getting information. So a couple years ago, all of a sudden you saw a news report that said our No Way Home star Jamie Foxx was hospitalized after a mysterious medical emergency. Now there was a quick leak that said it might have been an aneurysm a couple years ago, so I mentioned it then, but it was never confirmed until Netflix paid him a whole bunch of the money to tell you that yes, that is exactly what was going on. Now, listening to the story, it was a little bit interesting and different based on the way it was told, but one of the things that if I was a listener who did not know anything about aneurysms, what I was hear is the doctors missed it, that they misdiagnosed me and I almost died, and it was because the doctors weren't paying attention and weren't doing the things that they were supposed to do. So my goal is to make sure that as you leave this room, you feel comfortable and sure on if a person presents with his types of symptoms, what you might need to be looking out for. There is some question about that story as they told it, so I'm not really sure he was misdiagnosed in the beginning, but I wasn't there. But these symptoms are things that usually you're gonna be able to pick up. And there have been lots of people who have been affected by aneurysms. This is Amelia Clark. Many of you know her as Daenerys Stormworm. So during the taping of Game of Thrones, she actually suffered 2 aneurysms and had 2 brain surgeries. And they were both nearly fatal, of course. She had her first subarachnoid hemorrhage at the age of 24 during its first season of Game of Thrones. So what is this beautiful thing that can cause so much concern and consternation? How has it hit so many of our beloved? Even here in Jacksonville, we had our Tilly Fowler, who was an up-and-coming congresswoman who many thought could have been on the rise to be that first female president long before Hillary Clinton. Well, she also died on March 2nd of a brain hemorrhage. The reason why we see so many people that we know on the screen being affected, because really it affects lots of us in the world. Brain aneurysms affect about 1 in 50 people. And 4 of those, 4 out of 10 people with a ruptured aneurysm die as a result of it. So it's important that we pay attention to this. So think about all the people you've met in your life. Even if you don't know anyone who died of an aneurysm, you likely have met someone who has one. This equates to about 1 to 3% of our population. When we look at subarachnoid hemorrhages, they account for about 80 to 85% of those non-traumatic subarachnoid hemorrhages. But autopsies suggest that maybe it's more than the 3% and closer to maybe 5%. Either way, 50 to 80% of all aneurysms do not rupture during the course of a person's lifetime, which is why they're found more on autopsy studies, not autopsies as a result of brain bleeds, but autopsies in relation to other things. They are more common in women, about 3 to 1 or 2 for a ratio of women to men. So again, making sure that we pay attention to our patients as they're coming in and we do appropriate risk assessments. When we look at those numbers I said earlier, that equates to somewhere between 6 to 15 million people in the US having a brain aneurysm, but 90% of them know nothing about it. They don't understand what an aneurysm is, and they only have maybe a tough reference or a little reference based on knowing that maybe someone young in their family died, but they don't really know because we didn't have the technology back then or even the conversations back then with each other to really understand that, no, my aunt died suddenly at 37 from an aneurysm. I was talking to my husband even, and he was telling me a story about his aunt, and the more I heard that story, I was like, are you sure she didn't have an aneurysm? And then he went and talked back to his family and was, oh yeah, they did say something about a brain bleed. So again, it's the conversations that people have, and we don't know until we ask them as clinicians. When it comes down to strokes, 13% of those are caused by an aneurysm, but their actual risk of rupture can be about 1% or less than half. So when you talk to your patients about aneurysms and you talk and you're thinking about it, framing it in the perspective of, although yes, this is something that happens, and if it happens, there is concern, but the screening part is important and your delivery to them about what their risks are, what types of things that we need to do to evaluate them can really allow your delivery about prognosis to be a different type of tone, because how you deliver it to them is how they end up living their life thinking about this aneurysm in their head. So let's take a step back to when we talk about aneurysm. I know we got a room full of brain surgeons and people who deal with brains all day, but we're gonna just review anatomy really quickly. As you know, the blood to the brain is supplied by the major blood vessels that are joined by the circle of Willis. You have that anterior cerebral artery, your posterior cerebral artery, your vascular arteries that come in and that internal carotid is going to the basilar, the posterior cerebral, and the anterior cerebral. So when we talk about an aneurysm, we're talking about a bulge or a balloon in this vascular structure that is a swelling due to a weakness in the wall. Now, the areas where that circle of Willis divide are going to be the places where things are most weak, just like with other things. That's the area where you're more likely to see these bulges. And that's because that's where hemodynamic forces are usually going to be greatest when they are bifurcating. And so you see these changes based on those different wall mechanics. There are several different types of aneurysms. You have your saccular aneurysm, your fusiform aneurysm, and your dissecting aneurysm. Now, two of those are the true aneurysms, and that's your saccular and fusiform. But then you have your false aneurysm or dissecting aneurysm, which doesn't actually involve the adventitia of the wall. When it comes to saccular aneurysms, these are usually several different causes. They can be degenerative changes that occur over time, developmental or traumatic. It can be related to certain infections or actually medications or drug use, like cocaine use, things that put a lot of vascular force onto our vessels. Most of our saccular aneurysms are going to occur at the anterior communicating artery bifurcation. And this is the most frequent cause of subarachnoid hemorrhages that are non-traumatic. It's a rupture of that saccular aneurysm at those sites. This just shows you that most common sites where those saccular aneurysms exist. And so it used to be thought that people were born with these, that you didn't have to worry about it if it wasn't something that was detected and that you had no say in the development of them. But what we've learned over time and study after studies have shown is that it is actually not just a congenital issue, that it is basically a development of an inherited weakness in that arterial wall. Now, there are some genetic conditions that are associated with the increase of aneurysm development, and we'll talk a little bit about that later. But most of these aneurysms likely result from those hemodynamic forces like blood pressure control, smoking, cholesterol, those basic things that as primary care providers, we are charged with making sure we help patients control every day. So if it is these risk factors that are your primary insults, then we actually have great opportunities to make a dent in those vascular changes that occur in these patients. So things that also can cause are those less common things like trauma, those big events that occur that, yes, can cause a rupture of the arteries, infection, tumors, and then, yes, there have been times when drug abuse, such as cocaine, has been related to the development of these saccular aneurysms as well. Other things like AV malformations and fistulas can be associated with it. Inherited risk includes things like alpha-1 antitrypsin. If you know, this is also associated with COPD development in people who are not smokers. So you have these changes in our tissues that occur because of these deficiencies. AV malformations, people who are born with coarctation of the aortas are also at higher risk of developing aneurysms, aorta stenosis, and if there's a history of aneurysm, then that puts you at risk. And we talked about that disconnect, that higher risk in women versus men. Fibromuscular dysplasia, which is also something that is more common than we realize, can be associated with aneurysm development. So if you have patients who you have incidentally found fibromuscular dysplasia on, then you want to make sure that you are also evaluating them for an aneurysm. Hereditary telangiectasias, Klinefelters, Newmans, PCKD is something that we see frequently. So again, opportunities to make sure that we're evaluating the right people. And then tubular sclerosis. Things that are going to affect aneurysm development that are acquired. Of course, the older you get, the same way things on the outside start to change and look a little different, the things on the inside are changing. So those strong vessels that we are born with and develop as we're younger start to get some wear and tear on them as we get older. So the older you are, the more likelihood of developing these aneurysms. Excessive alcohol consumption or binge drinking. So if you have those screening conversations with your patients about how much they are drinking, this can help to clarify if that is one risk factor or many. So you want to always talk to them about their binge drinking, atherosclerosis, cigarette smoking, illicit drug use, high blood pressure. Again, high blood pressure is one of those things that we can do. Some people are going to be more likely to develop, but there are so many lifestyle changes and things that occur that you actually are in more control of. So guiding them on these things that they actually may be able to do more about are things that are important. Infections, identifying them rapidly so that they don't have time to interfere with the vasculature. And then in trauma, we don't always have an opportunity to intervene, but it can help to make sure that, of course, if there's any head trauma, you're looking for those types of things. Helping people understand their risks, though, is key. That is what that conversation is about. You understanding the risk factors allows you to be a better advocate and a better manager of these patients who comes in with these types of conditions. As you talk to them, though, about risk, it's important to help clarify for them that risk does not necessarily mean that they'll absolutely develop these things. It is not an absolute cause and effect. So people who have more than one risk may be more likely, but it still doesn't mean that they're going to develop, or if they develop it, that they're going to have a rupture. Now, there have been a large meta-analysis done that look at genetic studies, which have identified a 19 single nucleotide polymorphism associated with some sporadic intracranial aneurysms. There's still a lot of research being done on that. There's strongest associations were found with chromosome 9 within the CDKN2B antisense inhibitor gene and chromosome 8. Now, why am I talking to you about chromosomes? Because everybody on TV is talking about chromosomes and how patients now have the ability for $150 to do a genetic screening and all types of things. So you have to be aware if they come to you and say, hey, this showed positive for the chromosome 8 NK2950 type of mutation, because now they have that information that they're bringing to you. So know that, yes, there are some genetic associations with it, but talking to them, just like we talked to them about the BRCA gene and other types of genetics, that something showing up doesn't, again, necessarily mean that you're going to develop a certain condition, and that you have to be aware that, yes, you have a higher risk, but this is how you live your life. Control the factors that you can. Many studies have looked at patients who have aneurysms and where aneurysms have been found, and try to clarify further patients' risk and the likelihood of rupture. So that's what everybody wants to know. I have this, you're telling me I have it. Now that we found it, what's the likelihood that I'm going to rupture? Well, there are several scores that we use to clarify for patients their likelihood of rupture over time, or to clarify for us what their likelihood of rupture is over time. So we have three major ones. The phase score is where we do a 5-year estimate of 5-year rupture risk in aneurysms. We look at things like their ancestry. So people who are Finnish or Japanese ancestry have higher risk scores, hypertension, age, size of aneurysm. If they had an earlier rupture from a subarachnoid hemorrhage, and again, where that hemorrhage is. So each of those different risk factors are assigned a score, and then you add them all up. And that gives you what that percentage risk of rupture is over the next 5 years. So it's a very helpful tool in trying to clarify for yourself and your patients what exactly their risk of rupture is over time. So if they have a score greater than 12, then that is going to put them on the high end of almost a 20% risk of rupture in 5 years. So those people you want to make sure you have hands on, and that they're mitigating any of those lifestyle changes and any of those acquired risks that they can control. The ELAPSE score is also a helpful tool that assesses the risk of aneurysm growth over 3 to 5 years, and then that increased growth is associated with rupture. So they again look at when did they have a previous hemorrhage, where the aneurysm is located, age, population, aneurysm size, and shape. Again, they assign points based on the those different attributes, and the higher the score, the more likelihood of potential growth and rupture. A new growth score, however, is a simple scoring system that has been looked at and thought to be actually a better way to understand the growth and potential risk of aneurysms long-term. And that is just looking at if they're a woman, if they smoke cigarettes, if their age is less than 40, then they're using that to predict the growth of what we should be doing for these patients long-term. So those are your scores that, because we live in an age of EHRs, we should be able to have them built into our systems better. So institutions that have great neurovascular systems should have their primary care docs actually being able to calculate this more easily. So that's something that you guys can help us advocate for at Baptist, to be able to make sure we're screening those patients that we need to get to you guys the right way. PCKD, polycystic kidney disease, AV malformations, and fibromuscular dysplasia are easy things for us to be able to catch and diagnose frequently. And these are people who you have great opportunity to really look at and clarify for them that they have higher risk, and to do those interventions and screenings that are going to be important. Now, the scariest thing for patients when they come in to talk to you, if they bring up the conversation, is it usually has happened to somebody they know. And they're even more worried if that someone they know is a family member. So for us, helping them understand that family risk is not necessarily a guarantee that they are going to develop it, and then using those scores and doing the proper screening, if there are people who need to be screened, then you're able to give them the reassurance they need as they continue to walk this life. That even though they may have it, the risk of rupture is still very low. So the guidelines say the people who should be screening are people who have 2 immediate relatives with intracranial aneurysms. If there is 1 person in their family, then there's a 4% risk, so still very low. If there are 2 people in their family who have had aneurysms, then there's an 8 to 10% risk. All patients who are autosomal dominant, though, with polycystic kidney disease, their risk is up to 40%. So way higher than just someone who has actually had an aneurysm. So again, pointing the light on why it's so important to screen these patients. We talked about people being contacted all the time about genetic screenings. And so they may not come to you about a risk of aneurysm. They may come to you about the fact that they've shown positive for PCKD disease. They may have never had high blood pressure, don't go to the doctor often, are managing their their health through Google in their home. And so now you get pulled in because they've done a genetic screening. So again, be prepared to be able to talk to these patients about the likelihood of their risk, and then do appropriate screening is necessary. There are some doctors who are offended by the patients being, I'm going to use the word advocates for themselves in a way, because if they are taking the time to go do some stuff, although some of them, again, are only guiding their own health, them taking the time to come into you is now saying they trust you enough to help them the rest of the way. So don't be offended if there's misinformation, if there's things that they are not right about, then help them understand what their true risk is. You have an opportunity to be calming, reassuring, or to be on alert and help them understand, okay, you have not been coming into the doctor, now you need to. So look at it as an opportunity and not an assault on our medical professions. Now, one of the things that is very controversial about aneurysms is the use of anticoagulants. Many retrospective studies, though, suggest that the rupture risk is reduced in patients taking aspirin. Now, of course, there are other risks, and people who have an aneurysm that ruptures and they're on blood thinners, that can be devastating and detrimental. But when you look at it, although it may seem counterintuitive, people who are taking aspirin are actually at less. It's been studied and shows that they're at less risk of rupture. Look at your demographic of patients and know who you're talking with. This is, again, about risk factors. People of color, and so Black women, are 2 times as likely to rupture. It is the rupture that is the biggest concern. So you want to make sure you stay diligent on helping these patients understand what they need to be worried about. Because again, most aneurysms are silent, but there are times when they are going to speak to us. And there are certain things that if a patient presents, we should not ignore. So those symptoms that are there, just to go back, I can't read all those for you, so I'm just gonna highlight the big ones. But I did put this in here because if you want to really take a look, and I know everybody has the ability to Google it, but those aneurysm symptoms that are suggestive of rupture versus leaking versus unruptured are a little bit different. The ones though that you need to be concerned about, you were taught, it's the worst headache of my life, and so you know you need to first and foremost look for that. Seizures, sometimes people don't present with a headache because they just have a seizure. And that could be a slow rupture that has occurred and they're leaking into the brain that has set off those neurological firing, and so they'll come with seizures. Light sensitivity. Now, it may seem like, well, this person is just complaining that their eyes, we live in Florida, everybody's kind of sensitive to the sun, put some shades on. That is not how you want to approach, because if someone comes to talk to you about light sensitivity, then that means it's something different and something that is a change for them, because most people aren't going to talk to you about that, right? So you want to make sure that you pay attention and ask those other questions about headaches and dizziness. Double vision is something where they'll complain, or even just blurred vision. Again, these are those subtle signs that the aneurysm is something of a greater concern. Facial pain, they may say, all of a sudden I'm getting these stabbing pains across my face. Those again are signs that you want to pay attention to. Don't just think something's going on with their TMJ or their ear. Don't be dismissive. Do a thorough history so that you'll know what you're dealing with. Sometimes you'll have someone who presents to the ER and they actually have a small embolic stroke, and it's not thought of where it might have come from, but this also just could be an aneurysm thrombus. So we want to make sure that if you're working in the ER that you're looking at all of these things. The visual field defects and deficits, so if they come from you to from the eye doctor and say that these are things that the eye doctor have mentioned to them, then we should be looking further. TIAs, dilated pupils. Again, the idea is to avoid misdiagnosis. One scan can save a person's life. So what scan do you do? The CTA, MRA are very common and easy for primary care doctors to do, but the gold standard is going to be angiography using digital subtraction angiography. And that's just the type of, when they're looking at you guys probably know this better than me, but it's still an angiogram, but they kind of remove all the background noise so you can see just that anatomy of the aneurysm, and that allows them to be able to truly see what's going on when it comes to the brains of these patients. They are very accurate in diagnosing. It's about 90% accuracy. And so again, getting them properly guided to the team that can take care of them is going to be important. An MRA has a sensitivity of about 70 to 99%, but a specificity of 100% if the aneurysms are greater than 3 millimeters. So again, under 3 millimeters though, you can have it as low as a 40% type of sensitivity. So monitoring these patients is going to be important. Again, you're in a place where we have wonderful neurosurgeons, so you'll be able to refer when needed. Once it has been determined that they have an aneurysm, the management is going to be important. The neurosurgeons are going to be there for them. However, you're going to see them more often. And so patients who are over the age of 60 and have small aneurysms, unless there's a big, strong family history, it is still recommended that conservative management be how we're guided. And by conservative management, again, controlling those things that we can control. Now, if a patient's aneurysm is 7 to 12 millimeters in diameter, that's going to be guided by your neurosurgeons, and they will determine what is next. If a patient is over 60 with aneurysms and is greater than 12 millimeters, usually some type of interventional procedure is going to be considered. conservative management, like I said, control if they're a smoker, tell them to quit. Making sure that their blood pressure is controlled, that they minimize alcohol use, and that the proper screenings are done at the appropriate intervals, usually every year for about 3 years, and then several further occasions at reduced frequency if you determine that it's stable. And you guys probably had great talks on coiling and clipping and all of the other great interventions that are there now. I'm moving fast because again, lunch is coming. So when we look at these studies of treatment and how you should be managing these unruptured aneurysms, the biggest part of taking care of patients with aneurysms is the reassurance. So if you walk out of here today and you are a primary care provider, of all the things that I have taught you, I want you to know how to reassure patients, how to remove the doubt and fears of someone who thinks they have a ticking bomb in their head. Put their minds at rest by dispelling some of the fears, helping them understand what their true risk of rupture is. Help them understand that they can walk through life in the same way that they have been, but now they know that they need to follow up appropriately. There are lots of support groups and education opportunities that are available for these patients. So connect them with the proper places and people. Even if you say, go do a Google search on aneurysm support groups, you have given them some guidance, but take the time, look them in their eyes and ask them, are you comfortable walking out of here? Look them in their eye. If you feel the dis-ease in them, then take a few more minutes and take that little extra time to give them better reassurance, because you can point to the fact that survivorship is real and they will live to tell about it. Thank you. I appreciate this opportunity. Any questions?
Just, you gotta put it closer.
Okay,
There we go.
okay, thank you for your talk. So my question is, in the primary care setting, and these patients who have either a strong family history or the polycystic kidney disease, are you able to get insurance carriers to cover getting a screening CT, angiogram, or MRI?
Typically I am. It's one of those things that, this is kind of the one you fight for. It's if I am getting a lot of pushback from insurance companies, you know, I explain to them how the death will be on their hands. And so that oftentimes will help, but and the reality is, completely, I'll take the time to do the peer-to-peer and then make the doctor on the other side feel real bad about, hey, this patient had 2 family members, you shouldn't be giving me a hard time, I shouldn't be arguing with you about this, if it comes to that. But most of the time, you know, if there's a little subtle dizziness or headache or something, I'm listing it all and we're usually able to get it covered.
Okay, great, thank you.
You're welcome. Well, thank you guys, I appreciate it.
Thank you. So our next speaker is Dr. Travis Captain from Mount Sinai, New York. Very exciting medical treatment for brain aneurysms. So TNF alpha in aneurysm formation, rupture, and TNF alpha blockage for treatment of high risk aneurysms. Thank you, Travis, for making time and sharing your brilliant work with us.
Thank you so much, Chris, to be able to share this discussion here. Chris?
You're on. You're on.
Okay. All right, so you hear me?
Yes, can you make full screen for us, Travis? Thank you.
How's that?
Awesome, perfect.
Okay. Hey, thank you so much. I'm very sad that I can't be there, you know, in person. Things changed in my schedule But I'm honored to be here, and to talk about, this topic, which I think is a really interesting, one, and one that, we in the neurosurgery and intervention can encounter, which is, dolichoectatic aneurysms, typically of the posterior circulation. So what I'll do is kind of set the stage, talk about these aneurysms a little bit, and present sort of a different framework, a philosophy of, how we might, treat them in the future. So I don't have any disclosures or conflicts. So dolichoectatic vertebral-basal aneurysms is a mouthful. These aneurysms are fusiform dilations, typically of the vertebrovascular artery. We in the field know that these are among the most challenging types of aneurysms that we encounter. I love this quote. This is from Michael Lawton, one of the most experienced vascular neurosurgeons of this generation. He described it as akin to glioblastoma for tumor neurosurgeons. These aneurysms have a complex underlying biology. The cures are elusive, and the fight will involve conventional teams of scientists. I think that really summarizes very well the challenge that these aneurysms present to us in neurosurgery and intervention. This is the typical dolichoectatic vertebral-basal aneurysm. You can see on this MRA, it's compressing the brainstem. We know this type of aneurysm can really cause morbidity through a number of mechanisms. Some patients will present with progressive cranial nerve palsy. They can lose the ability to swallow. They can lose the ability to breathe on their own. They can develop hydrocephalus. They can develop recurrent ischemic strokes. And of course, they can rupture, right? And that can often be fatal. So my mentor in fellowship thought of these, with a different perspective. We have these challenging aneurysms, and we have to start thinking outside the box. And this is Dan Cook's sort of outside the box thinking is what I'll sort of summarize here in this talk. But instead of thinking of dolichoectatic aneurysms, the way we think of them as just bubbles that we fill or we block to prevent rupture. Maybe we should be thinking them as a chronic disease, something that we should try to modify the natural history, and maybe non-invasively, maybe through medical treatment, right? If such a philosophy, were to work and be effective, there are several things you would want to have for this hypothetical treatment model. One would be that we don't have a good existing treatment, and I'll show with some data that I think that's the case for this type of aneurysm. We should have a good understanding of the biology of the aneurysm and a target, right? A target that we can actually intervene on biologically. Whatever we use to treat the aneurysm medically, we should have knowledge that it's a safe treatment, something that could be tolerated over a bigger fraction of patient lifetime, not 6 months, a year, but maybe 5 years, 10 years, 20 years. And we need to have something that we can follow, right? If we're not going to obliterate the aneurysm, RR1, coiling or clipping, we need to be able to follow something to show that the treatment is having an effect. And finally, the thing that we're following, the biomarker that we're following, should be biologically, and clinically, we're making a difference on the clinical outcome for the patient. So when it comes to this type of an aneurysm, which typically presents in middle age and carries a very high annualized rate of mortality, much higher than most other types of aneurysm or AVM or even arteriovenous fistulae. The key biomarker is growth. When these aneurysms grow, we know from natural history studies that patients are more likely to have ischemic strokes. Not everyone is in that category, so people have stable aneurysms. But of the fraction of patients who do show progression, and by progression I mean growth, they do much worse, right? So if you look at patients who progress in size, their chances of remaining asymptomatic diminish really, really rapidly. So really, the key here is that growth is the key sort of imaging biomarker for these lesions. Over the decades, a wide range of treatment strategies have been employed using the tools in our toolkit, right? Open neurosurgery and endovascular treatments. These range from complex stage bypasses, takedowns, stents, stent coiling. All of them don't seem to work very well in the long run. When you look at aggregate data, the quote unquote good outcomes are not great, right? In surgical and endovascular treatment arms. Patients don't tend to do good by the definition of good, meaning not dead or significantly worse after an arbitrary time period. So we have poor data, but the data we have is not effective, that these treatments aren't effective. Endovascular treatment, specifically flow diversion, has been studied more recently, and even in cases where it seems to work, many patients go on to progress, and of the patients who continue to progress, many of them die, right? So we're not seeing that long-term benefit in flow diversion. When you look at strictly periprocedural complication rates, they're not stricken, right? The treatments carry in themselves substantial morbidity, and the outcome that has been used in our meta-analyses is angiographic outcome, which seems to be better. What I'll argue later in the talk is that may not be the best biomarker. So the point here is that we have a lot of heterogeneous treatment strategies, but none of them seem to work very well in this particular type of aneurysm. One I think that deserves additional attention is flow diversion. Flow diversion is using a stent with a very small pore size to try to remodel the artery in order for flow diversion to work, and it works quite well in many types of aneurysm. It has to do three things. It has to physically redirect the blood. It has to promote neoangiogenesis neoendothelialization along the stent, and then after that has taken place, the hemodynamic remodeling has to be favorable. In the very limited data we have in philipotatic aneurysms, has very interesting findings, which is that despite sometimes a very nice looking radiographic result that you can see in panels A and B, when they look on autopsy, histopathology, you don't see neoendothelialization across the aneurysmal segment of the artery. You might see it in the healthy parent artery, but it's absent over the aneurysmal segment. And what that means is that of the principles of flow diversion, you're really not achieving all three of those principles with flow diversion the way you would in, say, an ophthalmic and saccular aneurysm. Another question is, we might see changes in flow with something like a flow diverter, but is that beneficial? We're still not really understanding how these aneurysms behave and grow, but it's very clear that hemodynamics play an important role. And what's interesting is that if you model these aneurysms, you look at where they tend to enlarge, like what segments of the aneurysm tend to enlarge. Those tend to be areas where the flow is slow, there's low wall shear stress, and the flow is complex. There's vortices and oscillatory fluctuation. It's believed that this type of hostile flow, promotes greater inflammation in the aneurysm wall and further degeneration of the aneurysm wall and further growth. What's a key finding from that is that, and this is from the conclusion of this paper, is that seeing stagnant or turbulent flow may actually be paradoxically a negative biomarker. We look for stagnation of flow in saccular aneurysms. In these types of aneurysms, if we see that kind of flow, it may actually be promoting more hostile inflammation and growth. And this is borne out by the aneurysms that grow despite flow diversion. When you go from hemodynamics to on a cellular biologic level, what's happening, this is sort of the gold standard study from Japan about 20 years ago. They identified 4 steps that happen in the formation of these fusiform photocatatic aneurysms. The first step is always disruption of the internal elastic lamina. You then get angiogenesis, hemorrhage within the wall of the aneurysm, and then some sort of cyclic inflammation and positive feedback loop that leads to further wall degeneration and growth. The key observation of this study is not that, it's that it can occur in the absence of atherosclerotic plaque. Historically, we think of this as a disease of people with atherosclerotic risk factors, but in many cases, these patients actually don't have plaque or histopathology in their aneurysm. So this happens independent of atherosclerosis. It may be related or it may be exacerbated, but it is a different process. And I think the lesson from this type of study is that this is not the same thing as a spinal athero. It should be reframed in our minds, not as an atherosclerotic disease, but as a disease of the vessel wall, a disease of inflammation of connective tissue. So to try to contextualize this, we look outside of the brain, and I try to find some analogous types of disease in other parts of the body that are better studied. So coronary artery aneurysm is one of them. They're a very interesting disease, right? They're not rare, they're not common, but they're more well studied than what we're talking about. Interestingly, in coronary aneurysms. Afro is also absent in about half of cases. About a third of the patients have some sort of systemic inflammatory disease, indicating the role of inflammation. And if you look at them on a histopathologic level, they look pretty similar, right? They have the same sort of elastic lamina degeneration. So these may be related sister lesions in the heart to what we're seeing in the brain. Another parallel I think we should draw is to abdominal aortic aneurysm, of course, because this is the most well-studied, right? This is very common. In fact, it's been shown that people with abdominal aortic aneurysms are more likely to have bulloco-hepatic aneurysms in the brain. So there's likely a epigenetic relationship between the two lesions. These again, they're a disease of vessel wall inflammation. So why do I bring up these sister diseases? Well, I think we can try to learn from them a little bit. In abdominal aortic aneurysm has had the most research. Right? People have been studying animal models for a long time. So much so, in fact, that there's actually been a number of clinical trials of non-surgical disease-modifying medical therapy in this condition. Things ranging from doxycycline to cyclosporin, metformin. You know, unfortunately, in the studies that have been done, these have not shown a meaningful benefit. Even though in the lab, in the rat model, you know, you can show it. In humans, we have not seen the benefit. In coronary aneurysms, similarly, people have advanced the human studies of disease-modifying agents. But there's one study, at least, that is positive, right? That's an infliximab for TNF-alpha inhibition. So this is a prospective placebo-controlled study in children with Kawasaki's disease. And what they found is that infliximab in this very narrow population is associated with more rapid regression of coronary aneurysms. There's at least some data that this actually works in practice in this particular circumstance. So you know why TNF-alpha? Well, TNF-alpha is known to play a role in aneurysm inflammation and aneurysm growth. As I mentioned before, it's very well studied in animal models that we can upregulate or downregulate TNF-alpha signaling, and it has a very tight relationship to the tendency to form aneurysms in aneurysm models in animals. And in humans, in select case series and case reports, there are descriptions of aneurysms that have regressed or resolved with infliximab therapy in a few inflammatory conditions, such as polyarteritis or Behçet's. This is an example of a pulmonary artery aneurysm in Behçet's that resolved after infliximab therapy. So, okay, infliximab, you know, may be beneficial in these oddball cases outside of the brain. We don't really know what's happening in bulloco-hepatic aneurysms. The only really study we have of the endothelium of these aneurysms is from my mentors at UCSF. They did what's called a Neurosurgery cell sampling of a patient with polyarteritis nodosa and a large Cerebrovascular aneurysm. And what they did was compare the endothelial cells they extracted in vivo from the aneurysm to the common femoral organ, like a control. And what they find is that in the aneurysm, there's a number of pathways, gene expression pathways that are dysregulated, and one of them is TNF-alpha. Right, so this is like the first in human demonstration that TNF-alpha signaling is disrupted in these aneurysms. Okay, so maybe we're building a story that suggests that this is a reasonable, you know, treatment approach. We have something we can use, and infliximab, which I described a little bit before, it turns out it's actually a pretty safe medication. It's been around for almost 30 years in widespread clinical use, and it's been used for long periods of time with very low risks of drug-related adverse events. And that's really important with this sort of paradigm of disease modification. You need something that's safe, not over 6 months, but over 6 years, 10 years, 15 years. You really want to make a difference in the progression of the disease. So among immunomodulating drugs, it's not perfect, but it's generally considered very low risk. So in fellowship, we did sort of a proof of concept study, what I would call a natural experiment of this. This is where we didn't intervene, but we looked at patients we were following through a different lens. And this involved 5 patients. All of them had symptomatic bulloco-hepatic aneurysms. All of them were on max medical therapy, as we define it. 2 of these patients happened to have rheumatoid arthritis, and they were being treated or considered with treatment for infliximab for their rheumatoid arthritis. They said, well, let's watch them compared with the other patients and see how the aneurysms behave over time. They're not intervening here, they just are incidentally being on infliximab for another reason. We follow patients for a number of years. We looked at things like neurologic events, clinical outcomes, and drug-related side effects. When you look at the control aneurysms, they look pretty much like the natural history of the disease. They have pretty rapid but variable growth rates, and the patients all did poorly. 2 of them died, and 1 became significantly disabled from progressive cranial neuropathy. The other 2 patients who were on infliximab, again, for the rheumatoid arthritis, had a very different progression over the years. We see that there were no changes in clinical status, no neurologic events, and there were no side effects of the medication. But perhaps most interestingly was the patient in red here, who started infliximab after about 3 years of observation. And what we saw is that the growth rate before and after infliximab was started, again, this is of the dolichotic aneurysm, the growth rate actually plateaued and reversed. It's not to say the aneurysm shrunk, but the rate of growth diminished and actually slowed around the time the infliximab was started. And this is another way to sort of visualize that, but what we're seeing is sort of a plateauing of the aneurysm around the time of the drug initiation. And the patient who was on infliximab long-term had a very flat, low-growth state. If you can keep patients in a flat, low-growth state or plateau their growth, you can theoretically have a great impact on their long-term outcomes. So to kind of wrap up, the rationale here for disease-modifying treatment of dolichotic aneurysms. We don't have good current treatments for these lesions. We can't think of them the way we think of saccular aneurysms. The risks of surgery and endovascular treatment are high. The outcomes are very uncertain. And things we use for other aneurysms, like angiographic appearance, may actually be misleading at best in this condition. We may actually be creating more hostile flow conditions inadvertently. We have a semi-reasonable biologically informed approach. TNF-alpha seems to be involved in the pathogenesis of these aneurysms. It's druggable. We've studied it in other aneurysm model systems elsewhere in the body. The treatment itself is, at least preliminarily, seems to be very safe, and it certainly appears that way in other conditions. And we have a biomarker, right? We can follow the aneurysm size over time and measure that reproducibly to show the effect of the drug. That's what our preliminary studies sort of imply. And the most important is that if we can plateau the growth or slow down the growth over time, we think, based on natural history studies, that that should reduce the risk of adverse events in these patients. So, stepping 10 years in the future, what you might have is a different paradigm for this type of aneurysm. You might have the patient who presents late in extremis with debilitating neurologic symptoms or rupture. There's always going to be a role for salvage intervention in these patients, right? You have to save a patient who is dying or in extremis from this condition. On the other extreme, you might have someone who's detected incidentally through, like the last speaker mentioned, something like screening. If you can start treating the patient early, you may keep them at a level of growth where it's stalled to the point where they never reach a level of symptomatic presentation. Of course, that would be ideal. And then you have the in-between patients, right, where you can maybe modify the course of the disease to a certain point, and maybe the progression happens later and requires some sort of surgical intervention, but you may still be able to buy that patient extra time of event-free years, and that's very meaningful in a condition like this. So I want to thank all my mentors at Sinai and UCSF and Dr. Hanel for inviting me again. I'm very sad that I can't be there in person, but very grateful for the opportunity. Happy to take any questions.
Any questions, guys, for Travis? Phenomenal work, man. I naturally have seen this before, but every time I watch it, this is very inspiring, and I don't have something better than flow diverters or high flow bypass for these poor people. Neither works.
I think that's what we're seeing. It's gonna take a long time, right? This is a long game. And it'll take a lot of inertia to overcome, but, you know, I think anything that we can do, to change the natural history will be meaningful.
Crowd is pretty silent today.
It's almost lunchtime.
Dr. Chimaisani.
Thank you for the talk. I have a question. How feasible to give this treatment because of insurance, or is it only part of the, and when you started, believe the engine is growing?
So, yeah, it's a very, very good question. So we haven't, we're in the process, you know, my mentor of trying to get, you know, Kindle interest, right? Right now, the only evidence we have is the sort of anecdotal observation. But I think that if we can show with enough index cases, that we have some effect and no harm, then we'll get into the point where we can do these small trials. But right now, this is a ways off from being something that's going to be, you know, in the mainstream in the clinic. But I think if you have patients and you're interested in, you know, discussion of this, you know, myself or Dan at UCSF, you know, we can keep everyone updated on the progress of this. We'll be slow because it's a very different strategy. But right now we don't have enough data to, you know, support this in real-time practice.
So Travis, just segueing what you said, do you have a protocol with IRB that we could tag along and copy that here and back? Because again, we see some of these patients, and as you said, most of them, again, unfortunately, AJ Waterloo is not here today, but from the Stuttgart paper on this doliprane, they propose, they see that the worse the patient, the worse that they do a treatment, so they propose early treatment. I'm not sure if we share that belief, that you do a full metal jacket if somebody has no symptoms. So that'll be great to share protocol and get that.
Yeah.
Do you guys have anything active ongoing with this?
I'd have to get I will circle back with you on that. I have to see where we stand. What we wanted to do was at least to share this is a very initial experience to start the discussion with the FDA and stuff like that before starting an IRB. I can update you on that. I have to talk to Dan and see how far he's gotten so far.
Perfect. Would love to collaborate if there's an opportunity.
Good thing.
Thank you, man. Anybody else? Thank you, Travis, for your time, man.
Thank you again. Sorry, I can't read that. See you.
Really good. Thank you. We're switching lanes, and the next session is kind of a small round table panel. This is Ramesh here. Oh. 10-year anniversary of Dr. Grundy's graduation, so we have the honor of having him back. Ramesh Grundy and Rick Williams were brave enough to say yes to the first fellows at Baptist with Eric and I in 2014. And Ramesh Grundy is now the head of Cerebrovascular at the University of Utah. So Ramesh is going to share with us 30,000 feet a view of this very hot topic that is embolization for chronic subdural hematomas, embolization of medial artery. We also have here Professor Peter Kahn, the chairman of UT Gulf. So Peter is going to share with us a clinical trial that we started recently that Dr. Neiman enrolled the first patient last week or earlier this week. So they're both going to talk, and I think 4 of us in the whole room, and we're going to discuss where you see this fit. And thank you, Ramesh and Peter, for being here. Honor to have you guys.
Thank you. This is a great topic, segueing from a disease state that's very rare to a disease state that is not particularly rare. And you know, reflecting on this, I now come from the youngest state in the country. Utah is the youngest state in the United States. And Florida isn't. We have to be honest about that. And how do we tailor make solutions to a population that is, particularly the geriatric age population that is a huge component of the Floridian population. And it's very important for us to be very honest and reflective of how we can offer better solutions. So before I get going too much, I just wanted to take a moment for pause and reflection. And this was 10 years ago. I was adding some slides this morning and looked at a presentation that I gave on May 29th, 2015, and took these slides. And I just want to say thanks to everyone here for all that they gave to me over the years. It was a great team, and this again was taken from my graduation slide deck. Some of the members of this team are here in different capacities, but it was a really meaningful 1 year, and then we got the band back together last night with Nima, who I've known since we were in Pittsburgh together. So without further ado, we'll talk a little bit about middle meningeal artery embolization, and I'll present it through the perspective of a patient. So hopefully the video will come. So this is an 81-year-old guy who presents after feeling unsteady and off. He had head fullness, and he had a head bonk in his shower 5 weeks prior, and his medications were written there. Overall, he was doing quite well, but with a slight pronator drift on the right, and he was 5 out of 5 strength, but he did have some gait issues. So he was taken for surgery at an outside hospital by an outside doctor. And he does a great surgery. He does burr holes bilaterally, leaves subdural drains, just like we would do. And then 11 days later, he goes back to that hospital, to that doctor with reworsening of gait. And here you can clearly see that he's reaccumulated his subdural hematomas. And then he undergoes his second surgery. And this time they only evacuate the left side. And then he comes back into that doctor's clinic for follow-up, and he feels well, but he's starting to feel unsteady. And I think you guys know where this is going. So he's reaccumulating yet again. So what do we do for this guy? The options are surgical, obviously redo burr holes. Another option is to take him for a craniotomy and coagulate the individual membranes that are involved in this process, or come up with or use or employ an endovascular solution to this problem. And that's middle meningeal artery embolization, and it can be used as a surgical rescue. Here's a different patient. This is an 82-year-old guy. He came into our hospital with headache, fatigue, and brain fog. And as you can see there on the right panels, but on the left side of the head, he's got a non-acute or chronic subdural hematoma. This guy fell while vacationing in Southern California, and those are his medicines written there. And similarly, he has right-sided drift and a decently life-affecting headache. And this guy, I still remember to this day, he's on the board of like 5 companies. He is a mover and a shaker, and he's 82, and he's still very active. So what do we do for this guy? Leave him with his headache? Leave him with his pronator drip? So the options are, again, surgery. But what is the indication for surgery? He's doing really well. He doesn't have much in the way of symptoms for this. Observation is obviously another potential option, but what is the likelihood of this patient eventually needing surgery? And it's important to put into perspective, how's the patient going to manage his symptoms? Finally, of course, this is a patient that we could consider for endovascular middle meningeal artery embolization as a primary treatment. So we talked about before as surgical adjunct, but this is a patient that we would consider doing for primary treatment without surgery. We know that the pathophysiology of chronic subdural hematoma is driven by these subdural membranes. So that for those of us who go to the operating room or see this in the operating room, what you do is when you open the dura, you can clearly see that this is a very kind of interesting inflammatory process in which the subdural hematoma is actually liquid, but it's contained by an inner membrane and an outer membrane. And there's a lot of cyclical inflammation, membrane formation, and angiogenesis with something called fibrinolysis. So this is a vicious pathway that develops. Conventional surgery has a surgical re-intervention rate. I still remember when I was here 10 years ago, I had a patient when I took a general call for a night or two who came in with a chronic subdural hematoma. And the problem was we did the evacuation. I thought I did a good job. And then it came back 3 days later or 4 days later, it got worse and we had to take him back. And we had another, he actually needed a second operation after that. So it's really a problem. And the risk factors for post-surgical recurrence are written there. But a lot of these risk factors are endemic to a geriatric age population. So we have to recognize that many of the risk factors for surgical recurrence are also risk factors themselves, such as old age. So when we think of middle meningeal artery embolization, we need to think of what the middle meningeal artery acts like in this disease state. We know that the underlying membrane underneath the dura, where the middle meningeal artery travels through, parasitizes blood from the middle meningeal artery. So we can see this on angiography. So the top panel shows us when you do an angiogram, you see this on, like it's described as a cotton wool type phenomenon in which the middle meningeal artery supplies the membranous blush blood. And we also know that there's diffuse dilation in the ipsilateral middle meningeal artery on the side of these chronic subdural hematomas. And this was described actually a long time ago. This was the first case report in which they described this 25 years ago of how to perform a middle meningeal artery embolization in a person with cirrhosis and thrombocytopenia. So it was actually described 25 years ago, and now we certainly have started to do it much more commonly. So the advantages of middle meningeal artery embolization is, of course, you're targeting the underlying pathophysiology. When we do chronic subdural hematoma evacuations, you're just removing the blood, you're removing the byproduct, and potentially, when we think along the lines of middle meningeal artery embolization, we have to think that we're actually treating the underlying pathophysiology. There's a lot of advantages of middle meningeal artery embolization written there. Shorter procedure times, you can do it under local anesthesia. You're not cutting the patient open, so there's a decreased infection risk. The disadvantages clearly are it doesn't address mass effect, and the treatment effect does occur over the span of 2 to 4 weeks. So this patient, whose CT scan is shown here, is not a candidate for primary middle meningeal artery embolization. In fact, for this patient, it would be considered as an adjunctive treatment. Multiple MMA embolization retrospective studies have demonstrated safety and efficacy. And I have to say, I'm really thankful to Peter. Peter and I have known each other for since I was here. And he's been a real thought leader in this space, getting us together, writing papers on this disease state. So this paper on the right, the series of 154 embolizations, was something that Peter put together with multiple institutions, inclusive of ours in Utah. And it's something that also works great for patients who are at advanced elderly. We talk about geriatric age patients, and we talk about early elderly and advanced elderly. And what we realize is that patients who are 80 plus, 85 plus can readily undergo this procedure with a great degree of safety and efficacy, as opposed to be taken to the operating room for a mildly symptomatic subdural. Well, we moved from the retrospective case series space to randomized controlled trials several years ago. And the establishment of the literature was discussed in February of 2024 at the International Stroke Conference, in which the results of 3 randomized controlled trials were established. All of these randomized controlled trials had slightly different inclusion criteria, exclusion criteria, and primary outcome. But the most important thing is that these randomized controlled trials showed efficacy for treating this disease state with endovascular needs. And Embolize written there was a surgical study. STEM was surgery plus patients who were managed primarily with middle meningeal artery embolization. So we have to recognize that there was some difference in each trial. So what does the future hold for this endovascular intervention? Well, first things first, we need to think about our procedural volume. So this is a great figure from Ansar Rai's paper that he published in JNIS, in which you see middle meningeal artery embolization performances or indices showing that the rate of MMA embolization being performed keeps increasing from year to year. And when you put this in perspective next to endovascular treatment of aneurysms and stroke, what you see is that honestly, over the last 5 years, the rates of aneurysm and stroke are relatively stable. We're thinking that aneurysms in terms of endovascular interventions grow at a rate of about 5% a year, AIS 7% a year. But what we're seeing is a massive growth rate in the number of patients that undergo endovascular treatment of chronic subdural hematoma. And if you look at this and plot out these curves, what we will see is that endovascular middle meningeal artery embolization by 2030 is going to far surpass our performing any other endovascular intervention in our centers. I think it's very important to talk about how to improve this process. We need to talk about improving efficiencies and costs. The type of embolic material that is used has to be considered. Is it, should we use something super cheap? Is liquid embolic the way to go because of higher efficacies? It's important to think of all of this stuff. This is the second thing, single session. For a person who needs to undergo surgical intervention, how do we make this better? So typically, what we sometimes do for a person who needs surgery is we take them to the operating room and then you fit them in your angio schedule. Christina, I can only imagine how much we torture you on a daily basis with it. So, the angio suite is really busy Tuesday, Wednesday, so we keep the patient in the hospital and we do the MMA embolization on Thursday. But what is the cost to the hospital of doing that? What is the cost to the patient? So these pictures are actually from our angio suite, in which our fellows, I convinced the OR staff and the IR staff, the nursing leadership, to talk to each other so that we could start doing burr holes in IR, in our angio suite, and then do the middle meningeal artery embolization right away. Our fellows are neurosurgeons, so this is not a big deal. That's me taking the picture, so I'm not scrubbed, but they made the incision, they did drill the burr hole, evacuated the subdural, and then you can see it's being done right on the IR table, and then right after we prep them and do a middle meningeal artery embolization. And that's really important. We've seen, we've written this paper, and there's new reports coming out that you can decrease the hospital length of stay from 7 days if you do it staged on average to 5 days. And that's very important. Outpatient. For a person who doesn't need surgery and has a chronic subdural that's detected and sent to Dr. Hanel's office, how do you do this? Do you have to admit the patient? Can you just bring them in from home and send them in the same day? Send them home the same day? And the answer is yes, you can do that. Finally, it's very important to put in perspective what we are treating. So this patient on the, with the CT scan on the left, who perhaps shows up to your clinic or shows up to your ER due to a mild headache and has a small chronic subdural hematoma. Do we really need to treat that patient if they're good about following up, if we take them off of potential blood thinners that can exacerbate the process? And of course, the patient on the right is a totally different patient. This is a person who needs to go to the operating room and probably shows up with a lot of symptoms. I think it's very important to put in perspective, again, that the elderly population in the United States is the fastest growing subsegment of the population, and we know that there is an epidemic of falls. And this is a paper from the picture from the right is something from the CDC. And then the paper on the left is something from, is a paper taken from JAMA Network Open, from a center from UCSF, and this is something called TRACK Jerry. TRACK is a multi-institution consortium of trauma centers, and they specifically looked at the incidence of traumatic brain injury in older adults and found a significant high incidence of traumatic brain injury, and again, it's related to falls. I will say thanks, but I want to just say ultimately, you know, I'm going to turn 45 this year, and my parents are still healthy. My dad works, and that's a picture of my dad at Christmas this year with my 2 kids. He's 76 years old, and what will happen if he develops a chronic subdural hematoma? I think we all have to sometimes just dial it back and think of our own families and think how important it is to understand disease states, understand how to improve these, the ways we treat them. I will tell you, this man right in front of me is the PI of an NIH-funded randomized clinical trial looking at better alternatives for patients with moderately symptomatic chronic subdural hematomas. And ultimately, who this is going to impact is maybe us one day, but definitely potentially our parents and our grandparents. So we always have to be reflective. Thank you.
So grande in Portuguese means big. Great job. It fits you really well, and it's very, very nice to see you maturing and growing old, 45, beautiful. I had the honor of visiting. I'm sure it's a proud daddy of that picture, holding the grandkids. I think we're going to save the questions because Peter is going to talk on the same topic, and then Nima just joined us from his spasm intervention. Somebody got to work right now. So Peter is going to share with us what Ramesh just alluded to, the chest trial, and then we'll dive in discussion.
Always tough to be the one right to fall on, you know. I'll keep it short. Okay, great. Well, first of all, I want to thank you, Ricardo, Eric, and Chris, and everyone for the invitation. It's a real honor and pleasure to be here. So this is the view. I took a walk on the beach yesterday. Pretty nice. I used to work in Tampa, Florida, so I missed the beach here. So here, you know, scrambling pictures with these guys, and I thankfully got all of them from this day. Again, Ricardo, Eric, Ema, Chris, thank you. So, I'm just gonna talk about this particular study. I think the mesh, where's your mesh? Is there a shot? That's what happened when you're approaching 50, you know? So we're not sure already have gone through, the evidence around my trial for the utilization. So I'll talk a little bit about our study. So our study is chest, chronic subdural hematoma treatment with embolization versus surgery. So it's a multi-center prospective randomized study. We're trying to enroll close to 400 patients. The study is a little bit different. I'll get into it, but essentially we're comparing surgery directly against embolization, so not as an adjunct like the studies that Renee showed. And I think the only one who did this in symptomatic patients, as you saw in the measures plot, there's a group of patients with small subdural and asymptomatic, probably can be safely watched. The other thing is that we're going to test a different embolic, one that's much cheaper, with particles and this figure, so PBA. So some of the inclusion criteria, so elderly people, as you expect, we're looking at really just the lateral subdurals. We'll consider bilateral. The other side is small and asymptomatic. We're really looking at non-acute hematomas, so either chronic, subacute. Again, these people need to have the symptoms, so we kind of went through some rigor and trying to find out how you can quantify people's symptoms. So we end up using these pretty objective scales, the MRC for strength, the TOUT scale for gait, and then the aphasia severity scale for language. So primary outcome, we're really looking at people who either failed the treatment needing rescue surgery or died within the first 6 months after treatment. So what is kind of a little time on this slide? I think it's important, for everyone to set apart the chest trial from the other higher quality level studies that's published in New England Medicine, the three that we showed. So chest is different because we're actually looking at using embolization as a primary treatment. So all the other trials looks at embolization as an adjunct to surgery, so you have to do surgery plus embolization. So here we're looking at, in this group of patients, can embolization replace surgery? Is embolization as good as or better than surgery? Secondly, we allow people who, you heard Ramesh's talk, a lot of people after surgery recurs. So in the other trials, they typically exclude patients who have prior treatment. So here we're allowing people with recurrent diseases after surgery to be enrolled. Also, we heard about people with bilateral diseases. And we're also really the first and probably the only study in the US looking at particle as an embolic agent. The main advantage of particles is very cheaper. It's a fraction of the cost per liquid. If it's less effective, then I think we're doing the rest of the world some good to give a cheaper option. And also, potentially can do this maybe a little more easily with the weight since we don't need the MSO and so forth. Other things that is interesting, I'm going to mention a lot of interest in this. We have a lot of exploratory things. We look at cognitive outcomes, we look at quality of life outcomes, headache outcomes, and there's a lot of data right now. We're talking about embolization for headache, so we kind of want to study that a little bit, and then also kind of taking advantage of being a surgeon and doing clinical trials. We also want to collect tissues, just like what Carrie talked about earlier. We want to have a repository for these tissues, including dura and brain blood. We look for potential biomarkers, just like we did in aneurysms. And actually, we've done some spatial transcriptomics on membranes, and the results are pretty interesting. That basically shows that even on the membrane, on the different side of the membrane, the gene expression is different. So that kind of gives us some new nuance of the disease and perhaps some different targets. Again, just like we mentioned, my whole goal of doing this is really to understand the disease a little more, maybe local clinical therapy that we can use. So again, I want to give a big shout out to Ricardo and his team and Ema and Eric for enrolling the first patient here for chest last week, and they're super quick. They're just up and running last week and enrolled the first patient. So let's see how we do. Supposed to be done. And so I'll maybe quickly just show two cases. So one embolization, one surgery based on trial. So this is a 78-year-old patient with just mild weakness in the left side, just to give you a sense of the subdurals that we're enrolling. So this is, so this one, is pretty big size, so I think in the past we may just operate on this or maybe operate in embolization, but here, this particular patient, we can see here again, I think this is the ideal one to enroll, like pretty big subdural, not a lot of inline shift, the symptoms are pretty mild. So here the patient enrolled to embolization. So just this shows some plural, and this not a protocol. You should just do a common run to look, to quickly peruse the choroidal blush, in this case, typically from the ophthalmic to the internal, and then, then we kind of interrogate the external just to look at the middle meningeal and the outer anatomy. Then we do microcatheter in the middle meningeal to make sure there's no dangerous anastomosis. So then here we just are selective in one of the two branches. I think here is the parietal branch here. Then we do, particle mixed with contrast and embolize. You can see on the right side, fairly standard technique. Then how do we know we're done? We just have a micro run, just show stasis. Then we go to the other branch, in this case, the frontal branch, bypassing. There's a little lacrimal connection here. We just bypass that, and we again, do a microcatheter run here on the frontal branch. Same kind of technique with embolization. And then we do just final, the final, and then we're going to be the final common run to make sure that the part of blush is still here, and looking at the MMA, there's much reduced flow either proximally and don't see any distal, filling of the MMA, and then we're done. So I think this is important. So I just want to show, so this is the 30-day scan. So as part of the study, we did a 24-hour scan. Of course, that's exactly the same. So in the 30-day scan, we see there's some resolution already, and I just saw this patient back after 3 months. So you can see here is a 90-day scan compared to how it was before. I mean, I think the results are pretty good. I think when we started doing this, I was a little bit nervous about these patients. It's like it was pretty big, but they had little symptoms. But I think once we've done now 10 patients on our site already, and I think the results have been good. So I just wanted to show one quick companion case of someone having surgery. I think Ramesh showed about that already. This is a patient who has just very mild special pigmentation. We use this ASR score, so just very mild pigmentation. Again, the subdural that we're randomizing, I think the key is that these people need treatment. I mean, this is another, I think, good one to enroll, like fairly big size, not a lot of shit, pretty mild symptoms. This is the 30-day scan. I just want to show this case just to show that even in surgery, it doesn't go away all the time, every single time. So this is 30-day scan in surgery, and this is the 90-day scan. So just to again show that there's some equipoise, to this here, that the embolization can work. So in this case, we're kind of torturing everyone from research to collect all these things. So we collect blood, serum, buffy code and plasma, and we collect subdural internal fluid, membrane, durum. For everything, the tissue is separated into 3. We get the fresh, we get the hormone, and we get the RNA layers so that we can do kind of transcriptomics things. So we've kind of put in so far 6 patients in viral chest, and we just enrolled 29 patients in the overall chest study. So just want to stay on time, and thank you very much, Ricardo, for the opportunity, and Ramesh for the companion talks, and happy to answer questions. What were questions at all?
Thank you, Peter. So I think Ramesh, Peter, you might take your chairs there, and Ramesh has the microphone for you guys. And I think there are a lot of questions for you guys. So there's one right here. I know Dr. Naval is itching.
Great talk, thank you. Are there any downsides to the loss of irrigation in the MMA due to the embolization? Any downside to the loss of circulation in the MMA due to the embolization?
Great question. The dura is highly vascularized. So the dura has multiple branches of There's, for example, there's the middle meningeal artery, but then there's also the accessory middle meningeal artery. There's an occipital artery that provides blood supply to the dura. So the answer is actually, as far as we know, none. And then number two, we also have to be cognizant of the fact that every time we do, well, I shouldn't say every time, but when we do craniotomies, we frequently take the middle meningeal artery as part of that craniotomy and opening the dura. So hope that provides some answer. Yeah.
Ramesh, it's good to see you. It's been a little while. Peter, thank you so much, you guys, for those nice talks. So I have a couple of questions. So one, I didn't realize, Peter, that in chest, because I saw that the patient got the subdural evacuated, I had a mini craniotomy. So I thought that was burial, but you guys allow mini craniotomy, even if we know that the risk profile is more elevated than burial.
Well, thanks, Eric. For the trial protocol, we allow verbal or mini craniotomy. The only thing I don't know why the FDA didn't allow it is SEPS. Like, I think SEPS is less effective. I think these cases, there are two reasons. I think the main reason is that it's hard to get a membrane with I think that's one of the reasons. And secondly, if you look at the literature, like I do think the recurrence rate is a little lower with mini craniotomy, even though the risk is higher. So I think in my mind, I think it's the dealer's choice where you have to refer all of mini craniotomy. The added advantage, once the patient consented, the bio part of the bio chest studies, they try to do a small craniotomy, so I can take them too. So that's the main.
Okay. And the second is more like a comment, and I just would like your perspective on this, is that, obviously you guys show cases, as you pointed out, Ramesh, I mean, that has completely changed, the treatment care for subdural hematoma. Now, when people who are not familiar with this, it's like, subdural hematoma would always recur. The majority do not, but recurrence is definitely a risk. So just for people in the room, based on all those studies, the needed number to treat. So there's about 14 patients that will get an embolization of their middle meningeal artery to prevent one recurrence. So there's a lot of patients who get a surgery that someone could argue is not necessary because they would not have needed. All those studies were defined in a way that people getting the embolization early on. So coming from a country that would say would be more, would not have all the incentive alignment to make procedure, because the US, everybody benefit from procedure. The interventionalist, the hospital, and the insurance company to some extent as well. So looking at other countries around the world, my question is that how things have been adopted in other countries. Are you guys aware of that? Because an endovascular procedure is more expensive than just cutting the skin, doing one hole in the skull. Catheter are about a couple of thousand. A lot of time we'll use a couple of catheter. The embolic agent are $5,000. So those procedures are really expensive. And this is why, again, kudos for the NIH trial, because particles are really cheap, and your study compared directly to surgery, so it's not necessarily in that genre. But the best study would have been to kind of follow those patients, and people who seem like they're developed recurrence would get embolization. But obviously the cat is out of the bag. So in the US now, it's pretty much standard of care to embolize everyone. But I just want your opinion about this and what's happening in the country that are a bit more cost conscious, as far as resources.
Eric, great comments. I think the uptake of this procedure, as you said, is certainly greatest in the US compared to the rest of the world. I think for reasons you mentioned, to begin with, the accident angio suite is much easier here than elsewhere. And you're not from Canada, just give an example. Maybe the person has one angio day a week and they're really hooked up with elective cases. It's hard to put, this is a common disease, right? You're talking about CTWs a week to put them in. I think, not to mention the cost of the embolics and the catheters. I think the other question we should think about, I have to say that in my mind, I know we quote people a fairly high recurrence rate, 20%, something like that, but I think the recurrence rate is lower, and look at it in the study, and I don't think 1 in 5 patients recur. I think the recurrence rate is much lower than that, maybe like 1 in 10, something like that. So I think of course now the studies that we have all show kind of the benefit of adjunct embolization, but the timing is not specified. Some of those adjuncts were done before surgery, some was actually done after surgery, like immediately after, the week after. So I think, I think a reasonable approach is, like you said, maybe a reasonable approach, and this has been studied rigorously, is to have the surgery, and then you have some criteria of maybe like very high risk patients, a patient who shows signs of early recurrence, maybe those sort of patients, we can do embolization. And I bet if you do a study like that, obviously I think there's a significant amount of patients who have, and we all see these patients in the past, we don't have this when stop with the patient and they're all in the way, right? So I think there's these patients certainly exist, so I think that's a good study to do, maybe you can do a surgery and then wait, to see who to find who needs the surgery.
So that's an awesome question. So let's dial it back a little bit. First of all, just based on US surgical data from the Embolize trial, you saw an absolute benefit, reduction of recurrence or surgical recurrence of 7.2%. 11.3 was in the folks randomized to surgery alone, and 4.1 in the MMA plus surgery alone. So an absolute benefit of 7.2% has to be put into perspective. This is not acute ischemic stroke with an M1 depletion. We know that the natural history of that is a lot worse. So you're absolutely right that we need to kind of be very thoughtful about this. And the truth of the matter is this hasn't been widespread adoption in many countries. How do you go to India? How do you go to China? How do you go to a Latin American country that does have a lot less resources in healthcare and talk about this? I think, I think you're spot on. Number two, I think it's very interesting that we look at this disease, which we just showed has a significant pathophysiologic process, neuroinflammation or dysregulated inflammatory processes going on, hyperfibrinolysis. And just look at it as a picture and say it's 1 or 0. Does it need to get an operation? Does it need to not get an operation? Do we need to do an MMA embolization? And I would just say we need to take a step back. When we look at patients who present with chest pain, we get a blood biomarker to help us understand what to do with that patient. And I would say that what we need to do, and Peter, I tortured Peter over text and on email, even yesterday on the plane, I sent him an email about this, that what we need to do is take these biologic specimens, understand them better, and develop a blood-based biomarker to understand, hey, is this particular subdural hematoma showing such increased inflammatory properties that this is a subdural hematoma that's likely to recur? And we should, right off the bat, when we're in the OR and we're drilling a burr hole and taking the fluid out, we can send off for laboratory analysis and say, this is a subdural hematoma that's likely to recur, and this is a person who needs an MMA. So I think we'll get there. It probably won't happen this year. It won't happen next year, but maybe in 10 to 15 years with a true precision medicine based approach, we can do that.
Hey Ramesh, good seeing you right here. So I just had a question about like unilateral versus bilateral with your experience in that. Doing strictly unilateral, I would have a unilateral subdural. I would still have some recurrences, and I just noticed that when I have a lower threshold, treating bilaterally out of the gate, there was far fewer recurrences. So I was just wondering your experience in that.
It's a very good question. I think, and it's a topic of debate, and I can tell you for everyone in the audience, there's actually a 4th trial whose results were espoused in November at the SVIN meeting, but the paper hasn't been accepted yet. It's called membrane. And in the membrane RCT, you could do bilateral treatments for a unilateral pathology. There were only 19 patients treated that way. So the problem is we're not gonna have high level data. I mean, it's not powered well to understand that. That said, we're trying to work with some other centers to understand this exact question. My personal belief is that when you do, I really believe that the goal is penetrance, to take the embolic agent and penetrate distally, penetrate into the membranes. And if you do that in a unilateral fashion, it doesn't really matter what you're doing on the other side. Because if you believe in this concept of getting distal, getting your embolic agent into the membrane, I don't really think that the other side really matters in terms of long-term efficacy. But could you perhaps lead to subdural hematoma resolution faster? I think that may show signal. But at the end of the day, we do have to go back to what we were just talking about with Eric. How much money are we going to spend? I mean, now we're talking about doing bilateral treatments. I can tell you, I had a recent patient who had bilateral subdural hematomas who required bilateral treatments. And I did use Onyx, sorry, I don't know if I'm allowed to say that, but I used Onyx and my fellows were doing the case with me. Our consumables were guide catheter, intermediate catheter, 4 micro catheters, 2 vials of Onyx, 2 micro wires. That's a lot of resources and a lot of money, and I think we need to think about it.
So great segue to my question. So Peter, this patient is not a candidate for chest. He's heavily symptomatic, 82 years old, not a blood thinners, come to you, you're on call, there's a subdural that is drainage. Do you embolize this patient or you don't embolize this patient? With the bar hole, mini cranial, whatever you.
Yeah, I think if someone is very symptomatic, but more than mild symptoms, I would operate, I'll drain it, and I think I'll do is Eric's still here, I'll do Eric's approach, like I'll operate and wait and see. I still think, you know, the majority of people can be anything else done. But I will consider if there's, you know, if, for example, the one scans look great, or if there's some very high risk tissue, which I would consider actually embolization.
So make it harder for you, Ramesh. You show the picture, you open the door, is your father. He has a subdural hematoma, chronic, that needs surgery. Are you gonna expose him to your own paper? I think it's Utah number, 14% recurrence without MMA embol, no recurrence with MMA. Do you embolize him together with Barhol or not? Are you not your partner? You can take the ethics very close to home.
I think I would do it as, I would do both as a single stage operation. I think that ultimately what we've done some, this should come out eventually, but we've done some cost-effective analyses, which also incorporate quality of life measures. And we have seen that one of the key drivers of a diminished quality of life is a surgical recurrence. And if you are one of the 14% or whatever we want to say of folks that have a surgical recurrence and in patients treated with surgery alone, that does affect your quality of life. So for me or my family member at that age who unfortunately has that problem, I would just do it, but I would do it efficiently and safely.
I'll second that, because my dad is getting MMA, I'm on a bar hold. Cannot go any harder.
Hey guys.
You're talking about, let's see what he's gonna do to his body. My poor father just got through procedures together with Ramesh.
So I'll start with a comment and then I have 2 questions if you don't mind. The comment really is, I think, thank you. No, thank you, not just for the talks that you guys gave, but thank you for everything you guys do for patients. But most importantly, thank you for the research that you guys do. at a time where research funding is getting pulled on one pretext or another, and we don't know if science will develop at the rate that it currently does. I think the work that you guys do, the amazing stuff, this work that you guys do, doing research and helping science move forward, I think is pretty amazing. And that's for those of you on the stage and for those that have given talks and my colleagues here who do some amazing research. So thanks for that. I know I stand on the sidelines and basically say we criticize research and statistics, but I do truly appreciate all the work that you guys do. The first question really, I think we already asked by Eric and Ricardo, but just a tiny little follow-up to that. Again, as we were talking about the Embolize trial, number needed to treat 14, Magic MD, number needed to treat 20. So, again, for number needed to treat, how many patients do you have to treat with a particular intervention to benefit one patient? So I appreciate you putting up the slides, Ramesh, of like your dad and your kids. My dad's 87, I have 2 kids, so it touches a note there. Of course, I'm also Indian, as you might have guessed. But I guess the same question that Ricardo brought up about what you do, if it's your dad, how do you sell this to a patient when you have, in other words, how do you consent? So like Dr. Chimasani, our telescope director, like when he goes and talks to someone about giving TMK, his first thing is, okay, there's a 30% greater chance you'll have minimal or no disability if you get TMK relative to if you don't. There's a 6 to 7% chance of having a symptomatic hemorrhage that could potentially be life-threatening. That's how, we consent those patients. And we talk to those patients and let them have informed consent, right? How do you sell this, for example, to me, if you're talking to me about my dad, and if you come and say, listen, I could do an MMA embo, and there's, we would do it on 14 patients, and 1 out of 14 patients would benefit. Or we would do it on 20 patients, Magic MT, and 1 out of 20 patients would benefit. If I hear those numbers, I'm like, wait, 1 in 14 is 7%, 1 in 20 is 5%. They're undergoing a surgical procedure to reduce their relative risk by 5%. You line up 20 patients, what are my odds? Do I have better odds playing the lottery? Right? It's just with numbers worry me a little bit, because this is not one of those interventions where, as you pointed out, mortality is different or functional outcomes perhaps are different. You're just talking about reducing recurrence. Along those lines, we have studies where they studied steroids, right, that significantly reduce the risk of recurrence. The outcomes were actually slightly worse. The mortality was actually slightly higher, which is why they never caught on. But they reduced recurrence. If at any point it's just going to be recurrence and the numbers are so small, in other words, the number needed to treat is so high, is there truly benefit, or are we just looking for something because, we see it?
Great question, in a holistic sense. So I think the first thing is I certainly don't approach patients and talk about numbers needed to treat, because no one understands that for a normal person. But I do present them in terms of, and I love the fact that we actually now have randomized controlled trial data. I started doing MMA embolizations in 2017, when I was still in Texas, actually. And for me to be able to talk to patients about, and their families about, hey, let me do this procedure that doesn't have randomized controlled trial data associated with it, but this is my experience with it, was a little difficult. But I'm really glad that we have this RCT data. And I can truly say that now when we approach patients, particularly those needing surgery, I can say, this is your absolute risk reduction. I also quote to them that while Embolize had, I think, a 0% rate of causing an issue through the MMA embolization, 0% rate of facial weakness, 0% rate of blindness. I have had a blindness complication. I still remember 2021, August. It wasn't my patient, it was my partner's patient. And it was also our department chairman's patient. And I caused this patient to go blind in her left eye. And it was awful. And what I do say to patients is that I believe that there is a 2%, and I think some of our data from our retrospective trials or retrospective series have showed this, that there's about a 2% chance of a facial complication or a blindness complication. The other stuff I talk about is, hey, we are going into the external carotid artery, but sometimes people have bulky plaque in their carotid origin or distal common carotid, so there is a chance of stroke. And that's probably less than 1% chance of having that. But I think we have to have these conversations with patients and explain them, these things to them. And in terms of primary MMA embolization, I think that's also even harder. Because we don't still have the best best data for these patients. I think we can quote, generally speaking, of 65 to 70% efficacy of preventing the need for surgery, but not every not every chronic subdural hematoma that we're thinking about doing primary treatment for is created the same, right? There's some that are 7 millimeters, some that are septated, some that are non-septated. You have to think about the patient. Are they on antithrombotics? What's their comorbidities and things like that? So I think putting that into perspective is very important as well.
Just a follow-up question to that. Sorry, Emma.
You got some time limit really.
So, the next question is about STEM. You know, as you know, STEM was probably the most robustly positive trial out of the 3 of them. And it had the breakup into the surgical population and the patients which were managed conservatively, and then you split them up into some of them getting MMA and others not. And really the benefit in STEM came more from the group that was followed conservatively. And, you know, and then the other group, the treatment group, got MMA and plus conservative management. So the question there was, in the control group, 60% of patients that were managed conservatively ended up requiring a subdural evacuation at some point in time. So when you look at that study, do you look at that as a limitation that in 60% of patients who we thought were not going to need any sort of surgical intervention, they got surgical intervention? Let me rephrase that in Brazilian for my Brazilian brother, Ricardo. You know, take a soccer field, right? If you look at the width of a soccer field, it's like 75 meters. If you look at the width of the goalposts, it's about 7.5 meters. That's 10% of the width of the soccer field. If you're going to expand the goalposts to be 60% of the width of the soccer field, I have a hard time believing that any goals you score are valid. So if that's your comparison, you know, 60% of the patients you predicted weren't going to require intervention ended up getting intervention. The fact that MMA dropped that from 60% to about 20%, is that actually valid scientifically in terms of as a study?
I actually reviewed these papers, and I think, you know, so which group, to your point, I think again, which group benefits, we still don't know, right? So all these studies are designed the same, right? So a patient comes in, they either think, okay, need surgery, then they randomize, you know, observations, the observation plus MMA or surgery, the surgery plus MMA. So instead, the main you know, driver of the positive result came from the conservative group, as you said. Whereas if you look at, you know, embolists, they haven't published the conservative group yet, but the result from the surgery group is very positive. You know, so maybe we can assume that the driver is different way, I'm not sure. But then Magic MT, it's essentially a makeup study. It didn't really kind of reach the primary endpoint. So I think to begin with, it's a little bit unclear kind of which of those 2 groups the embolization, you know, is most beneficial in, you know. And to your point, that is a tough one. I think the fact that a significant number of patients, you know, end up getting surgery from the from the conservative group, I think that's a limitation in the results. But I think my takeaway is that, you know, overall MMA. So that's why I go back to Ricardo's question. The first question about talking to patients, I'm not saying that adjunctive embolization is the standard of care. I think we're still not there yet. You know, I think there's certainly now high level evidence to suggest that. But I think that there's still a few questions. One is the magnitude, right? So it goes from a study like Magic MT, which shows essentially no benefit. You know, study like STEM and embolus, you know, showing big benefits. So I think the magnitude of benefit is unclear, and also which group benefits more, is the observation denial group or the more severe group, like I'm not sure. So I still would say that it's still not the standard care when we counsel patients, and that's why I still do what Eric kind of suggested, I still, even if it's my family, I would do the operation and not wait and ambulance later. If I think it's, that's my take.
All right, this is the last one. I think everybody's,
Lunch is coming.
I just want to say thanks again for coming and giving such great talks, and it is really refreshing to see this conversation, and I hope everybody enjoyed it. The study that Naval mentioned, being part of research is very important. These are the questions that we have to answer. So thanks again for all that. So I'll make it very easy and simple. You said adjunctive therapy, and I think that's very important whenever we're doing this. When you're dealing with an 80-year-old with M1 occlusion and age of 21, you don't have much else left. You either help that patient as best as you can or you don't. This is adjunctive therapy. So the last thing you want to do is hurt somebody. So I think that we should be very cautious as to put a different hat on when we do this, as interventional is that's the most important. Sometimes the anatomy is such that there's so much tortuosity in the middle of the meningeal artery that getting distal is, you can change wires and catheters, it just doesn't go. In those situations, is there anything that you recommend?
Yeah, so initially we just had a last chest case, one of the, so I mean, like again, I think the risk of this procedure is a little bit under reported sometimes. So we had a case in chest just last week, not one of my cases, but when we called and say the products are so hard, they couldn't even get carotid access, basically stable carotid access. So they tried, so they asked what to do, couldn't get access. The patient randomized the device, she couldn't get access. So, and she, and the person's along to try. So they tried from that. This is 80 plus year old patient, right? And it's able, I'm sure about 10 they called and tried. So the problem from now already, the child finally got access, right? And then everything is so tortuous that we barely got a catheter to the end proximal MMA, right? Way below where it's really safe to do this, right? So I end up suggesting just do boiling, and you're there. I mean, it took 2 hours to get there, you're barely there, don't make the risk anything, just but even then, the patient in the post-operative, shower from all the arch things, So I think to Ramesh's point, to Nina's point, I mean, I think, like I saw the company work from all the trials, but I think it's not that trivial. Manage to navigate the arch and these older people, and to do some people have this anastomosis to the eye, troubles with drainage. I think there's a low single digit risk of complications that we can discuss, And of course, the thing is that some of these complications don't happen in the surgery, right? You never find something in surgery, just find the find something in surgery. So, so I think some of these is just really, I mean, so I think it has to be those and really making surgery conservative. If you can't try it 2 hours, can't get access, probably should just call it later.
Sorry guys, we have to cut because the lunch is served and Dr. Khan has a flight to catch. He's our first speaker, so let's be back at 1 sharp. So Peter can give his talk and be on time for his flight. Thank you, it was a phenomenal session, thank you both.
If you haven't completed already your vendors, remember we have a basket at the end for everybody. So make sure you guys put that table there. We will be adding the eval for this afternoon later. They are required for the nurses. Please make sure that you guys fill that out for me once you see it at your table.
So I want you guys to take a look. When we started doing this, it's looking for exactly cases before that. Because they'll show same operator, same environment, to see what's there. Because again, it's not that big of a problem. It's not, it's not playing the Ricardo. It's not more seizure. Good on you. I'm Salvador. I'm Salvador. Oh, hi, how are you? Good. Thank you so much. Like, you agree for sending my letter for that reason. No. I really appreciate what you're talking about. Yeah, you do 100 meetings for Okay, sorry, yeah, one, two, see you.
Did that fire already?
Thank you. Oh, yeah.
The quick are better. Somebody turned it down, yeah. Yep.
I looked at it and I was like, no problem to me. I figured I could at least see what else would they come? Oh.
Oh, yeah.
Yeah.
Oh.
And maybe I'm not eating them right, but. Sure you are.
I'm running around like a chicken. I know, it's fun, yeah. That's not a great finding. I'm just okay, when keep us on reverse. Yeah, I don't even know someone back there on December 26th. Yeah, she said she was. I'm like, I said, I'm pretty sure that you were the nurse that took care of them.
There he is. Oh, yeah. It's like, yeah. Pardon? They didn't keep you? No.
Hello, everyone. I wanted to remind the nurses to please complete the evals before they leave. Also, if you are a tech or if we do use the evals to be able to improve this conference for you guys. So in each table, I added the QR codes. They are CEUs for the nurses that you can only scan the data we in. You will be able to do day one, but if you were not here, no point. But you can do day two, you will just not be able to do day three. And then the CMEs are on the other side for our ARNPs and our physicians. So please make sure that you guys complete that so you get all of your credit for today. I will include this in just a minute, Dr. Hanel.
Okay, good afternoon, everyone. This is the toughest hour of the day, not fall asleep after eating. Dr. Khan was kind enough to give another talk before his departure later this afternoon. Again, he's been a pioneer and been thinking a lot outside the box. With a great partnership with MD Anderson, you'll see he has really interesting avenue of experimentation and all that. With catheter now, we're able to basically go everywhere in different territory in the brain. So is it possible to use this to address other pathology that currently are not necessarily treated using those modality? And you'll see the future is exciting as far as what is possible. So thanks again, Peter, for being here.
Thanks, Tina. I know Chris, you said I have a hard stop because Matt got the show at 1:30, so give me like a 5-minute warning so I can stop this. So I'll cut some of these points here. So again, super excited to share this work with the group. I know Eric, you're a vascular and tumor, just like Ricardo, so I thought I'd bring a topic that combines with you. So on the vascular treatment for brain cancer, I wanted to present also some of the neural work and all that. So I'm just going to skip some of this here and go right to the therapy. So we know that the myeloma is a bad disease, so we need that therapy. So this is the therapy. So I'll start with this slide here. So the therapy is Dr. going forward. So this is really the life work of Dr. Bradley. You've got to give him a lot of credit. This essentially is an engineered cold virus that's specifically for immune cells. So you look at this virus, it's designed with a antigen that binds to the receptors of the immune cells, the RGE protein, the indicating receptors of the immune cells. And once it's uptaken into the cancer cells, it only replicates in cells with a deficiency in the retinopathy, which is a common mutation in most cancer cells. So again, this virus is specific for glial cells. So how does this virus work? So part of it is intuitive. So we want to get it into the tumor cells so they can replicate and lyse the cells. So that's intuitive. And once the tumor cells lyse, it exposes the antigen from the virus and from the tumor to the patient. So the patient can mount an immune response against, brain cancer. So this kind of adaptive immunity is really how we think that most of the tumor cell effects come from this therapy. So already there's a phase 1 trial from Framingham doing direct injections, so not intrathecal therapy. So I took the virus and injected it into tumor cavities. So results pretty encouraging, actually. 37 patients with recurrent tumors, 3 people have complete response. It works some way, to some degree, on about half the patients. I think most importantly, he demonstrated that this technique works in humans. So the virus gets into the cells, it replicates, it breaks the cells, and it spreads across the tumor. The problem is, this was 10 plus years ago, the medicine study said about half the people injected to the virus doesn't get the virus. So I think it's a problem with delivery. So that was invented about 12 years ago. So we kind of think, well, if we can't really directly inject the virus into the tumor cavity and the tumor does not get in the liver, how about delivering through the blood vessels? So that's when we first started the experiment. So when we gave the virus just by itself in the bloodstream in animals, it causes liver toxicity. So we know that that's a no-go. So then we searched for carriers, wondering if we can have a carrier to kind of put the virus and they can deliver the virus, to the cancer. So it turns out that stem cells are home to brain cancer. So basically it takes, these stem cells were injected in the artery, not in the veins. It goes to the brain cancer through different mechanisms. And this is like to remember. So these are initial kind of animal experiments with mice, immune deficient mice with human brain tumor implanted. So if we just give the virus in the bloodstream, it causes liver problems. Doesn't help anything with the tumor. If you just get the stem cells go to the tumor, doesn't do anything. But if we combine the two, which means to infect the cells with the virus first, kind of this kind of Trojan horse kind of approach and deliver the whole thing. Then the virus gets delivered to the cancer. The virus replicates, it kills the tumor, and eradicates the entire tumor in about 30% of the animals. So these animals have long-term survival. So we're pretty excited about that. And that was our hypothesis at the time. Maybe we do it endovascularly with this stem cell combined with the virus. Maybe you can distribute it better. You don't have this problem of direct injection. It's minimally invasive. You don't need to open the head. And deep tumors, this could be good for. And of course, I think importantly, this is a tough disease. We know that we're going to need to do deep infusion, not just one to have an effect. So endovascular therapy really perfect for that. So I'll skip some of these things here. These are just kind of preliminary things that requires the FDA. So they want us to prove that the catheters we use, the medicines we use are compatible and don't destroy the therapy. Then we did some preliminary experiments. So we first did a canine experiment. So we showed that in canine, when we infused the cells, when we went to the dose of 1 × 10⁸ cells. So we know that when you infuse the cells at this concentration, it doesn't cause stroke. So we did MRIs and histology on that. So one hemisphere we infused the cells, the other one we did a control of saline. So MRI histologies were negative. So I'm just trying to speed it up so I can give the whole time here. So in this study, we have 8 animals which did the acute experiment. We just skipped the cells with the MRI and histology, and 2 animals we survived them. So after infusion, looked them up, wait for 24 hours for the watching examination. Then we do the MRI sacrifice. So these 2 animals have one immunologic deficit. So at least in a dog model, we show that we can infuse this in the carotid. We chose the carotid because we're just trying to do this in potential tumors to begin with. It's safe. So then the FDA wanted us to do this in a tumor-bearing model. So we picked a rat. So this would be injecting human brain cancer cells that will suppress rabbits. So all these rabbits take treatment suppressants. We basically use 2 cell lines. One is a professional cell line, and the other one is patient-specific cell line. So we injected it, we did angioms and all the rabbits, we did that. And then we did the MRI, so the standard sequences. We also did this dynamic contrast enhanced sequence, really to local the ability of breakdown. So we did some heavy MR sequence angiography, and of course histology, basically HME and histochemistry to really prove that we're able to grow tumors in the walls. And so this is what the FDA was really interested in. They wanted us to capitulate that in large animal model. When you get the cells and the virus, but the cell still goes to the tumor instead of the mice. And here I'll show us this is what tumor looks like in MRI. You can see enhancing tumor, intense in T2, and maybe have a blush. You really squeeze your eyes. I think it's hard to say, but certainly histologically we have the tumor. We do histochemistry on basic HME, and in this dynamic contrast enhanced sequence, you can see there's some change in permeability suggesting that the empiric breakdown can be capitulated in the tumor. So excitingly, so apart from the mice study that I showed earlier on the rabbits with human cancer, when we get the cells intracellularly with the virus, the cells also goes to the brain cancer. You can see here, these are GFP labeled fluorescent cells that will make the GFP able to see the fluorescence in the tumor, suggesting that these cells are there. Okay, perfect. So now the exciting part. So I'll slow down a little bit here and talk a little bit about the clinical study. So basically all that in vitro and vivo work FDA granted us to start the clinical trial. And fairly common criteria, right? Adult patients, good Karnofsky functional status. These are all IDH1 wild type tumors with recurrence, failed standard therapy. So it's a phase 1 study. So the phase 1 study really is looking for dose escalation and also the toxicity. And it's nice to see the tumor response and time of progression, but really like the point being is just to look for dose and so here we're really down to last patient. We hope to complete this next month. So we've been 17 patients already on the highest dose. And this is kind of 3 by 3, pretty standard phase 1. Sure. So you have 3 patients, they do well, we go into the next dose. You can see here on the 3rd cohort, we have 1 patient with seizures afterwards, so we repeat the whole cohort, and thankfully nothing happened with these 3 patients. We're able to go to this next cohort. Some preliminary results, basically were successful in normal patients. And these tumors are everywhere preventorily, so we didn't really prevent people with healthy tumors to get in, which is important. And we're pretty distant. We reduced everyone beyond the circle levels. And I think a little bit to my surprise, these cells are pretty thick, especially in high concentration. I'm surprised that we didn't cause strokes in anyone, but everything was fine. And a lot, they want kind of much like our elective inhibition and elective treatments. And I think that's probably one of the important conclusions of that is that the therapy is actually pretty safe in cells and people's intracranial vessels. So, of course, not a natural body. We actually have a pretty long-term follow-up on all the patients. So the 17 patients, 15 patients died already, but importantly, 4 people lived up to about two years, and we still have 2 surviving patients, and we're out now to 4 years for each one of them. So you can see here, this is like the best part of the patient, right? This group of patients have returned with about still 6 months median survival, and hopefully by this therapy, we're pushing the curve out somewhat into the year and a half range. So I will quickly go through these cases in short, but we'll work through them. So this is our first patient. So patient has a lung occipital tumor. After resection, you see a nice resection, and like all these tumors, they recur in the medial part. So this one is pretty straightforward. We're doing single infusion, single particle. So a lot of PCA catheterization, microcatheter, and infused. So one caveat is that because these tumors have all been treated before with radiation therapy, we actually don't see any blush from these tumors. So what we do is that now we kind of do a free infusion study, from the microcatheter and merge it with the preoperative MR just to make sure that we're infusing kind of most of the tumor. In the future, since the first actually, we're only doing a single injection for a single particle. So in the future, we'll probably do multiple infusion, multiple particles, and that'll be better coverage. But I think for now, we're just doing this for the first study. So this was our first patient, we infused, and no strokes will be involved after. So I want to show this case, an interesting case. This is a young man in his 30s. Had a big recurrence, here, and you see the angiogram, no no blush, again, always kind of retreated tumors. So this is a microcatheter from the prefrontal branch. Again, very hard to see if you're really, perfusing, checking the tumor or not. So we merged the microcatheter perfusion ring with the MRI, you can see here. So it shows that we're actually pretty good here. So they did the infusion. Unfortunately for him, 3 weeks later, he got really sick, really symptomatic. You can see on the MRI, there's a big change in the MRI. So we kind of, forced to pick it back, we moved the tumor and then study it. And it turns out that most of this is inflammatory cells, which I think goes back to support the hypothesis that this is really like a kind of therapy. It triggers your own immune system to target the brain cancer. So the brain usually don't get immune cells in it. So the fact that the tumor is filled with immune cells, maybe tells you that the hypothesis is not far. So this is how I think this works. So basically, initially you inject the virus obviously goes down, and then immunity goes up. And then initially you probably get this pseudoprogression as you get this inflammatory kind of response from the host. And then once that works, then the tumor slowly regress. So we kind of think that if you really get the long-term benefit, you have to get this kind of pseudo progression. So this is a good case. So always from the end of a good case. This is from the long-term survivors. You see here a very similar tumor, medial recurrence of occipital tumor, and this is almost 4 years after infusion. That little nodule kind of one of the way the patient stay stable. So just transit. So this is a phase 1 study. It really showed that it's feasible and safe. I think this is part of the message, and there may be some signal that this has some efficacy to it. Next steps, so we're planning the next study. So next time we'll do a double infusion, because in my study that I showed earlier, the efficacy was better when we infused it 3 times. And also we want to really prove the hypothesis that this actually does what we say it does. So we're going to do the infusion, wait for 14 days, because that's how long it takes for the virus to replicate and to lyse the cells. Then we remove the tumor, and then we do histochemistry to make sure that we get actually viral particles, the E1A and the exon. And also we can do chemistry look at inflammatory cells like that case I showed. So this will be important because if we don't see any virus or inflammatory cells, then maybe this is not the way to go. We have to go back to the drawing board. So in the last probably 5 to 10 minutes, we wanted to kind of talk about something new. So that first study is kind of maturing. So we want to start something new and then tackle another desperate tumors. This is the DIVG now, the diffuse systemic glioma. Again, this everyone knows this. This is a childhood glioma, again, a terrible disease, median survival of less than 12 months and 2-year survival of only about 10%. So really as bad as glioblastomas, the children's glioblastomas in essence. So the good thing is that Delta 24, the virus that we talked about, has been used in this treatment already. So again, Dr. Lang and his collaborators has tried to directly inject this into the tumor, and it shows some efficacy. So very much like his original study in glioblastoma. So it pushes the survival curve all the way over here. So this is what we know so far. Okay, so we know that that Delta 24 may have some efficacy to the tumor. So based on the studies that I showed you earlier, we know that we can load the virus in stem cells, so we can deliver the cells safely. So we know that. And also, the paper on the right side is a paper from John Beaufort's group. John also got a lot of work in arterial tumor realm. So this year he was fusing monoclonal antibody against these tumors. And so he has kind of a proof of concept that intraarterial therapy has been tried and has been done safely. Here he actually addressed another important thing of opening the blood-brain barrier mannitol and also the balloon. So here you can see the plate balloon vascular. Basically, it's trying to slow down the transit therapy and also get mannitol in the blood-brain barrier. So I think this is what we know now. So what don't we know? So we don't know that if you combine the virus and the stem cells, it's still effective against DIVG, a different kind of tumor, right? And also do the stem cells home to the DIVG like it did in the glioblastoma, so this is another known. And since with all preliminary experiments in the carotid, so how about using cells, fixed cells in the vascular system? The vascular has much more perforators, so it's safe. And finally, do we have a preclinical model to study this? So quickly, in the last 5 minutes, first I promise I'll have time. So this is a killer assay. So basically, we have the IPG cell lines, and we just mix, Delta 24 and the stem cells with them. And you can see that with increasing concentration on those green bars, there's increasing tumor cell activity. So it shows that the Delta 24 and the MSC actually do work against the DIPG cell lines, And then about the homing question, we did some migration assay. So here we basically mix just the cells with no virus and a few different DIPG cell lines. This particular cell line, the TP54 cell line, that the cells do home and clump with the tumor cells. So again, both homing and tumor cell activities. In terms of the safety, so I went back to the lab and did some rapid work. So you can see here, so I did a long run here. This is the T-bar area around it. So we did a microcatheter run, microcatheter into the T-bar as distally as I can get it, probably still barely extracranial. So here you can see injection of the T-bar, the film basal of the rocket, the cerebellum blush. So this is before we infuse the cells, and this is after we infuse for 1 times 10⁷ cells, for 4 cc. So after we check this, so at least know that's what drop often cause the basal division. And these rabbits are very finicky. I think we can do the rabbits safe in people. We did MRIs too. I don't have the histology yet, but the MRI looks clean on the rabbits. And finally, we're building the model, we're translating all the work that we did with the last time out of the IPG. So we can take these deficient mice and we put different cell lines. And in this particular case, one cell line, this SUDIPG 36 cell line, took better than another one at a higher dose. So you can see here, we can actually implant the IP into the mice frontal lobes, and we're about to start the study that we'll do the carotid puncture and directly test this with Delta 24 and see try to replicate some of the early Boston experiments. So again, in summary, we've answered a few questions. That the therapy appears to be effective against the IPG, it homes to the cancer, and infusion appears to be safe. So now we have to really test this with the preclinical model whether or not it eradicates the tumor. But hopefully all this will lead to a phase 1 study, just like how we do it. So with that, I want to take the last minute to thank all the collaborators. Obviously, Dr. Lane is really the brain behind the therapy. This is a lot of work. And Chris Young, my partner, folks from the lab, vets, and many folks and sources. So I'll pause the last 5 minutes. Happy to take questions. Thank you very much.
Peter, thank you, man. Great. Thank you for spearheading this. I think this is super exciting. How do you see this for GBM, for the IPG? I don't think there's much competition there, but GBM with recurrent surgery, with gamma time, viral vector vaccine, a bunch of vaccines, a bunch of drugs. Where do you see this fit in? Unfortunately, Rob Valer could not be, because I would love for Rob to be in this discussion. Because again, we do see a fair amount of GBMs, and it's a dreadful disease as well.
Yeah, yes, the Robert Anderson. At some point, we'll have to do this as a multi-center study once we get it figured out. I think, Ricardo, to your point, this is a top tumor. The advantage for us that nothing has worked so far, so that's our advantage, right? A lot of people are trying different things, even as you know, in the endovascular intravascular world, with people doing line might be, coming to us, chemo embolization, basically. And honestly, with a disease like that, you welcome everything. You hope something will work, whether it be lifestyle. But I think my hope in all this is that this is not going to replace surgery, radiation chemotherapy. I hope that this could, one day become something that all of us can do for these patients as adjunct therapy. So not one, maybe two injections or 3 injections, different chemicals, and that kind of stuff. So I think this will hopefully have an adjunctive, even here, it's not a panacea, right? Most people are just strictly and die afterwards, so.
Is your protocol currently open if you have patients that would like to explore that?
We're just reopened right now because interestingly, we have to remake the virus, so right now, it's stuck at the FDA. I think we can get it reopened. And we're trying to finish this one last patient. That's the first protocol, a single center study. But we'll love to, we'll have to expand this. And also, you guys have, affiliation, collaboration, and energy. So we'd love to get you guys to follow once we extend. I think we'll soon, we'd love to. And I think the other thing, Carl, I think this kind of goes back to the cancer therapy. I think the way of doing this is good because it makes you really want to see if this works because, like, let's say they infuse the thing. You think of the tumor, there's no virus, there's nothing. Then we know we're wasting everyone's time, So I think that would be an important step. I think as painful, this is like about a 10-year worth of work, but as painful as it is, you like that knows something doesn't work. So that's I think.
Thank you.
Well, thanks everyone. Thank you.
So we're gonna continue here with a frequent flyer. He typically comes to Jacksonville because he has family ties. But this year, I think it's too cold in Worcester, Massachusetts, and Professor Gunis got frozen there. So he's talking to us from a dark room somewhere in the world. Matt, even though you're not here, we love you, man, and looking forward to learn from you again. Welcome, my friend. I hope that's a glass of beer. Oh no, pouring coffee or good disguise, I would say. Thank you, Matt.
Looked at the agenda, it looks like an incredible meeting, so congratulations as always for putting together wonderful content. I was tasked with talking about new developments of brain aneurysm treatment, and I kind of want to tag on some of the stuff that you guys have already talked about earlier today with Ivana Frozen talking about aneurysm inflammation, Vince talking about aneurysm genetics, but would be remiss not to mention what's happening in the device side. These are my disclosures. AJ Lockley and I, when we were working together here at UMass almost 20 years ago, put this slide together, and I wanted just to point out it hasn't really changed much. So we had the development of endovascular techniques really exploding with the advent of the detachable coil, and then stent-assisted coiling and flow diversion, and now we're entering a new era of intrasaccular devices. But really, the target ultimately has to be the pathophysiology of the aneurysm to render effective treatments. And we're still not quite there yet, but I'm going to talk about some of the things that we're working on. New technologies that are imminent. I'm going to briefly mention optical coherence tomography. I know you have a whole talk on that tomorrow. So I'm just going to briefly mention that. Intrasaccular devices are quite the rage right now. Very safe technology, one and done, more efficient procedures, and then of course novel coatings and surface modifications. Just want to briefly introduce the intravascular imaging technique. It's basically, this is the optical probe. It looks very similar to an 014 guide wire. It generates real-time micron level images, and it's very much analogous to ultrasound. Instead of using ultrasound, though, I use near-infrared light. So you look at the light that scatters back to the probe, and you can characterize the optical characteristics of the tissue. And so this is a case done by Vitor Pereira. This is a patient with multiple aneurysms, and here we're interrogating this relatively small middle cerebral artery aneurysm. And what's really interesting about this pullback, so these images are generated in real time, so you can see this is the actual probe being pulled back through the vasculature under a contrast injection. And then you get this micron detailed information about the vessel wall, and we can see it's actually the vessel wall looks relatively healthy. It's got a typical 3-layer appearance, intima media and adventitial surface. But this aneurysm was small enough we could actually interrogate the dome of the aneurysm. And even though it's a really small aneurysm, this is quite what we would consider histopathologically a very dangerous aneurysm. It has a very thin hypocellular wall, just not a lot of cellular content in that wall. We can see the actual disruption of the internal elastic lamina, so we can define with histological precision where the aneurysm really begins. We didn't see clots inside of this aneurysm. Here's just highlighting some of the details. This is the dome of the aneurysm, again, about 30 microns thick, hypocellular, has very little cellular content, no smooth muscle cells. And if we look at Ioana's paper from back in 2004, this would be considered a class D aneurysm, hypocellular thin wall, of which 100% of the aneurysms in his series that presented with this type were actually ruptured. So we presume a very high rupture risk. He did notice in his series that all of these aneurysms had adherent thrombus on the wall. But as I mentioned, they were all presented rupture, surgically clipped. So that thrombus could have been present after the subarachnoid hemorrhage. What's new in terms of intrasaccular we're seeing is, this is obviously the microinvention web device. This device was introduced a number of years ago. We had a lot of experience with Europe before it was trialed in the United States. What's amazing about that trial was there was a 0.4% risk of morbidity and a 0% risk of mortality, so incredibly safe technology. One of the concerns that I'll present today, though, is the durable aneurysm occlusion. This device is under trial. It's ending that trial soon, so we'll have that. And then I want to present a little bit of our data on this newer thing that's also this Arc Seal device, which is being trialed. And of course, there's these aneurysm assist devices, the Nautilus system, which protects the neck to allow coiling. There's the tetracoil from Stryker, and then the next step. All of these are coming. One of the questions that we had, it's a broad category of these intrasaccular aneurysm devices. This was a Medina type coil. Was that it seemed like one and done works sometimes. In other cases, though, there was recanalization, very similar as we see with the web. And using this technique, these are preclinical bifurcation aneurysm models. We think we know the answer. It really requires reconstruction of the neck. Here you see this gap that was present using this device. That was where the microcatheter was inserted in the aneurysm to deliver the device. When the microcatheter was withdrawn, it left this gap at the neck, and that led to recanalization of the aneurysm with compaction of the device at 6 months later. Here we see actually what looked like on our standard angiographic imaging is a very poorly deployed device. It did completely reconstruct the neck, and we see here 30 days later, which was persistent to 6 months, complete exclusion of the aneurysm from the circulation. So it doesn't really matter the angiographic appearance of these devices. You really need this kind of information that shows how you're reconstructing the neck, how the device is opposed to all aspects of the aneurysm neck in order to adequately reconstruct that. And this was, of course, we're engineers. We say that to measure is to know. And then we made these measurements, including scanning electron microscopy and comparative optical coherence tomography. And we were really accurate in our predictions of aneurysm neck coverage. And like I said, aneurysm neck coverage was very consistent with complete aneurysm occlusion. And we can follow this at multiple time points and see the gradual healing of the aneurysm neck. In this case, a sidewall aneurysm, that was one of these devices was placed, so we can see how it heals over time. What we did find with the web devices, and we think these data are fairly conclusive, again, using optical coherence tomography, is a different type of saccular aneurysm preclinical model, where we found that when the device was flushed with the aneurysm neck, it would readily endothelialize. So that tissue, which is the curative event, was growing over the device. However, much like with flow diverters, when it prolapses into the main vessel, that milieu where you're in the main slip lines of the flow doesn't allow robust cellular attachment, at least in the early period. So this leads to complete aneurysm filling at follow-up. And we studied this, and we have a fairly robust prediction algorithm that when the device is herniated in the main slip lines of the flow, that is predictive of delayed aneurysm treatment. So at the early time period, the aneurysm isn't cured. And we decided to apply a similar methodology with a new device, the Seal-It device from Galaxy. And we found really high rates of angiographic cure at only 12 weeks, as shown here. Whereas it was quite consistent with the web device to have filling of the aneurysm. And we were able to study this again with optical coherence tomography to understand what's happening. Again, the device is at the level of the neck, not excellent apposition with the wall, but because of this construct, this dual layer construct, we found that it had a great amount of tissue growth, 86% of the device was covered with tissue and across multiple aneurysms. I apologize, this jumped ahead. And so what we saw is that this new technology, complete aneurysm occlusion was observed angiographically 80% of the time at that early time point, 12 weeks. However, what was interesting was that in the 20% of aneurysms that showed, here's the case, an angiographic remnant, when we did the histology, it was actually a completely new wall inside of this herniation. So in other words, the aneurysm was in fact protected histologically from any kind of rupture risk. What about these new generations of coatings? It's a very hot topic. In this coatings, I'm going to speak specifically to fluid version, but they could be applied to any kind of device. And we all know why the feared thromboembolic complication occurs. It has to do with your house triad, which was described well over 100 years ago. It has to do with the blood products themselves, has to do with vascular trauma, it has to do with the flow environment, where circulatory stasis can lead to thrombus deposition. And so the first thing that we know is we introduce a foreign body into the bloodstream, and then you're going to have contact activation and thrombosis. The platelets and blood products will react to this foreign body and cause a thromboembolic event. Looking for solutions for this, especially in cardiology, has been ongoing. This paper was from the 80s. This proposed using phosphorylcholine, so basically a fat, to hide the surface of the device from those blood products. This has been very successful and has been introduced by Medtronic as the pipeline shield product. Again, it's a surface modification where it's a chemical process in which phosphorylcholine is coated the device. And this has been robustly studied across multiple models, including blood flow loops, ex vivo primate shunt models. Demetrius Lopez did some pig studies, I did some rabbit studies, and we found routinely that it is indeed prevents platelet accumulation on the surface of the device. And then another solution is presented by Phoenix. This will be coming to the United States. It's instead of using a fat, they're using a sugar. Again, hiding the device from the circulation so that you don't have platelet activation. And that implant has been shown in various, both in our laboratory in vivo models, a number of other in vitro models. It does in fact resist platelet accumulation on the surface of the device. But we have these cases where the goal being aspirin monotherapy in using these devices where they've shown all these great results preclinically, but in clinical experience hasn't always worked out. And the question is why? We're not solving all the problems by hiding the actual prosthesis or the metal from the body. What else happens? Well, here is an example of an anterior spinal artery in a dog. Eric Savageau and Ricardo Hanel showed me many years ago about how to place stents in the basilar artery of the dog. And we do this by going through the rather large ventral spinal artery. And why I'm showing you this picture is because on scanning electron microscopy, we can see that just microcatheter navigation alone, you can actually see where the microcatheter went because it disrupts the endothelium. It actually completely removes the endothelium. And this picture is quite compelling because it shows exactly where the catheter stopped. In this case, it was just an SL10 microcatheter, and where the wire was navigating beyond that. So you can really see on the vessel the path that your devices took. Now, I would argue if a microcatheter is doing this, obviously when you're deploying a flow diverter or an intrasaccular device even, and you're doing all these manipulations, that's going to cause some level of vascular trauma. And when you look really closely at where this endothelium has been removed, here's a subendothelial matrix, you of course have platelet aggregates and cells that adhere to the vessel. So how do you stop this? And one of the ways that's been investigated in cardiology is using heparin-coated surfaces. So this covalently bound heparin, they're not drug-eluting devices. You bind the drug to the surface of the stent. And what that does is it changes the whole thrombin reaction. So antithrombin is activated and it creates not just an anticoagulation effect, but it also has a profound antiplatelet effect. And this has been trialed. I want to point this out. We kind of lose this trial because it was in cardiology and it was done a long time ago, 2003 it was reported. And the excitement for this technology completely went away with the evolution of these anti-proliferative drugs and drug-eluting stents, such as rapamycin or derivatives thereof. But this study was really interesting because it's the only trial that I'm aware of where it was done with patients under monotherapy. So this is treating coronary atherosclerosis, doing an angioplasty, putting in a balloon delivered stent, and then getting these patients only aspirin in a very thrombogenic milieu. And they didn't have any complications. They had 2 early stent thromboses. The one case, the patient had a platelet disorder, and the second patient had a blunt force chest trauma. So it was secondary to that event. But in the remaining patients, there was no early stent thrombosis. So very promising aspirin monotherapy intervention in the coronary circulation. So we've tried this now in vivo on floaterburgers using the same technology. This is by Stryker. It's a technology from Carmita, which is a wholly owned subsidiary of Gore, where they covalently bind the heparin to the stent. This technology has been around for decades, but it has never been investigated for neurovascular implants. And so here what we did was we implanted overlapping floaterburgers in the basilar artery of the dog, so intracranial circulation. It's a 1.3 millimeter vessel, overlapped the stents, and we didn't give any antiplatelet therapy. So absolutely none. This is a very aggressive model. And we tracked over time what happened. And here's an illustrative case of a bare stent. We have a mid-basilar thrombosis. These are young, healthy dogs. They tolerated this very well. I was quite surprised that 60 days later, and 180 days, I'm sorry, this should be 180 days, we have thrombosis of the mid-basilar segment. And then we did look and we found these hits on susceptibility weighted imaging, which we believe are blood products in the vascular distribution of this stent. And this is a coated device, kind of typical. We did find one of these MSA lesions, but at further follow-up, we didn't find any. Interestingly enough, about half of the animals in each group, coated or uncoated, the mid-basilar artery did thrombose. But we did find it very interesting. We only did angiography at the final time point, 180 days. But we found that it correlated very well with the MR angiography, where if we saw the tip of the basilar, that meant that the basilar artery was patent. So we did see a delay of the thrombosis in the coated sample group by more than 1 week. And then we did find that the accumulation in the acute period, when we did optical coherence tomography and had a microscopic view of the stent, we measured how much acute clot volume was on the surface of the stent, and that correlated really nicely with the presence of these susceptibility weighted artifacts. Another interesting thing is these susceptibility weighted artifacts. If we did have a flare lesion, as shown here, indicating ischemic injury, this was consistent with the presence of these artifacts. And then we also saw that they corresponded with histopathology, where we saw inflammatory cell infiltration, we saw gliosis, and even evidence of hemosiderin, so hemorrhagic transformation. And what's interesting is that with this coated technology, we had a dramatic reduction in the number, and statistically significant reduction in the number of these magnetic susceptibility artifacts, indicating to us that this device, in an extremely aggressive model, I want to point out, overlapping floaterburgers, 1.3 millimeter intracranial vessel with no dual antiplatelet therapy. In hindsight, I thought maybe it was a little bit too aggressive, but we did find a reduction in evidence of thromboembolic events. I'm really excited. This is an article that came out of France, in the north of France, where they have figured out how to, I talked about heparin, again, it's a very mature technology. It's been around in the space for 20, 30 years. This is binding both an anticoagulant and a 2B3A antagonist, a protein 2B3A antagonist on the surface of a stent. I think this could be really exciting. Obviously, this is still investigational, but this could be a very powerful solution to prevent thromboembolic complications in neurovascular implants. Another solution that's been proposed by a number of people is to modify these devices, again, either intrasaccular or floaterburgers, to more rapidly recruit cell attachment. So this is some work that Satoshi at UCLA did, where they use UV passivation to improve the surface chemistry of devices. And this is just a basic study, but it shows increased albumin absorption, increased endothelial cell migration and attachment to the surface of the device. This is some work that we did showing that endothelial progenitor cells do indeed participate in the healing of floaterburgers. Of course they do. We've known that in the coronary system going on 30 years now. And this is a coronary device where they do have on the abdominal surface, they do coat it with CD34 antibody peptides that kind of bind these progenitor cells to allow more rapid endothelialization of the device. This technique is being pursued in France. Again, this is by my good friend Aymeric Rouchot, who is showing it using a PARI peptide on the surface of a flow diverting stent leads to more rapid endothelialization of these devices. This is the early work published in Stroke that's showing more favorable endothelialization at earlier time points. What do I think the real opportunities are for the future? And I always try to share new stuff with this group. I think theranostics could be really interesting. This could be for aneurysm screening. You know, instead of using such advanced imaging like MR, CT, I mean, proposed optical coherence tomography, being able to screen just plain film X-ray if patients have, and I'll show you how I think that could be done. Also, you know, use of nanoparticle delivery systems that are specific to brain aneurysm could lead us to the work that Ioana and others have been doing to find molecular targets to try to stabilize unruptured aneurysms so that you don't have to do a surgical or an endovascular treatment. And then malignant aneurysms, I love following Peter's work. Peter is doing some really interesting things. There are these aneurysms, and I'm not going to show any here, you guys are all familiar with them, that are just, they're usually quite large, they're usually very complex in the posterior fossa in particular, but can be in other places in the brain, where you know, you do this great endovascular repair, you do the best surgery, and they just keep growing. You see them on cross-sectional imaging constantly growing. Is there something we can do? There's a group in Japan that's doing microcatheterization of the microvasculature that's supplying these aneurysms and are embolizing it, but could we do something like what Peter's presenting and treat them more like malignancies such as brain tumors? And I think that's an area that could be explored. This is some work that I did in collaboration with the Technion. Mark Epstein led this, and he's now joined our group as a postdoc. But they're nanoparticles, and they're delivered targeting both the physical characteristics of the blood flow in aneurysm as well as molecular targets of the aneurysm wall. So this is just a simple CFD showing you a two-phase solution where, depending on the density and the size of the particles, they accumulate in brain aneurysms, whereas they don't attach to the blood vessel wall. This is just some experiments done on the bench. We later did real flow experiments, but then working with Professor Bauwachs in Germany, Tübingen, we've also functionalized these nanoparticles, coating them with glycoprotein 6, which then binds to the collagen. And in a lot of brain aneurysms, we hear a lot of work about endothelial cell transduction of mechanical forces and what that does to the aneurysm wall. But if you study Ioana's work really carefully and you do histopathology of these aneurysms, you find that a lot of the aneurysms is not even covered with functional endothelial cells. So we think targeting some endothelial matrix might make sense, and we did this in vitro where we have these models that they have endothelium in the parent vessel, some injured or lack of endothelium exposing collagen in the aneurysm sac, which we know characterizes a lot of human brain aneurysms. And we see accumulation of our nanoparticles just in the aneurysm. Now, I would argue if we could get sufficient contrast, we could load these nanoparticles with contrast agent. This is what I was talking about, maybe just a plain film X-ray to screen patients for brain aneurysms by looking at an accumulation of these targets inside the aneurysm. And then, of course, you can, if we can find suitable drug targets, you can load these nanoparticles with a medication to hopefully stabilize the aneurysm. A final example, we found a way, following the work of Serge Marbacher, he's in Switzerland. He has done a lot of work on decellularizing aneurysms, and these aneurysms tend to grow. They tend to have a lot of inflammation. We prepared saccular aneurysm following those techniques by decellularizing the wall. And then indeed, we find accumulation of these nanoparticles inside the aneurysm, but they're not, they don't attach to the healthy vessel wall. So a targeting mechanism for hopefully theranostic work in the future. I really appreciate the opportunity. I think this is one of my favorite meetings of the year. I'm really sorry I couldn't be there in person. And Ricardo, please don't tell my mom that I didn't come down. She literally lives about 3 blocks away from the hotel there. So she doesn't know I had this invitation, and I would be in a lot of trouble if she found out. Thank you for listening, and would love to see if you have any questions.
Thank you for putting on a silver plate for us. We know how to get you here next year. I know what you call, I'm not calling you, calling mom. I have this invitation for your young son. Brilliant. What do you think about, is there a way in your brilliant mind that we could get stem cells? Again, I just did yesterday, this poor guy. I did a full metal jacket on his vertebrovascular fusiform, enlarging, and now this guy has a bladder cancer that needs surgery. He's on Eliquis and Brilinta, and I have no good way to discontinue this. So is that a brilliant way to put stem cells and talk about drug on these walls? You have an idea if there's a way we could put the stem cells there and get them to get trapped and proliferate?
Yeah, I think so. It's really promising work. The stuff that Amerique Bouchot is doing shows a lot of promise. There's just really, Ricardo, this becomes a market problem because now you're doing a combined device with biologic. And that regulatory pathway is not straightforward. So it really becomes a market size problem. Maybe as an HUD device, this has potential. But it's a big undertaking to get these devices through our regulatory systems.
Any other questions from Matt, guys? So I'll keep going here. I have 7 more minutes to Victor gun. So what about you showed this beautiful basilar model with Mystique from Stryker. Your thoughts about coding, because again, we are all very excited with phosphoryl I think it's a step in the right direction, but it'll take thousands. Every time somebody asks about that, I think it'll take thousands of patients to show a difference, not 100, not 200. Do you think the heparin coated Mystique from Stryker, it seems more powerful than phosphoryl on the end?
So I definitely, thanks a lot, Ricardo. I really appreciate the question. I agree with you. I think the trial that Perot is running to look at, and you guys have done similar work with the existing Shield technology and a retrospective review. But I agree with you. It's going to take, first of all, it's not going to be clinical. It's going to be neuroimaging. And it's going to be looking at the size and number of diffusion, areas of diffusion restriction. And it's probably going to show maybe a minimal effect. And that's because you're not fixing everything. Just by hiding the implant, you're definitely, it's a step in the right direction for the very important step to do this work. But I think the next level is an actively bound drug surface. In coronaries, it never took off despite positive results. That's simply because it wasn't their problem. Their major problem was proliferation of the lesion causing lumen loss. Where that doesn't seem to be a huge problem for neurovascular implants, our big concern is obviously thromboembolic complications. I do think these drug-coated devices, again, I want to really emphasize, they're not eluting a drug. The drug is covalently bound to the surface. So putting a P2Y12 inhibitor that requires metabolism through the liver, that's not the target here. The target is a direct effect like heparin or tyrosine was another example I showed. And I think these particular agents are really going to change the game for neurovascular implants. I think that you're going to see a dramatic decrease in the risk of thromboembolic complications. And again, it's probably going to have to be a neuroimaging-based study. Fortunately, these complications aren't so prevalent. But if you do look, there was a French study done a few years ago where people are putting flow diverters, and I don't know what the practice is at Baptist, but they are going more and more distal. So they are, even though it's off label, they're putting a flow diverter across an M2 branch to treat an MCA bifurcation aneurysm. And you've had Sarwo present on this before at Jackson. They're also, I see a lot of ACOM aneurysms being treated with flow diverters. In those situations, I do think, and if you look at diffusion-weighted imaging, although the patients are intact, based on the standard assays, there's a very high rate of areas of restricted diffusion. So I think in those settings, these active coated drug devices are going to be superior to what we have.
You know, as you said, we publish on that, no difference on bare metal pipeline or shoe pipeline in our series, about 60% on both groups, so we're definitely looking forward to something else in that direction.
Yeah, you guys always lead the way. I saw that paper and it is discouraging. I still think if you had the choice, based on the propensity of data that we have from all these models, I still think it's worth it to use a coded device versus an uncoded device. However, I think the next real big change in the findings that you had with diffusion rate imaging, I think it's going to be with these drug coded devices.
Nobody else have one more for you? The mass of 64 wire flow diversion brain deformation. What's the engineer brain, why we're seeing that?
Yeah, I specifically stay away from the topic. It's obviously a very hot topic. We do have, Pedro did an OCT of one of these cases. So take a step back. We first have to make sure, and I encourage everybody in the audience when they're looking at their data, that we're all using the same terminology. The cases with Vantage that I've seen that were called brain deformation, there was one case where a patient stopped taking their toilet therapy and it was an acute thrombosis. It's not a brain deformation. There's a couple of cases of hypoplasia. That's not a brain deformation. So Jens Spieler wrote a very nice paper. I was happy to collaborate with him on that, and we put together a nomenclature that I hope everybody follows because it's going to help us to make sure we're all talking about the same thing. These brain deformations are indeed happening. They're happening not just with Vantage, they're happening across this broad class of 64 wire devices that are made out of softer materials. They have DFT, some of them, and it's typically the cases that I'm familiar with. We reviewed a lot of these. It's typically in younger women. I think based on the imaging that we have, okay, n equals 1, that it's a vasoreactive response that crushes the device. And frankly, the OCT that Pedro has, it looks like vasospasm. So it's concentric thickening of the media that's basically squeezing the stent. Now I know what everybody says, that's crazy, goodness. There's no such thing as chronic vasospasm, and I accept that. But the data that we do have is suggestive that that's the underlying mechanism, that there's a vasoreactivity that the device mechanically cannot resist. So it's a mechanical failure of that process. I just hope that with the advent of neurovascular OCT, which Demetrius will talk about tomorrow, that we'll get more data to support that conclusion.
Thank you, Matt. Read it as usual. Any other questions for Matt? I'll let Matt go and we'll jump next. Thank you, Matt. Appreciate it.
I'll see you in person next year, okay?
Thank you, thank you. We're waiting for Dr. Ricardo to be in a second.
So like what American Airlines website, they don't show up and it's the bottom of the screen. Figure out what is that?
Send you an email too. And it'll have a switch here for your reporting.
I usually and they usually earlier study. Oh.
That's not. Can we do like that? Rare. Because there's a lot of time that I see waste that could be spent on making sure that the park is good. So, I'll invite you to that. In terms of the audit, okay.
Guys. We're having connectivity issues with the next speaker, so we're gonna do a 15-minute break, so we'll come back at 2:15. 2:22, 15 minutes long for the next final three. Thank you.
Hey guys, I'm gonna do the housekeeping update. Apparently the bathrooms are out of water, but there is a beach nearby.
Brazilian Indian style.
If we don't check angioedema, then we're gonna.
Oh, yeah.
That's only if that's CAK, right? Okay.
Yeah.
They need to know that too, like, stop.
My grandparents,
Unless they had.
But it was nice, we had a bunch of dogs.
Right now, they don't even know to take one professional doctor, go doing a leg, that's too. Yeah.
Went to high school together and coordinated in high school and connected on Facebook, and then she started talking about
If they would have done it, like go see breathing.
Yeah, and like
It'll have like one more nurse that show, but my body has deep patient. Yeah. Yeah. So you can definitely different those. Yeah.
Well, they're going to less.
Bring it up with Jenny. Maybe even her. Especially now that they
that's why.
Yes, it is. I will send you. Is it just tonight? It's one in the morning, but there's enough people to do it. Yeah, we can. I'm gonna go ahead and go. Yes, I'm hoping they come tomorrow. I'll text you later. Yeah, I hope so. I just have to find out if there's enough people. To do the,
Not on Monday. And I tried to change my name, but I said right now. Yeah, that's my fix, like, I don't. So like, I'm not listening to them, but they know that that's not your fault. You know, like, I see people talking in spite of violence and just like, oh, yeah, I'm like, no, I don't think about it. Like, trying to.
Is that downtown?
Yeah, that guy walked south all my life.
I'm just walking on all the patients are there. You can tell they don't know where they are.
They asked me because I'm like, stuff and I'm not that I personally do it. South people,
It's like a noise downtown. Get out of here. What do you want? I saw this town. A little bit around this. Where's that? Paul family's place. It's just like that. It's in downtown. Boston.
They're like a couple of days ago, like I had like 4 patients. One was like, so like I actually got like 10 pounds, like whenever I'm down, I like.
I'm in a pavilion building. And I had to visit a nurse resident who said Riverfront.
Yeah.
And we had to walk down, it's called the rabbit hole. Yes, the rabbit hole, way down the hallway to Riverfront.
No, it was there. I'm like, I'm just going to the tunnel all by myself.
It's a tunnel, yeah, it's a tunnel leading to P1 Park.
And I'm like, it's so quiet. I made it. Amazing.
There's different parts that are connected on different floors. Our hospital and the tower are connected on the floor. It's like it all.
I always have to come down and go to the
I'll figure out before I retire. I'll figure it out.
like now this is yeah, like if you start with anything like you start with like
Oh, yeah, yeah. They have signs there now. It says something.
If you go to patient in the middle, It's funny, I still get things from you alert warning. Yeah, I'm like, oh, here that happened again over there.
I hear somebody. Father would ask me like. No, I can't.
Yeah, emergency alert. Yeah.
It's not that bad. It's not.
It's like a parking lot. Yeah. Yeah.
He's driving. My son is. He's 21. He just turned right on the house. Yeah. Well, I'll have to look upstairs. Actually, maybe. Saturday.
Having fun?
I am.
You know, I came here a few years ago, I had. Yeah. And this pulled in, only valid. Yeah, I hate LA. So at the end of the day. It's not that, well, yesterday it wasn't so bad because they had the reception, people were kind of trickling out, but you're right, we may have a deluge. That's what I heard. Deluge, thank you. So I'll probably, yeah. You're feeling well? Yeah. Good. Yeah. Okay. Yeah, it'll be fine. Okay. Good.
Yeah. I was like, I saw her on Friday, and I'm
We'll be leaving a little earlier than yesterday, which will help, because the traffic on the way home yesterday was like, yeah, but we left later. Because we had that, we had the reception. Oh, the reception. Yeah. You almost have. That was, you see the gap? Yeah. They eliminated the gap. And see what. Five thirty. It was bad, traffic was bad. It's like 30 minutes to get here, an hour, 5 minutes to get home.
Like an hour.
Yeah.
I think if you go, during the traffic time, you go over now. Then you go. Yeah.
I'm gonna be going back with that entire area, so I don't know if I should say on land or chance the Matthews Bridge going over or.
But it shot me, why, I don't know, to take 295 loop around, but then again, I live out, on the west side, so. I don't
It
know.
often went that way.
Oh, really? Sometimes you do that, because the traffic.
Yeah.
It sometimes does that.
Yeah, it's like this.
Instead of sitting in traffic, you take a ride.
And that's what it is, right? Yeah. And it was very,
Yeah.
I guess I'll let the GPS.
I do that. That's what I do. I let the GPS tell me. I just say, yes, ma'am.
Follow.
What do you say here? Yeah.
I like that, it's a nice place to be. Sometimes they like. Yes.
So I got a question for you.
Yeah.
That's the only. Is that what the one I asked? Was there a party? So much a bigger question. Oh, okay, good, good, okay. I didn't know. Everyone's asking questions are all brilliant. Simple things in life, you know? It was kind of anatomy.
That one.
Yeah.
I don't know, it's some family care, I'm not really sure. But she had a very.
So.
Oh, she did a good job. I thought.
Good job.
Yeah, I like that song. I was, yeah, I was. Yeah.
But by own summer,
Oh, they're all.
At least walk around here.
Well, it's not just fancy.
Let's move
Yeah.
highlight.
I
We're just talking out.
Yeah, yeah.
We earth, people on Earth one.
Like that guy who's in the book through there. I'm trying to follow it.
Yeah, I was doing the same thing.
So I used
It was coming to me, sitting right over.
Yeah.
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 Somebody lost.
Yeah, that was a little bit cool. I'm gonna try to follow him.
He put on some.
He put on, yes.
Because he wanted, he might have.
He had plenty.
Probably an earlier time. I like the idea. Maybe.
So the people wearing suits. Style.
That's the favorite.
And I don't understand. It looks psychotic to me. Oh, it's like, put it on.
$5,000. You have 6 high, and you walk around and you walk around in tents. Yeah, constitute Johnson. So I, what happened? They know they picked them. Oh, I didn't know that. Oh, my God, I'll tell you, will you tell me when you want to say first? I'll tell you. Yeah. It's a Hanel. Yeah, really? He could dress, but he also. Oh.
Which part of the world are you on? What part? You're all.
Oh, I don't know.
Hello, Chris. Hey, good turn. Boa tarde.
I like them.
Hey, Dr. Hanel. Oh, perfect, perfect. Are you doing that? Can we have this screen of Dr. Herrera? I don't know where, there's a little game, where's Waldo? I think Andrea and the Herrera family played that at home. Where is Peter? Last I saw he was in Brazil, and then last I saw he was in Orlando, so we don't know where Dr. Pereira is, but it is our distinct honor to have Victor Mendes Pereira, my fellow Brazilian brother that works now in Toronto. We're just together in Brazil at Link, honoring Professor Moreira as his mentor and our dear friend. We have a joke that all roads lead to Toronto. That's nothing new happening in endovascular that doesn't pass through Victor Pereira in Toronto. So it's an honor to call you a friend. And this year we'll get to go with a virtual, but next year we need you here because you're true valuable to be here, giving your input and opinion, experience, and everything that we share with the team today. Today, Victor is going to share Cerebrovascular, the next frontier in INR, and all the work that he's doing on that. And tomorrow, Victor and Nicole, his right wing partner, going to share with us robotics. So, Victor, thank you very much. I know how busy you are, my friend, and really appreciate you making time to talk to us.
Thank you, Ricardo, and the roads coming to Toronto, from Toronto, or it comes from Jacksonville. And it's a shame after all this collaboration that I had the opportunity to come there just for a meeting in one of the studies that we collaborate, but definitely on the books. So I'm in Toronto. I haven't seen Andrea today. But I'm here, I have procedures and I have my clinic on veins and patients coming from all over the place that is very hard to move and the book months in advance. But thank you very much, my friend. And it's a pleasure to be talking to the audience. And I think last few years we've seen a lot of innovation and a lot of discussions about the things. But in fact, the knowledge and the understanding of the veins has been there for a long time. These are a few books from the French schools. Professor Moret had done a lot of work on the spine that Walid used to do his work in hypertension. And I also have worked when I was with Professor Lejegas on the evolution of the venous system. That certainly gave me a very interesting perspective. Sang, who is the first author here on this paper below, he studied the whole venous system of all the vertebrates, and we discussed every week. And with Professor Lejegas, that was a big fan of veins. And he always said that the venous system has a lot of what we don't understand. And today we can assess the venous system in a much better way. This is a 4D CT that is here showing a venous stenosis. And this is part of the new insights that we have now on the veins. And we've been using the veins a lot as root or as source of embo. So we all know the classic transvenous embos for fistulas, mechanical thrombectomy for venous sinus thrombosis. The transvenous approach for brain AVMs has gained a significantly predominance in the last few years, and particularly the work with René Chapeau, Chagamounier. This work has been pretty widespread. But what else? What can we talk about veins? So for many years, we only knew that veins would be the outflow, and that most of the reports, our colleagues in radiology, and I was just talking about it with our patients that don't even pay attention to the veins, and it's not uncommon that we see pathology of the venous system with report that everything is fine. And we also know with other diseases that the venous system can impact somehow the functioning of the brain. Look to this case. This is a 59-year-old patient that has a progressive cognitive decline. And you see on this brain, there's a lot of small vessels, the small transmedullary veins are dilated. These are abnormal signs on MRI, and contrast injected, you can see a lot of veins. And this is a case of a fistula. This is the angiogram of that patient. And here on your right side, we can appreciate what the French school called pseudophlebitic pattern, which is like veins that are dilated, the capillary venous system, and it looks like an inflammation, but actually is reflux because of a venous outflow restriction. And just to point it out, this patient only had cognitive decline, but because of this functional obstruction of the outflow, the brain function was impacted. And there's certainly a cause effect between the brain and the venous outflow. And until recently, we didn't know how this could be possible. And there's, in the last few years, discussions, it sounds like diets. 1 year, the hyperprotein diet is good. The other year, is ketogenic diet is good. The other year, no eggs. The other year, more eggs. And lymphatic has been a culprit of many things, including dementia, but it was initially described after one of the decades of the brain. And it's supposed to be a flow from the periarterial space to the perivenular space, passing through the brain parenchyma. And there are liquids and substance that can be washed out and flowing inside the interstitial space on the brain. And there are a couple of MRIs, very experimental, that can detect and depict some of this flow, but yet to be fully understood and how it impacts the brain function. But we know that somewhere in the system is where the veins can actually influence the brain by increasing the size, by making the brain more swollen, by changing the function of the brain. And that's also what we reported here in our paper on the hypothesis of IIH with Stephanie Lang from Princeton that does a lot of research, animal research on that. And the hypothesis is that some of the aquaporin receptors disrupt this water transportation between the periarterial to the perivenular, and will produce an accumulation of liquid inside the interstitial space. And that will make the brain increase in volume and impact secondarily on the venous system. Let me show you a case that we illustrated on that paper. This is a nurse, a patient that is followed here for many years. And she presented with papilledema. And you can see here 2 MRIs in different stages of this patient. In 2013, you can appreciate the sinuses, those transient sinuses on the corner of the imaging. And in 2017, we can see that these sinuses are reduced. So the patient is more symptomatic despite of having a shunt and high doses of diamonds. And we can understand that actually what happens here is that the brain, the overall brain volume is bigger. You see that all the CSF spaces between the brain and the dura are not seen on the convexity, and the sinuses are smaller just by compression. So this is the mechanism of IIH. So there's something inside the brain. The hypothesis is that is one of the aquaporins, mainly the aquaporin number 4, that will induce this increase of volume of the brain and then secondary compression of the brain. And then it enters into a loop. And when we discuss this effect with the neuro-ophthalmology community, this mechanism is considered secondary. So this stenosis is caused by the brain volume increase by the primary disease. But we've been also seeing something, which is a primary stenosis of the brain actually causing a venous outflow issue that's similar to that patient with a fistula will then develop other symptoms related to intracranial hypertension. And that question of who comes first, the chicken and the egg, is actually here. There will be some cases that there will be a chicken and some cases there will be an egg. And this is why when we see those lesions, we try to separate them by the type of stenosis. In principle, is when it's the venous disease is the source of everything. So it's actually the intrinsic stenosis, and the extrinsic is when the brain is compressing the vein by a secondary mechanism. So it's very important to differentiate those two because it gives us a north. A patient with extrinsic should be managed by a neuro-ophthalmology, lose weight, manage the patient metabolically, and the stent is an alternative to the whole management of the disease. And when we talk about the intrinsic stenosis, then that is a primary cause of hypertension can be the vein, and these patients will not necessarily respond well to diamox, to medication, to weight loss, or to shots. They will actually get even worse. And some of them will also present with something that we call postperitonitis, which is a sound produced by the turbulent flow that disrupts and disturbs the patient quite a lot. And that is a mechanism that sometimes produces the main presentation of these patients. We have done a lot of computational fluid dynamics. Those are 2 papers from my group, where we actually describe the frequencies that are actually able to be transmitted, so there's a turbulent flow that gets to a certain level that can then go through the bone into the cochlea and then really produce the sound. We reviewed cases of many patients and described the method of that we used. And actually, we demonstrated how biophysically this sound is produced when there's this level of turbulent flow. And a lot of these patients, they will also have some degree of intracranial hypertension. We reviewed about 450 patients of postoperative presented to our clinic a few years ago. And we actually realized that from 30 to 40% of them will have some signs of intracranial hypertension on MRI or on the neuro-ophthalmological assessment. So this is why for these cases, actually, the primary stenosis and the primary cause of intracranial hypertension is actually the vein, and the intracranial hypertension will actually be a part of the assessment of these patients, including patients that present with tinnitus as well. So I apologize for this slide, but here it's a slide that is actually showing that for these intrinsic stenosis, the venous stenting can be considered as a primary treatment. Again, these patients, they may not improve with other techniques, and the patients with extrinsic stenosis, they actually will have venous stenting as adjunctive treatment in case they have the intracranial hypertension. And there are other topographies of pathologies that on the venous system that can influence the brain the same way we saw before. This is a slide of a review that we did with a couple of other groups that are interested on the veins that additional to the transverse sinus and intracranial stenosis, there are different levels of outflow restrictions of the cerebrovenous flow that can also cause impact on the brain. The most common site of occlusion or stenosis after the brain is actually the jugular here at the level of the neck. We will talk about it a little bit. And even cardiac or diseases in the subclavian can also cause outflow restrictions and symptoms similar to the transverse sinus stenosis that we saw before. And regarding the presentation, intracranial hypertension and postoperative tinnitus are two of the most common presentation syndromes, but we've seen a lot in patients with chronic headaches, some atypical types of migraine. I just saw today a patient as well that actually had tinnitus and pressure headaches that simulated intracranial hypertension. But actually, these are migraines episodes. She's actually better with nortriptyline instead of, and she doesn't have any vascular occlusion, but it took us some years to get to that conclusion. We have seen patients with 6, 7 different drugs for high blood pressure that actually have an intracranial venous stenosis. And there's a huge line of research of cognitive disorders in young patients with atypical types of dementia or too early onset of non-familial types of dementia that can also be related to those. And we've seen more and more some atypical types of Parkinson's disease that can also be related to stenosis and congestion, particularly in the posterior fossa. So there is a lot more to think about, but I think there's a lot of research, and now as soon as we tackle intracranial hypertension and postoperative tinnitus in terms of treatment and understanding, I think we have a whole new world that can be unveiled, and probably there are more things that we don't even know. And when we also develop an imaging to assess the lymphatic system or whatever system that connects the veins to the interstitial space of the brain, this will also bring a lot of new insights. Let me now just add to this presentation some aspects of pulsatile tinnitus that are important to consider that goes a little bit beyond the transverse sinus stenosis and the morphology of the venous systems that we have discussed. When we see a patient with pulsatile tinnitus, there are three main causes: arterial venous, and venous causes. And we all know classically the presentation of tinnitus of some of the arterial and anatomical variations. This is a case of a stapedium from Professor Lajumia's book of a patient that presented with tinnitus. These are fistulous cases, usually around the sigmoid sinus. They usually present with tinnitus as well. But the venous causes of tinnitus, these are causes that are really increasing on prevalence because we are just paying more attention to them. And those are additional to the transverse sinus stenosis. There are arachnoid granulations, there are emissary veins, there are also venous structures in the neck that can also be related to that. These are a potpourri of images beyond the transverse sinus stenosis that in the past we didn't pay much attention to those on the characterization and look on etiological assessment of the causes for PT, but now they are really getting a lot of prominence. Let me bring you some. So patients with dehiscence, so you can see here bilateral arrows, one showing the normal bone and the other one a thin bone between the vein and the mastoid space. Usually a patient with dehiscence may have a stenosis proximal or distal. If it's a stenosis distal of the transverse sinus, this is a post-stenotic dilatation because the flow comes from up down. And this is a dehiscence that we consider covering when we are planning the extent or the length of the stent. When this patient here will have something in the neck, a stenosis of the jugular at the level of styloid process, this dehiscence can be secondary to that water effect. And sometimes the dehiscence is the cause of the tinnitus, but it's secondary to an occlusion downhill on the floor. And this is important because if we decide treating the dehiscence by putting a stent, or if the ENT will separate or create a layer of bone between the vein and the mastoid cells, if the neck obstruction is not fixed, the patient will remain symptomatic. So it's very important that for cases like that, that is beyond transverse sinus stenosis, that we really have a thorough neck assessment, because we don't want to be in a situation that we put a stent and then you find in the post-operative phase that the patient had also an associated or another pathology in the neck that actually was more relevant to consider treatment than the one we did. So other venous abnormalities, this is a picture of a diverticulum. Again, they are usually associated with a transverse sinus stenosis or with stenosis down the jugular and the neck. And these stenosis in the neck are called ego syndrome. They are usually present in the ENT clinic on patients that have swallowing, neck pain, even carotid dissections. But more and more we see patients that actually they styloid, particularly the patients beyond 50, with the changes on the positioning of the cervical spine. They become a little bit more kyphotic and the vein is pushed forward, and then a compression will start to be occurring. And these compressions can be pretty significant. We actually do a full assessment of them before sending to the ENT or to the neurosurgeon. And they actually can impact the flow and create a huge gradient and really dive and prevent the outflow of the brain in a significant way. Look at this case. This is a patient that had 2 years of right side postoperative tinnitus. And it was worse when he was lying down. And if I'm not mistaken, to another patient, this patient could only sleep sitting up. But this is not an uncommon story. And he had to sleep on a chair because if he's lying down, he would wake up with a lot of headaches. And if you can see here on the first picture of the MRV, there's a transverse sinus coming down and there's no jugular veins. After the sigmoid, there's a stop, and then all the venous drainage is being done through the condylar veins into the suboccipital venous plexus. And in the center picture, you can see how close the styling process of the C1 is. And on the later picture on the axial on the CTV, you can see here how obstructive this situation is. And so cases like that, we actually, after the neurological examination, we do an angiogram and a balloon test of fluid, and then we send to the colleagues to remove the styloid. If we find a gradient, if we are able to stop the flow, sometimes the tinnitus is caused by the vein and not by the jugular obstruction. So it's important to start opening the styloid instead of closing the vein, because sometimes the condylar veins are the only venous drainage of the brain. So it's very, very, very important to do this full assessment in every patient that present with a vascular tinnitus or tinnitus that can present, a postoperative tinnitus that present with some changes on position. I'm putting this slide there is an interesting slide that demonstrates a differentiation between the venous and the arterial postoperative tinnitus on the auscultation. But actually, I do all these maneuvers to see if the tinnitus change. And if the tinnitus change with jugular compression or positioning of the neck, this is a very good sign that this is caused by the vein. And that is already per se, if there is not a transverse sinus stenosis that is clear, is an indication for a cerebral angiogram plus or minus one test occlusion. And this is how we actually start managing these diseases. Patients with transverse sinus stenosis and IIH, we discuss the venous stenting based on primary stenosis, patient symptoms, and severity. We may recommend the stent as primary option. IIH, neuro-ophthalmology, obese patients, we tend to manage the patient first and then the stent as secondary. In the past, I had a practice with IIH. I have a dedicated neuro-ophthalmology that sees all my patients, and she is really on our end. She understands the venous influence on that. And in the past, we used to, even patients obese that she was having a hard time to manage the IIH, we would stand to give them a boost to then continue on the treatment of IIH. So we would stand early and then, but with the intent to give the patient already some relief to move on the rest of the treatment for the metabolic symptom. But I realized that if they are too obese, the post-op is very difficult. They will not improve, they will be frustrated. And that's why in the last year, I have been using a lot of Ozempic to these patients, and I've been getting them already on a good positive pathway, weight loss, improvement, physical activity before doing a stenting of these patients, just to prevent the frustration that sometimes we see with these patients that we have to treat sometimes when, or we decide to treat when they were too obese. And on the other side of the slide, everything else, high-riding jugular ball, bone dehiscence, venous diverticle, prominent veins, eagle serum, we do what we call a balloon test occlusion. We also do a balloon test occlusion to exclude a fistula. We find every year about 5 to 6 fistulas over a good 100 of angiograms, but this is a good number. And just today, I presented a patient with a fistula that came with tinnitus and suspected the stenosis with high pressures. So we perform a balloon test occlusion and an angiogram, and we check for the relevance of these cases. So let me now just show you a couple of treatments. Let's start with transverse sinus stenting. This is a 28-year-old patient that had obesity, very high pressures, and this is the MRV. You can see here that she has signs on MRI of intracranial hypertension, but the stenosis are rather primary, like very short segments, and she had bilateral significant gradients. So we perform the pressures as you saw here, and then we usually treat one side, and we measure the pressure measurements, and we use the new stents called Boss stent. It's a braided stent from the vein. It's deployed through a 5-French distal access catheter. This is actually the result pre and post. It fixed the stenosis on that side, but the patient has still a remaining gradient on the left. You can see here that the torcula has split, and part of the superior sagittal sinus come to one side and part goes to the other side. And at that time, for this case, I have decided to place a stent on the other side. Today, my practice is not to do that. I just treat one side at a time. If the patient is not fully well, we bring the patient back after for a secondary treatment. And this patient, we were able to fix, to normalize the pressures, and the patient improved significantly. And she also had postoperative tinnitus, and it was completely cured. So for everything else, we do a balloon test occlusion, and this is a paper that we published a few years ago with our experience. And we don't do balloon test occlusion for transverse sinus stenosis that we know it's related to the teams of hypertension. But for everything else, we will do. And we first do a complete diagnostic angiogram to exclude the fistula. And then without the patient being aware, we put a balloon and we inflate the balloon in different segments. We start with a big balloon, as you can see here on this picture, and we close the jugular and sigmoid, transverse, and transverse. And we assess if the patient has any symptoms. And if we suspect that there is a vein, mastoid vein, cornular vein that is involved, or a marginal sinus, or occipital sinus, or any venous variation around the foramen magnum, we also consider taking a small balloon, and then we go inside. So these are pictures of different cases. This patient here had a high-rising jugular bulb, and these are usually cases related to neck compression, so eagle syndrome, and the patient by water Hanel will develop high-rising jugular bulb. Sometimes the treatment consists of removing the styloid, and sometimes, like this case I'm showing you here, it's a stent and coil, so we excluded the high-rising jugular bulb, and usually we use venous stents for the iliacs that can stay and make the jugular curve without pushing too much on the nerves. This is another case that we published last year with a different strategy, same thing. I write the jugular ball, looked at occlusion, patient improved, we brought the patient back. And this is the silver stent and a web, a little bit of a high cost treatment, but it was actually very effective to improve the tinnitus, and patient woke up without tinnitus, and it was actually very good. So cases like that you have to fill a space, we can use stent-assisted coiling strategies. This is a 32-year-old patient that had this diverticulum, and we also treated her with a stent, and we placed a catheter to fill the coils on that area. So now some atypical cases. This is a firefighter that had tinnitus, and very interesting, this is a picture of his email self-referring to our clinic, showing that by pressing that area in a sauna, that was the only time of the day that he couldn't hear the tinnitus. We did a CTV and we found this big mastoid vein. We did a balloon test occlusion, and he improved, and we actually coiled. And this is one of the tests we do before doing this specific types of assessment. And despite of having a compression here at the level of the neck by the styloid, this the treatment of the mastoid vein had a lower risk, and the mastoid vein was not taking a big portion of the drainage of the outflow of the brain. That's why we decided, but the styloidectomies is not something that the patients can find easily here in Canada. That's why we do balloon test occlusions, and we tell them in advance, like this was a patient with a condylar vein, but was a little bit between inside the mastoid. And again, we did a balloon test occlusion, and you can see here the occlusion of the vein. And after balloon test occlusion, this is really something we like to do, and we feel safe to do. For the patients with Eagle syndrome that we do an assessment, they improve the tinnitus or they have a gradient, we send them to surgery. This is a picture of Dr. Lawton. And he's also doing a lot of those recently. And this is a CT of the patient. You see here on the center picture how big the stylus process is. And is the vein is the stylus process removed, the vein is open. But sometimes, despite of the styloidectomy, the vein sometimes remain stenotic, or there is a healing process, a fibrotic process that can close the vein again. I have a couple of these patients now currently that we will treat. So this patient had, as you can see here, bilateral styloidectomies. We did an angiogram after that because she was free of symptoms for a few weeks and then came back. And as you can see here, she had persistence of the occipital sinus and marginal sinuses. She had this anatomical variation, but she had no venous drainage through the jugulars. And this is during the angiogram, as you can see here in this picture, there was a persistence of the stenosis. That's the surgery was good. It happens more as part of the healing process. Some of these vessels are pretty tough. This is a first stent that's slid down, and then what we've been doing is we do a balloon angioplasty. So here's it's a balloon with a body balloon, and then for this case we took a balloon mounted stent, and we were able to deploy. And I also try to be not as close to the jugular foramen to not push too much in the veins. And this is before and after what we can actually do. And I think I reached the limit of the time. So this is a very new space. I do a lot of tests when I don't understand or when something is not clear, and I learn a lot of them. And learn a lot from the patients that we should not treat. So patients that are treated and they don't improve, these are patients that sometimes are very heavy in the clinic, so I think I'm very happy with my practice. So today, in a day like today, I see between 15 to 20 patients, and I probably consent 1 or 2 for stenting, 1 fistula or 2, but I consent a lot of patients for angiogram or patients for balloon test occlusion to really understand which ones will be having a high likelihood of success. And I have to share the credits of this work with the team, and particularly the neuro-ophthalmologist. She is on our side, and the ENTs, they give us the best referrals. I've been giving lectures to them and discussing cases. Whenever they understand what we do, their referrals are just spot on. You don't have to do much, and having the neuro-ophthalmologist support for the patients with intraocular hypertension is very helpful as well. But I think if I compare my practice last 2 years, that I've been very close to the ENT Society here in Canada, it had not only grown so much, but the efficiency of the referrals are way better. And we have patients also to send it back when actually we exclude vascular causes. That is also something to keep in mind, because these patients in a neurosurgery or endovascular clinic, they can be also quite happy as well. So with that, Ricardo, promise next year I will be there. We will have tons of stuff to discuss, and there's a lot of new projects this year on my end and doing with you as well. And then I will be happy to be in person there sharing with you. Thank you very much.
Thank you, Victor. We have questions here, Victor.
Thank you for this presentation, very interesting for all regular primary care physicians and hospitalists. We hear this very often, patients with that kind of tinnitus and things like that. So what would be the triggers that will tell us, hey, we need to refer this patient to a specialist?
Very good question. So, first of all, the pattern of the tinnitus, if it's whooshing or heartbeat sound, if it gets worse with exercise, so the sound follows the frequency of the heart. If it improves when the patient lies down to one side of the head, if it improves when we compress the jugular, or if it gets worse when the patient turns the head to one of the sides or tilts the head up or down. And if it gets worse or better when there's movement of the jaw or valsalva minor. So if there are changes like that of the sound of a pulsatile tinnitus, whooshing or heartbeat sound, that those will be cases that will be really indicative of a vascular disease. So what I do here is a CTV head and neck, because that's what I have access. And if the patient will have signs of intracranial hypertension, headache, blurry vision, I do an MRI, MRV with a sequence tricks, which is dynamic, to exclude or confirm a fistula. But in my daily practice, it's easier to find a CTV. So sometimes I ask for a CTV, and then I reassess, and if the CTV doesn't show any obvious stenosis, then the next step is to do an MRI, or if there's something that is not transverse stenosis that I'm suspecting that is obvious in the CTV, the next step may be angiogram and balloon tested fluid.
We need a contrast for the MRI with contrast or without contrast?
Yes, with contrast.
Thanks so much.
And we have Dr. Shem, we have treats available at Baptist, right? I think we do exactly the same series here, so this is available. And we are gonna be part of Dr. Carrera clinical trial that the boss sent that we showed. Baptist hopefully gonna be a site. We're gonna be enrolling patients on Dr. Carrera's study for disposal diabetes. We're collaborating with Dr. Doug Green, one of our neurologists, to find these patients and be able to offer this treatment here.
I'm good, Ricardo. And technically, the stent, it simplifies a lot the procedure. I had a patient, when the patients are a little bit on the 50 to 60-year-old range, these stenosis can be very chronic and the veins are not so easy to navigate. Having a stent that, you know, there's an empty catheter that we can work on the apposition and the extension of the stent as it is deployed is really a must and beneficial.
Anything else, guys, for Victor? Victor, do you have a psychologist, neuropsychologist to have that type of support? Because again, these patients can be very psychologically demanding. Do you have anything on this realm in the clinic with you?
No, I don't. That is a good point. But there's one of the departments here at the university that they have a tinnitus practice. And they have psychologists there. So what we agreed upon is that they send patients to us and we do the workup vascular, and if there's nothing vascular, I just, you know, explain the patient and send the patient back there. Because the psychologist is important, but I realize that it's important if they are into an environment of TOs and audiologists that can help find alternative techniques to improve the quality of life. Well, like white noise, some patients, they will benefit of hearing aids. Some patients, the psychologists will work with biofeedback. So they feel more reassured because it's, you know, you have to change. It's just the way you present, the patient feels about it. And a lot of these patients, they have other issues. And the tinnitus is just one of the reflexes of it. So having the patient in an infrastructure that will manage different aspects of the tinnitus is important. That's why I've never pushed to have someone from our service, because I realize I cannot cover that other portion. And we send them to the tinnitus clinic.
Thank you. And one last one, we have 1 minute. I saw a patient Tuesday in the office, somebody else in a different city proposed. She has low compression of veins, very well studied angiogram done elsewhere. And somebody proposed a venous stent on her jugular because she compressed her jugular when she turns her head. Is this something that you think is there any leg to stand on to claim that the patient is symptomatic because she compressed her jugular when she turns her head?
So
normal angiogram, low compression around the jug when she turns her head, she does decrease the size. And I would love to do 100 normal people without diabetes and how many the jugular is compressed when you turn your head. So that a lot of us, the jugular gets compressed. So, thoughts?
Completely, yes, we do a lot of dynamic tests and the jugular really changes and compress. And you know, these, all, during the test, Ricardo, it's really interesting. We had a patient that only had tinnitus when she would be like in a very weird position. Like this, and she had to turn the head and then at the end, you know, she noticed some changes that of the flow in that specific position, and this became an obsession. You know, and then what I told her is that you just don't need to stay in that weird position. So don't keep looking for that because you will cause it. Yes, but what sometimes happen, Ricardo, is that in the origin of the jugular near the neck, you may have some narrowings that can cause tinnitus. So I've done some stenting here, but I had good success stories and some not because the patients will improve for some time, but the tinnitus will come back. So then you will send other valves in the neck. There was a lot of discussion a few weeks ago at the SNIS Venus Symposium when there was no consensus, including all the vascular guys that stent the neck a lot for other causes. I'm very careful with those patients because this is a territory that, you know, I'm not so sure if the symptoms are severe enough to justify the risk on our end. But some colleagues, the guys at John Hopkins had a stent in the neck that migrated to the heart. Patient had to do an open surgery to remove. So, you know, and if you bring this perspective to the patient, a lot of them, when you bring it up, they really, you know, we understand what is causing your tinnitus, but this is the risk for treatment. And then they actually have a reality shock, and some of them are really, okay, I'm happy, I'm not crazy. They now have something to say to all the family that some of them need that as well. But they will not be pushing us to do anything that, you know, we still yet don't understand. But to balloon test occlusion on these patients, this is a good way to make them gain awareness and understand the seriousness of the procedures that are beyond the regular transit stenting.
Great, man, thank you, appreciate it.
Thank you very much.
We're getting to the final part of the innovations symposium. So this part is innovations in neurocritical care. I just do want to say, I think it's very refreshing that we're doing innovations in something that is essentially a scientific endeavor, as opposed to all the recent non-scientific endeavors that we've been exposed to, like calculating tariffs and using chainsaws to cut jobs. And so, you know, this is good. Also appreciate those of you who stayed this long, because, you know, as most of you know, there's two major endeavors of conferences such as this. One is academia, the other alcohol. The academia to alcohol ratio kind of changes the later it gets in the day. For those of you that have, you know, resisted the urge to leave and drink, thank you again. Next speaker, here we go. So our next speaker is Dr. Santosh Murthy. So I've known Santosh for over 10 years. Actually, it's been, what, 12 years? Santosh, can you hear me?
Yeah, I can hear you.
Yeah, so, all right. So yeah, it's been 12 years. I saw him when he was a budding neuroscientist in Baltimore. And now seeing him as the guru of neurocritical care, the finished product, mentoring others, and doing some amazing things, it's fantastic. He's been a frequent flyer for us. He's done a few talks at Baptist Innovations. He was a little worried about whether it was legal to do a third talk at Innovations because there's the 22nd Amendment that says you only have 2 terms. I told him, don't worry about it. It's going to be repealed soon, so you're more than welcome to come back. So welcoming Dr. Murthy to talk about updates in the management of intracellular hemorrhage.
It's great to be back and apologize I couldn't be there in person this time. Thanks to Dr. Nawal for the eloquent introduction. So today I'll be talking to you about the updates in the management of intracerebral hemorrhage or ICH. And hopefully, despite the delay in the takeoff, I think we'll be able to land on time. These are my relevant disclosures. I think I'll break this talk into 2 simple sections. One is the acute ICH management updates, which will entail both the medical management and the surgical management aspects, and a little bit about some of the new data coming in as far as long-term ICH updates are concerned. So just to give a little bit of background, we all know the main things about ICH being that we have about close to 4 million cases every year, about 80,000 new cases in the just in the US alone. Most importantly, the historic data suggests that 30% or a third of patients end up dying, and nearly half of all patients at the time of discharge end up having poor outcomes. That said, there's a lot of new data to challenge this paradigm, which suggests that nearly close to half of all patients who have severe disability, even 1 month out, end up having decent outcomes at the 1-year mark. So we really shouldn't be giving up early on these patients, and we need to exercise good aggressive care, at least in the early period. And the first 72 hours, especially from the neurocritical care, acute management aspects are crucial in the management of hemorrhagic stroke or ICH. And you can encounter a lot of complications with hematoma expansion, IVH, hydrocephalus, a mass effect from the hematoma edema being some of the most important things. And most of the updates actually center around these issues, interestingly, although we do focus on preventing seizures and fever and also the DVTs down the road. So why do we worry about hematoma expansion? We know that nearly 75% of patients have some sort of hematoma expansion, and a third of them have significant hematoma expansion. And for every cc increase in the volume of blood, there's a 5% increased likelihood of worse outcomes. That being the case, how do we go about targeting hematoma expansion? And historically, 2 main approaches have been used. One is aggressive or intensive blood pressure control, and the other is to reverse coagulopathy as early as possible. So if you go back to history, suggests that blood pressure spares no one, and even at the conclusion of the World War II conference in Yalta in 1945, all 3 gentlemen suffered from extremely high blood pressure, with FDR who ended up dying a couple months later from a fatal ICH, Stalin a few years later again from a fatal ICH, and Churchill, who had 3 CTs of ischemic strokes, all from hypertension-related arteriosclerotic disease. So how do we go about treating the blood pressure aspect? You know, from the last decade or so, we know there's INTRACT-2 and ATAC-2. INTRACT-2 suggested that aggressive or less than 140 systolic reduction in the blood pressure compared to less than 180. There was a clear trend in the reduction of poor outcomes, or which was death or major disability, although the signal wasn't seen in ATAC-2. A lot of data have used pooled analyses of both these trials. And what the data suggests is if you prevent fluctuations early on in the first 24 hours, then those patients end up having good functional recovery. As you can see here, the more the fluctuations in the blood pressure, the poorer the chances of good functional recovery. The more the fluctuations, higher the chances of death, and more fluctuation also amounts to higher odds of hematoma expansion. And that said, time to intervention also appears to be very crucial, with this recent study showing that ultra early, that is less than 2 hours of systolic blood pressure intervention from the time of symptom onset, is actually associated with decreased odds of hematoma expansion, almost a 50% reduction, and a 2-fold increase odds of favorable functional outcomes. So ultra early and preventing fluctuation seems to be the main way to go about this. And this was interestingly investigated in the INTERACT-4 trial, which came out just a couple of years ago. And in this trial, patients who ended up having any symptoms of stroke in the ambulance itself are subject to aggressive blood pressure reduction. And the target they aimed for was somewhere between 130 to 140 within 2 hours of symptom onset. And notably at this time, they had no idea whether they were dealing with an ischemic or hemorrhagic stroke because they didn't have any imaging. And what they found was overall, there was no signal. But when they analyzed ischemic and hemorrhagic stroke patients separately, those who had an ischemic stroke, aggressive blood pressure reduction was actually harmful, and those who had an ICH, aggressive blood pressure reduction, ended up being associated with good functional outcomes. So what do the American Heart Association guidelines currently recommend? That is, the blood pressure at the time of presentation is between 150 to 220, and it's reasonable to bring it down to about 140 and trying to maintain it in the 130 to 150 range so as to prevent any fluctuations. Now, the question is, if the blood pressure at the time of presentation is over 220, how do you go about doing it? Many centers do it differently. It's very reasonable to do a percentage reduction depending on what you think is feasible. The other aspect is coagulopathy. About a quarter of all patients that we see with ICH end up having antiplatelet therapy on board. And in the PADS trial, patients who had antiplatelet therapy associated ICH were randomized to either receiving platelet transfusions or just the standard of care. And interestingly, patients who were randomized to receiving platelet transfusions, they had a twofold increased odds of death or major disability compared to those who didn't receive any routine platelet transfusions. And importantly, these were patients who had a supratentorial bleed and they were medically managed. These are not patients who ended up going for either surgical interventions or had EVD placements at bedside. And in one of the additional analyses, it was the single antiplatelet or antiplatelet monotherapy arm where platelet transfusions were actually associated with adverse outcomes and not so much the dual antiplatelet therapy. So it's totally reasonable in clinical practice to actually go ahead and reverse the antiplatelet medication with platelet transfusions, especially if you're dealing with combination antiplatelet therapy. And similarly, the American Heart Association guidelines also very clearly recommend that if you are dealing with antiplatelet related ICH, and if the patient is not being considered for any imminent surgical intervention, it's totally reasonable to wait as compared to a patient who's actually being considered for surgical intervention, including an EVD, where it's very reasonable to go ahead and give platelet transfusions. And conversely, we also are faced often in the ICU with the situation where we have to restart antiplatelet therapy, especially in the context of patients having a fresh stent or having a new MI or any such cardiac indications, usually. And this was a recent trial that came out from China called the eSTART trial. These were patients who had a primary or a spontaneous intracerebral hemorrhage, all of whom ended up having surgical evacuation. So these were surgically treated ICH patients who were randomized to early starting of antiplatelet therapy versus the late start. And the early start was in the first week, and the late start was as late as a month after ICH onset. And interestingly, early start was associated with a significant reduction, almost a 50% reduction in the odds of having any ischemic events. So this was cardiovascular, cerebrovascular, major vascular death, so MI, stroke, or death. And patients who were randomized early starting antiplatelet therapy also had a significant, nearly a 50% reduction in the risk of death. And notably, there were no differences of increased risk of intracranial complications. What about reversal of anticoagulation? Now, this is a slide straight out of the American Heart Association guidelines. And we know for a fact that vitamin K antagonists like warfarin, we use PCCs, and that is the established standard of care. As for dabigatran, we know it is nitrazumab. But what about if it's factor Xa inhibitor like apixaban or rivaroxaban? And this is where a lot of the recent head-to-head data comparing Andexxa to 4-factor PCCs have come out. And this is the NXA-I trial, which was published in the New England Journal last year. And here, about 250 patients with spontaneous ICH received Andexxa versus a similar number received the usual care. And among patients who received the usual care, a significant proportion of these patients got PCCs. Now, what the study showed was that in terms of hemostatic efficacy, in terms of reversal of the factor 10 activity, Andexxa was far superior to the standard of care, which was PCCs. Andexxa was also superior to PCCs in terms of preventing hematoma expansion. That said, the study was not powered for detection of any difference as far as functional outcomes were concerned. So when they looked at the change in the NIH stroke scale at the 1 month mark, there clearly wasn't any signal. But what is interesting to note was as far as the thrombotic events were concerned, Andexxa was associated with almost double the rate of thrombotic events, 10% compared to 5% with PCCs. And most of these thrombotic events were ischemic strokes and myocardial infarctions. Now, there's a new data that was presented at the ISC earlier this year, which showed that among patients who had either PCCs or Andexxa, those who received DVT prophylaxis, interestingly, there was no such increased risk of thrombotic events, and that paper apparently is going to be published soon. So hopefully that will give us a little more data on whether we need to consider Andexxa versus PCCs. Obviously, financial and cost factors being another big consideration. And is time to anticoagulation reversal important? This was a very large study from almost a study including 10,000 ICH patients from the American Heart Association Get With The Guidelines registry. So it includes several hospitals which are part of the Get With The Guidelines registry and across the length and breadth of the US. And in this study, time to reversal of anticoagulation, especially if it was done in the first hour after symptom onset, was associated with significantly lower mortality and favorable discharge outcomes. They didn't really find any difference in terms of functional outcomes because it was assessed at the time of discharge, which is pretty early in patients who have ICH. Now, are we doing our patients any disservice by treating individual components, or should we go ahead and bundle all our care efforts and make a difference? And that was actually the focus of the INTERACT 3 trial, which included several interventions in the treatment arm. And these interventions included early aggressive reduction of blood pressure, which was the target of less than 140, strict glucose control, treating fevers, and correcting warfarin or any anticoagulation-related coagulopathy, at least within 1 hour's presentation. And not surprisingly, all these interventions were associated with a significantly lower risk of poor functional outcomes. And you can also see that the risk of odds of death at 6 months were also significantly lower. So clearly, bundled care, which is what most of us have now in the ICUs, is perhaps the way to go. And what about updates as far as surgical interventions for ICH are concerned? Now, historically, there have been two usual methods for surgical intervention. One is taking open craniotomy with clot evac, and the other is the decompressive hemicranie, and the new kid on the block be minimally invasive surgery. As we all know, open craniotomy with clot evac entails doing a craniotomy or disectomy, getting to the hematoma, and evacuating the hematoma, as the name suggests. And as you can see here, the CT scan should make a large a left frontal bleed, and this is the craniotomy approach. Getting to the hematoma, this is the cavity, and this is the scan after the hematoma is evacuated. And we also know that about 2 decades ago, the Stitch 1 and the Stitch 2 trials specifically looked at this approach as compared to standard medical therapy. Unfortunately, there was no difference in outcomes, as you can see in the curves here. And so open craniotomy did not really pan out as a standard of care intervention for ICH. On the other hand, you have decompressive hemicraniectomy, which is essentially taking out the skull flap and encouraging transcapillary herniation so as to make space. Now, you do have the option of doing the hematoma evacuation or just doing a hemicranie without hematoma evacuation. And very recently, in fact, last year, the SWITCH trial was published in the Lancet. And this trial looked at decompressive craniectomy only in patients who have deep ICH in combination with standard medical therapy versus just standard medical therapy alone. And interestingly, there was a clear trend towards favorable functional outcomes overall with the surgical approach. And clearly, there was a significant reduction in MRS of 6, which is death. So a lot of patients ended up surviving, but ended up being significantly disabled, as you can see in these two columns here. And so you could argue that perhaps this is a life-saving approach and may not really influence functional outcomes as much. So is that the end of the road for surgery? Apparently not, because now you have minimally invasive surgical options. And one of the first invasive options that was looked at was stereotactic aspiration with thrombolysis. Now, in this approach, you place stereotactically, you place a 10 cc syringe along the long axis of the hematoma, aspirate the hematoma as much as you can, place a catheter, and then you can instill fibrolytics like TPA. And over time, the hematoma is completely evacuated. And we know for a fact that the MISTY-3 trial, which was a phase 3 NIH-funded trial, looked at this particular approach in combination with standard medical therapy versus just medical therapy alone. And again, similar to prior surgical trials, while there was a suggestion of benefit in terms of mortality, there really wasn't any difference in terms of disability. What about other techniques? So very interestingly, there are two new techniques that have emerged for minimally invasive surgery. And one of them is called minimally invasive surgery with direct visualization or exoscopic approach of the NICO device. It's the company that makes this particular device. And what you do is you map all the fibers in the motor cortex, avoid all of important fibers, and go in trans-sulcally. So through the sulcus, you place this NICO device, take out the trocar, the sheet is left behind, and the hematoma is evacuated. So this does not require a microscope, it's just done exoscopically by the surgeon. And these are images of the hematoma before and after surgical evacuation using this approach. And again, last year, this trial was published in the New England Journal, which is called Enrich. It included about a little under 300 patients who had a spontaneous hemorrhage. And after the midterm interim analysis, the trial mostly included lobar hemorrhages between the sizes of 30 to 80 cc's. And the surgical intervention had to be done within 24 hours. And the surgical group was compared to standard medical therapy group. And as you can see, surgery was associated with improved outcomes early on, as early as the time of discharge, 30 days, 90 days, 180 days. It was also associated with a shorter length of stay, decreased complications. Overall, it was resounding success for minimally invasive surgical intervention. Now, there's another type of surgical intervention that can be done, which is also minimally invasive, which is the endoscopic approach, where you do a small slit, place the endoscope. It has a camera at the end of it. You can visualize the hematoma cavity from within. Once the hematoma is drained out, this is how it looks, and you can instill sterile saline, and you can see where the bleeding vessel is, and actually cauterize as you can see from this image here. And just a couple of months ago, this particular approach was evaluated in the MIND study, which looked at endoscopic approach versus standard medical therapy. And what the approach found, although there was no overall signal in terms of functional outcomes, when they broke it down, there was a clear benefit of this particular surgical approach in terms of improving disability early on in the first 30 days, although the signal was lost at the 3 and 6 month marks for reasons that are unclear, and hopefully we'll have more answers to these questions once the results are published. But importantly, this trial was sort of hampered by the publication of the results of the Enrich trial, which is why they had to pivot and start enrolling more deep hemorrhages and less lobar hemorrhages, because lobar hemorrhages, Enrich sort of became standard care. What about hemorrhages involving the posterior fossa? So when you have hemorrhages in the cerebellum, we know that the dogmatic approach has been anything greater than 3 centimeters goes straight to the operating room. But this is a very large prospective cohort study from all over the world, which included almost 800 patients. And in this study, what the authors found was the sweet spot was about the 15 millimeters or 15 ml of hematoma volume. Anything above that, surgery clearly had the overwhelming success. Anything less than 12, medical therapy was the way to go. And between 12 and 15, it was totally reasonable to watch these patients, monitor them closely in the ICU, and should there be any clear evidence of either mass effacement of the fourth ventricle or obstructive hydrocephalus, then those would be indications for surgical intervention, and which is what the current American Heart Association guidelines also recommend. Now, what about the long-term management of ICH? Now, we all know that there's a lot of data and a lot of interest in what to do with antithrombotic medications, particularly given that 30% of ICH patients have AFib, either at the time of presentation or down the road. So how do we go about dealing with these patients? And this was a meta-analysis that came out very recently also of several small pilot trials. Interestingly, the name was called Cockroach, for lack of a better word. But in the Cockroach meta-analysis, the authors found that the resumption of antithrombotic medications resulted in an overall net benefit. There was a trend towards net benefit, and this included a composite of both ischemic and hemorrhagic stroke. And when they looked at ischemic stroke, clearly anticoagulation was beneficial. And they looked at hemorrhagic, it was trend towards slightly increased risk of hemorrhagic events, although it was not significant. That said, as many of you may remember, the Prestige AF trial was a phase 3 clinical trial that was presented at the ISC a couple of months ago, later this year. And what the study showed was that the resumption of anticoagulation after ICH was associated with almost a 95% reduction in the risk of ischemic stroke, but was also associated with 11-fold increased risk of hemorrhagic events. And the hemorrhagic event here was a recurrent ICH. The number needed to treat was 13, the number needed to harm was 24, suggesting perhaps if you combine the ischemic and hemorrhagic profile together, there could be a trend towards net benefit. But that said, there wasn't any clear signal. And where things stand, I think there are some more trials that are currently underway. Enrich AF in Canada, which is completed, and hopefully we'll have results in the next year or two. Aspire, which is the US trial looking at apixaban versus aspirin in ICH patients with AFib, and hopefully that which is still currently recruiting, and it's about in the 50% recruitment stage, so we still have ways to go before we have more data. So just to summarize what the latest updates in the management of ICH entail, would be early, aggressive BP control, avoid fluctuations, reasonable to target less than 140, try to keep the blood pressure 130 to 150, revert any coagulopathy if it's present, and keep in mind that the time to reversal of coagulopathy is important. Body care approach is important, trying to avoid all medical complications, controlling the fever, controlling the blood pressure, controlling blood glucose levels. Consider surgical intervention if it's a lobar bleed, superficial, and if surgery can be done in the first 24 hours, even if it's delayed. I think there is still data to suggest that surgery may be beneficial in these patients. Obviously, you want to get a CTA to evaluate the spot sign, any underlying abnormality, admit to the ICU like you normally would, get an MRI at some point, evaluate the underlying etiology of the ICH. And more importantly, long-term, as far as resumption of antithrombotic medications go, we clearly have no signal one way versus the other. We do know that the risk of hemorrhagic complications is not insignificant, but the benefit of reducing an ischemic event is pretty significant also. So you want to weigh these decisions on a case-by-case basis. The long-term blood pressure, we know from the SPS3 that less than 130 long-term is the way to go. The tighter, the stricter the blood pressure, the better it is. And so with that, hopefully I haven't taken too much time, and I'd like to thank you all for the opportunity to present this talk, and I'm happy to take any questions.
Thank you, Santosh. Any questions?
Thank you, Santosh. Ricardo here. I wish you were here to help us curb the eloquence of your Indian fellow, Raj. If a soccer field were 68 meters by 105 meters, not 75, what size goal we would need for the new REACH surgical trial for basal ganglia hemorrhage to be positive? So translating that, what is your feeling about minimally invasive surgery for basal ganglia hemorrhage? Do we have a chance to get a positive trial with new trial coming from Emory, Reach? What are your thoughts, your feelings about studying all this data? Is there something that we have a chance of finding a positive trial for this?
Yeah, no, I think it's a very important question, and obviously it's a thing that a question that has always been plagued all our minds, because we know from historic data that deep ICHs in general have worse outcomes compared to low-bar ICHs. And a lot of data from the ATAC2 trial suggests that, and the CLEAR-3 trial suggests that I think it's involvement of the thalamus that is an independent predictor of poor outcomes, not so much the head of the caudate or the putamen. So perhaps I think when we deal with deep ICHs, I think we need to tease these different locations out and then enroll in a surgical trial to see which particular subset of patients will be benefited the most. I believe there was a proposal to the NIH from the Mount Sinai group called the MINUTE trial, looking specifically at minimally invasive endoscopic procedures in deep ICHs. And hopefully if the trial gets funded, I think that would be a great avenue to answer all these questions. I don't know what your thoughts are, Ricardo, or if anybody else has any other thoughts about this.
I'm typically optimistic, but I don't know, I've seen this movie so many times over the years. Again, we're gonna support Gustavo and the team and we're gonna enroll in the trial, but I'm not that optimistic. I don't know if Eric or Niraj have a different thought.
Yeah, there was a very good session at the ISC where you had, all the, scientific experts, and I think you were there, Santosh, where we had Claude Hemfro, Dan Hanley, Wendy Zi, Hanel, Gustavo, all talking about surgical evacuation of ICH and, what were the different surgeries that they had done, the different modalities they had used, and the outcomes. Again, the disappointing thing was, the one thing that was universal was nothing really had basal ganglia hemorrhages. As you know, even though we keep talking about NIH as a positive trial, it was an adaptive trial, and it adapted away from the basal ganglia to lobar, found benefit in lobar. The MIND trial, not published yet, and you're right, early on there's some benefit, and that basically goes away by 180 days. They're talking something about maybe less ventilator dependence we have to see, but typically, as you know, in these studies, you have one primary endpoint and 18 secondary endpoints. And out of those two come positive, and you focus, say, guess what we did? It fixed that one secondary endpoint. We don't know if it's going to be meaningful or not in any way. Same thing with MISTI, right? They made the argument that, well, if you took out more than 15 cc's of or the clot diminished to a point where it was less than 15 cc's with MISTI, then you tended to have better outcomes with doing minimally invasive surgery and putting TPA into the clot. But again, if they had continued to make it less than 15 cc's beyond 12 doses, would that have been safe? Would you have had more hematoma expansions? We will never know the answer to that. So I agree, I share a little bit of the pessimism. I think the REACH trial is a necessary trial. What surprises me about the REACH trial is I think every study should be based on the mistakes we have made in the past, the things we have learned in the past. And REACH weirdly allows patients to get enrolled between 20 to 80 cc's. 80 cc's is a lot for a basal ganglia hemorrhage. And as you know, once the damage has happened very early on, to go in and evacuate that when it is 75 cc's, I think might be futile. Now, we did actually ask Dr. Pradilla that question, and he was like, well, it's adaptive. So if we find that a bunch of patients from 60 to 80 are actually, not responding, they'll make it 20 to 60, then they may go 20 to 40, things like that. But I think if you already know, why kind of go with such a huge hematoma volume when you know the initial injuries already caused the damage? And that's my fear for clinical trials that end up trying to be too inclusive, and then you become extra inclusive, and then you end up with your little post-hoc analysis that will give you the basis for your next study. I hope the adaptive design will help us get an answer to that, but I'm not 100% sure.
Yeah, I think the other complicating issue with basal ganglia hemorrhages is IVH, which is also an independent predictor of poor outcomes, and how is ICH going to be balanced out and treated, so that's another complicating factor.
I have another question for you, Santosh. As you know, all the studies we've done, whether it was hemostatic agents, NOVO7 and FAST, whether it was, the INDEXA-NET studies looking at INDEXA versus Kcentra, and even though, there's more hemostasis, the outcomes actually, the signals were in the opposite direction away from andexanet, unfortunately. The attached trial kind of showed no benefit of blood pressure control. When you have a bunch of these negative trials and you combine them all together and you combine all these interventions together and then you show a benefit in something like Interact 3, it makes me a little skeptical. And then I think what's different about Interact 3 was it was conducted, and I'm actually, the point I'm getting to is the whole cold ICH theory, right? Should we be calling a cold ICH when someone has an ICH? So Interact 3 was conducted in third world countries, like 10 of them. And as you know, with us being from one of those countries, someone has a head bleed back in India, it's like, okay, game over, you have a bleed in the brain, you're gonna die. Now you're basically conducting a trial where saying we can do A, B, C, D, these 4 different interventions as a bundle. And then you compare that to a control group where you don't do those interventions, where in general, you're like, well, it's too late, these patients are gonna die because they have a bleed in their brain. So how do you extrapolate the findings of Interact 3 conducted in third world countries to, let's say, a first world country, where you do a lot of things right, where you do intervene when you have to appropriately do it? Do you think that bundle actually is applicable in the US, especially in, let's say, university centers such as your New York Presbyterian Hospital, or let's say Baptist Health, or a Hopkins, or a UCLA, places where you kind of do all the things, but do you really have to follow a bundle blindly, or are you going to take a bunch of insignificant interventions, combine them together, and then think you actually have some benefit with those interventions?
Yeah, no, that's a very valid question. I think that is one of the criticisms of both the ADAC 2 trial and the Interact 3 and 4 trials, also because they were, as you said, done in less aggressive, less ideal settings. But that's the only data we have, and the world we live in, I don't see any funding being available for any such questions in the near future, given the current climate. So we'll probably have to, stick to just those interventions for now. The only thing I would say in the defense of the Interact team was that they sort of knew that this was going to be a big criticism of the trial, which is why they did the cluster randomized trial approach, where there was the same set of hospitals. For the first given period of time, they were enrolling in one arm, and the second period of time they were enrolling in the other arms. Sort of, it's not obviously that we don't live in a perfect world, and this is not a perfect means by any way, but I think they sort of knew that this criticism was coming their way, and they wanted to address it head on.
This is Jawander Niraj again. We know we love this topic. So a patient comes to your hospital, does your own call, patient's on Eliquis and has a basal ganglia hemorrhage. Kcentra or Andexxa?
That's a very interesting question. For the longest time, we have only gone with PCCs, Kcentra, just based on cost benefit analysis that we all did. And given that there is no obvious evidence that it improves functional outcomes down the road, and there's theoretical risk of increased thrombotic outcomes with Andexxa, at least when Andexxa came out, it was like 5-6 times more expensive than PCCs. So we have historically gone with PCCs, and even to this day, we do PCCs. We don't even have Andexxa on our formulary, interestingly, even though the aging events recommends. I'm curious to know what you guys do about this.
Can you see his smiley face, or you cannot see from there? I'll let him answer.
No, I mean, honestly, I'm open to whatever the evidence shows, right? And we all were secretly praying, myself included, despite accusations of contrary, that Andexxa actually would show the benefit. I mean, there's clearly, if you look physiologically, if you look biologically, Andexxa should work better than BCC. I mean, it just should. And because it works better, you would expect a higher risk of DVTs and PEs and MIs, and that's also true. Like, to your point, maybe if you have subcuheparin going, maybe it doesn't, but no one in the first 24 hours is going to be on subcuheparin, right? So it finally leads us down this road of, okay, do the complications offset the benefit of hemostasis? And what we've seen, for example, as with FAST trial, where they use activated factor 7, significant hemostatic benefits, significant decrease in clot expansion. Mortality in the study group was 21%. The study group was 26%. That is the ones that got activated factor 7. Control group was 21%. So you actually showed an increased trend towards mortality. And my concern with the NXI trial is that the signals, you're right, it wasn't powered to show a clinical benefit, but when the signals are going the other way, for mortality and functional outcomes. I have a very hard time believing if you had twice as many patients, somehow miraculously, you would have seen a difference in outcomes and mortality. Again, remember, signals going away from andexanet. So that's kind of why I'm a skeptic. I know American College of Cardiology recommended it. AHA is like, well, you know, andexanet is 2A, whereas PCC is 2B. But the best evidence we have in the biggest randomized controlled trial to date shows no benefit. So it's very hard to convince myself to use something more expensive, higher risk, when we don't have evidence of benefit in the largest clinical trial out there, conducted by the company that actually sells that excellence.
Right. Yeah, no, totally.
Any other questions for Dr. Murthy? Santosh, it's always an honor and a privilege. Hopefully you can come here next time in person.
Absolutely, would love to. Thanks so much for the invitation.
Thanks, man. Hey guys, next speaker is Dr. Natalia Souza.
Yes, we're going.
Okay. So Natalia Souza is more international than most of us can wish to be. She did her undergraduate urology in Brazil. She did a fellowship in endovascular or neuroendovascular intervention radiology. She then did follow-up fellowship in France in interventional neuroradiology and has been working with Dr. Freeman at the Mayo Clinic, looking at different prediction models for subrectal hemorrhage, also in collaboration with Dr. Hanel. So welcome, Natalia. It's an honor and a privilege to have you.
Thank you, it's my pleasure.
And just accept that you repeat. Natalia is going to compete with Peter, who has the longest training in the universe. Natalia just got accepted. She's a neurology resident at Thomas Jefferson, phenomenal house of neurology, neurosurgery in the US. So congratulations on that.
Very nice to meet you, everyone. I know everyone might be tired right now, but I'll try to remain on time. And I'm going to talk about precision medicine in subarachnoid hemorrhage. My mentor is Dr. Freeman. Unfortunately, he could not be here today. So this is my disclosure. And aneurysmal subarachnoid hemorrhage, I don't want to be repetitive here, but we know that it's only 5% of all strokes. 50%, however, is in people who are younger than 55 years old, mainly women. 26% of pre-hospital mortality, 13% of in-hospital mortality, but 35% of overall mortality. And when we look into costs, we are talking about more than 80,000 per patient, plus costs associated with long-term care and rehabilitation, plus societal costs, because we're talking about young people. And it's impossible not to go through Dr. Watt McDonald's work, where he talks a little bit about how systemic is subarachnoid hemorrhage. So after an aneurysm ruptures, we do have an increase in intracranial pressure. And this increase in intracranial pressure leads to early brain injury. And then we are talking about the initial clinical presentation of a patient, which will directly impact on outcome. Then we do have like a lot of sympathetic system activation and an inflammatory cascade, which will lead to other complications associated with the disease. So the initial blood volume actually has high importance on this. The more blood volume we have, the more inflammation we have. So this patient is graded in a poorer grade than a patient with lower volume of blood. And age is also something that matters when we are talking about SAH participation. That said, we also know that it is declining incidence, mainly because of a declining incidence of hypertension and smoking. But of course, we are treating more unruptured aneurysms. And there is also a declining case fatality rate, which is asymmetrical across the globe, but has many drivers. For example, we are diagnosing more. This is a very nice paper from JAMA 2019, where they compared the incidence of CT and MRI, both in Canada with public healthcare and the US with a private healthcare. And we can see blue line, straight line, America, US, and triangles, Canada. So we can see that it is increasing everywhere. So we are diagnosing more, even though only 6% of acute soil headaches are actually sparknoid hemorrhages. And we are treating early, and this is a very nice paper from Busco and colleagues, where they proved that treating up to 12 hours actually can make difference in patient outcomes. We are also employing more endovascular techniques, and endovascular techniques have been proven to lower probability of death and disability, not only at 1 year, 5 years, but also at 10 years. And this is an important work of one of my colleagues. And of course, high volume centers, and I had the pleasure to be Baptist before, and I know that they do treat a lot more of 65 patients per year. So after 65 patients per year, we will have a significant decrease in mortality and disability, so improved patient outcome. And we do have Neuro ICU facilities. So this is a very nice paper, quite historical, from 2011, where they compared a group of patients that were not treated in Neuro ICU, group A with group B, that actually they were treated in Neuro ICU and they had a higher probability of being discharged at home. Which leads us to this, who are poor grade? Because when we look at the poor grade patients today, we know that a lot of patients with WFNS 4 and 5 who were actually classified as poor grade, they do well. So here, 73% of patients who survived the initial phase and that were initially classified as poor grade patients, they did very well. So we are promoting better diagnosis. We are treating high volume centers. We are promoting early brain aneurysm repair in Neuro ICU with transcranial Doppler or CTP. And we are being more aggressive for those patients who need more. And we are also, as we saw yesterday, rehabilitation improved a lot in the last years. Where can we interfere at this point? Because we are still talking about 35% mortality. Maybe here, in determining which patients can be discharged early and which patients we should be more and more aggressive because they actually have a chance. Aggressive care, I don't believe it's for everyone. The more a patient stays in the ICU, the more this patient is exposed to a high risk of infections and complications. And of course, it increases costs. So we need to use the system in a more cost-effective way. That said, who are the high-grade patients? How precise are we? So Hunt and Hess, they developed this scale to surgical scale initially in 1968 after the scale of Bottorell and colleagues, and they actually, as you can see, it's very subjective, like drowsy, confusion. It opens
it opens a way for questions. And it's no surprise that kappa values, which grades interreliability between grades and between different observers, is quite low, which means it has a high inter-observer variability. And when we look into class 0 to 2, there is no significant differences in between them. However, content has is still today a very common scale. And when we go into Glasgow Coma Scale, maybe a lot of people say, okay, there's not prognostic significant difference between ages and grades. However, in SAH, when they looked into 3 different groups in Glasgow Coma Scale, they were able to find a kappa value of 0.69, which is pretty good, which means it's pretty reliable. Inter and intra-rater reliability. And that's why WFNS incorporated Glasgow Coma Scale into it, because they wanted to bring more preciseness for SAH grading. However, it is also based on expert opinions from data from the International Comparative Aneurysm Study, where they saw that for death and disability prediction, the level of consciousness coming back from my first slide is really important. But when you're looking to disability, aphasia and motor deficits are really important, and we have both in WFNS. But is WFNS a perfect tool? No. So 1 in 5 patients with WFNS grade 1, actually they have poor outcome, but they should have a very good outcome. And this is a very nice paper. They looked retrospectively into patients in WFNS 4 and 5, and they found a significant amount of patients that actually did really good, which they called false poor grade. So they were initially classified as poor grade patients, and then they did pretty well. And they also assessed how could we improve this? So the later they found that the later the WFNS is collected, the better it predicts the modifying income scale at discharge. But we cannot be too late here, because we wanted to have a ready assessment of the patient as soon as the patient gets to the emergency department. So the best day would be around third day. And when we add WFNS to our imaging parameters, and here we use the Heiger score, the Hutsu score, and also the early brain image score, CEP, and we actually get pretty reliable. So nothing new, but combining level of consciousness with initial blood volume can actually lead us to better outcome prediction. WFNS incorporates the Glasgow Coma Scale, which has a low inter-rater and intra-rater variability, different than the Hunt has. But is today the modified Hunting scale the best way to access blood volume in the brain CT? So looking to Fisher and modified Fisher scale, we know that the modified Fisher scale came to address a problem that the original Fisher scale had. Of course, they were in the 80s, CTs, they were not as good as they are today, but the grade 4 of the original Fisher scale, they actually had a better outcome and a lower chance of vasospasm than patients grade 3. Why? Because they didn't take into consideration that when we look into blood, into the intraventricular space, and into thick subarachnoid blood, we actually increase the rate of vasospasm and delayed cerebral ischemia, which is the main neurological complication of subarachnoid hemorrhage. And that was addressed by the modified Huntington scale. But still, we are talking about an accuracy of 0.52 for Fisher scale and 0.67 for the modified Fisher scale. Let's combine that, and then we have the basal grade, which combines WFNS with modified Fisher scale, but still, we have an accuracy of 0.63. However, this is a work that we did back in São Paulo, and we found that the basal grade red had very high specificity for predicting poor outcome, whether the basal grade green is really good for good outcomes, but we still have a lot of patients, a lot of yellow patients in the middle that we don't actually predict anything. We don't know where this patient is going. So on, let's try to be more precise. And then we have the Hydro scale from 1990. But it's pretty good. And like, I mean, we have papers from 1990 and we still have papers from last year saying how reliable it is. But it's time consuming. You need to look into each feature and gradate blood from 0 to 3 up to 32 points. Takes time, and it's not very good for emergency setting. Then we go into precision medicine. So we look into segmentation, blood segmentation. And first person who did this, 1994, I was pretty young. And they were even able to find that if we had less than 15 ml of blood, patient had a pretty high chance of survival, while a patient that had more than 80 ml of blood had a pretty high chance of mortality. But it was super time consuming, like each brain CT would take like more than an hour for an expert. And many people, I mean, I saw at least 10 papers, they looked into that later on. They segmented blood to try to quantify how much of blood do we have at the beginning and how is the patient going to do afterwards. They could find 86% of accuracy. However, it's also very time consuming and it's not appropriate for emergencies. So this is a recent work from 2024. The group, Mayo group, Dr. Freeman with Fabian Fottinger, medical student, they use the ABC formula that we actually use for ICH, so everyone knows it. ABC divided by 2, considering that each cistern is an ellipse. And they were able to correlate the total amount of blood with vasospasm and outcome prediction. And they found it to be pretty reliable and actually had a better performance than the modified Fisher scale. And I know some might be questioning right now, okay, but we have AI now. Yes, AI came to replicate our abilities. They can automatically determine blood volume in as fast as 18 seconds for ICH. And some studies with subarachnoid hemorrhage, they have actually identified that so-called blood may be even more important than intraventricular blood, changing a lot of things we think we know. However, we still have limitations, high costs, technology, and problem of AI is it needs a lot of population from different countries to be reliable. Otherwise, we can make mistakes and a systematic mistake, a mistake that will be done all the time. So going back to the simple, what does it take to make a good score? Ideally, we need a significant correlation with outcome and differences in outcome in between grades. We need it to be easy to use, low intra and intra-observer variability, and of course, external validation and good calibration. That said, it can guide clinical management, prognosis, it can support end-of-life care, it can avoid overestimating poor outcomes like the WFNS 4 and 5 that I mentioned before. It can facilitate communication between multi-center studies for treatment targets, and it can track the patient status. So which variables should we combine to get to this? In this systematic review from 2025 in JNIS, they saw that the most important variables have been age, WFNS, treatment, blood load, and aneurysm size. However, calibration details were often poorly reported. How people handle missing data. Many papers don't even talk about that. And only 4 studies had external validation. A lot of people talk about SAHIT, which is a very good model, It takes only WFNS, age, and hypertension. It's readily available, it's really good. However, one downside of the SAHI study is that the area under the curve to predict mortality was not as good as to predict outcomes. So what if we combine a lot of variables? And here we are talking about machine learning. Yes, maybe we'll do better, but for now we are doing just the same. However, models that incorporated volume quantification into machine learning, they are doing better than the others. Challenges, variability, high costs, and it lacks external validation. Future, they will be part of your system and they will give you all the time prediction. They will be predicting outcomes every single day with readily available variables. But how to remain simple but still be accurate when we are talking about outcome prediction in SAH? Glasgow Coma scale, as I said, very good iterator reliability, age, undeniable, and blood quantification. So that's what the Mayo team did with the ESAH score. They looked into Glasgow. They subdivided the Glasgow into 3 scales, 3 to 7, 8 to 11, and 12 to 15. It goes from 0 to 5, and to calculate blood volume, they use an ABC formula that I mentioned before, that we already use for ICH, and age. 89% of accuracy to predict outcomes, 88% from mortality, low cost, easy to use, it's feasible everywhere, even in underserved communities. However, there's no external validation. And we are doing this now with SAH, large volume quantification, Brazil and Americas. So 2 hospitals in the United States, Baptist Hospital and Mayo Clinic, 2 hospitals in Brazil, Federal University of São Paulo and Federal University of Rio de Janeiro. We are accessing the ESAH in a diverse population. And we are also looking to secondary outcomes. How can we mitigate differences in SAH care? How can we improve this everywhere? This is our leadership group. This is our research team. So we are doing the volumes. And we already have some preliminary outcomes, which are pretty good. So they had more than 80% of accuracy for both mortality and for good outcome and poor outcome at discharge. And as you can see here, when we're looking to 4 and 5 for unfavorable outcome, we are very precise. So take home message from our project, volume matters, and machine learning models that incorporate SAH blood volume have a higher overall accuracy for predicting outcomes. ESAH, let's see. It looks like it's simple, easy to do with high accuracy combining very, very simple variables. AI, of course, it's now and it's the future. However, we need to validate AI in the whole world to be accurate and don't make systematic mistakes. Thank you, and thank you to the V Foundation who is supporting this project. Elizabeth, she's on the picture with me. She's a brain aneurysm survivor, and she chose me for this grant. So I'm very thankful to her.
Thank you, Natalia. Any questions?
I just want to say thank you, Natalia, for your persistence in getting us together and getting our data. So it's phenomenal to collaborate with David Freeman, brother from a different country who love to hear with us. Do you notice the difference between David Freeman and Ricardo? Because they're very, very close. Again, these 2 guys, the IQ would fill, 2 of these guys in this room would fill the room with IQ. You know the difference between one and the other? One writes, the other one talks. I was telling, we're presenting here at Total Time and so there, you guys need to record their eyes and transcribe because what he talks is an encyclopedia of data, so there needs to transcribe him. But phenomenal session, thank you Natalia, thank you Niraj.
Hey Natalia, I have one quick question for you if you don't mind. So again, phenomenal talk and great work. I think you guys have done a really good job in terms of taking something simple but measurable. As you know, those of us, including myself, who try to come up with these very complex prediction models, no one ever used them because it was too complicated to actually use on a day-to-day basis. I guess it's not a criticism, but just a thought. So we have the ICH score, like Hanel's ICH score, right? And it has a lot of flaws, if you will, like a little bit of IVH and you get a point, you're 80 years in 1 day, you get a point, you're 79 years in 364 days, you don't get a point. So the differences in terms of mortality go from, let's say, an ICH score of 2 from 26 to ICH score of 3, 72%, and we know that's not accurate. So the way they went around it, I said, listen, it's a simple communication. Don't use it as a prognostic, we use it as a communication tool that may give you an idea of how sick this patient is when you're transferring a patient over. Right, so again, not to be used as a prognostic tool. I think we have something similar with subretinal hemorrhage with Hanel. I don't think we need another communication tool. If you're using it as a prognostic tool, I kind of wonder if, especially with the data that you have, the so-called high grades on your ESH score, maybe focus on that a little bit more, because the way we take care of patients right now, a subretinal hemorrhage comes in, even if they're comatose, they're getting everything. Right? Let's make sure they don't have seizures for the first 48 hours. Let's make sure we put an EVD, see if they wake up. You do absolutely everything for all our patients. I think what I would compare this to is cardiac arrest patients. There's no way of being able to tell which patient is going to do well, but you want to know which patient doesn't have a shot. So you can tell the family in about 40 to 72 hours, listen, this is completely futile. It's based on your clinical exam, it's based on MRIs, so radiological data, it's based on other paraclinical data, if you use certain paraclinical lab data like they have. But I kind of wonder if your focus needs to be on those really high grades and say the utility of this tool is for not using resources on patients where based on your data, care would be completely futile. So waiting a week or 2 weeks is probably a waste of resources. And that might be a good selling point.
No, of course, thank you so much. I believe we are also considering a fast track approach for those patients who are actually in the low grade. They are doing this in Mayo already. I mean, for patients who are in the green side of the disease, they are discharging with a week, and the patients are coming back to do like serial transcranial Doppler to verify vasospasm and to be seen clinically. But yeah, definitely poor grade patients, they need to be better identified.
So we started that with Dave for low grade, and we're pretty optimistic. Christy Smith published that and present that. But I think going back to what Eric said about different countries, different realities. Brazil, for example, thrombectomy, some places you have 20 thrombectomies to do in a month. And you got this gazillion patients, so you're going to be selected who you're going to treat. So typically you favor the most viable patients. I think this will be very helpful in those types of scenarios that you have resources to treat 30 subretinal hemorrhage, you got 80, so you will pick. I think it'll be super helpful on those scenarios, not to throw a good poor grade into the bag with the really poor grade. So I think if we can help this reality, I think it'd be phenomenal. Thank you for giving countries like Brazil a better tool.
Thank you both.
I love the name, by the way.
Yeah.
That's why people stay this long, and not these 2 hours, opposite of and bad jokes about their eyes.
Okay, so I already sifted through, I didn't sift through the cards, I picked the card already. And today's winner is Liza Dumont. Are you here? Oh, you are here. Oh,
I don't work in the farm, but.
Wendy, you can take a drink. What's that? You want to take a picture? Yeah, I think. I think so. If you guys want to leave your house, please don't forget, we see a ton of them, so I assume everybody's done with their evals, but they are needed for the CMEs and for the CUs. Thank you so much. I don't know if you have anything else to say, I can change the state. Thank you so much.
Do you have a paper? Do you have a-
Okay, are we all done? What's going on? Is that it? Everyone going?